good morning to everyone present here today. Welcome you all to the Orthognathic and Orthodontic Surgical Symposium. This is organized by the Department of Orthodontics and the Oral and Maxillofacial Surgery, Faculty of Dental Sciences, Ramaiah University of Applied Sciences, in joint effort with the Indian Orthodontic Society and the Association of Oral and Maxillofacial Surgeons of India. We gather here today for this wonderful symposium. Science is organized knowledge, and wisdom is organized life. In these challenging times, it is prudent to use wisdom in our day to day quest to attain knowledge. As specialist dentists, our learning never ends. Hence, such online platforms offer a wonderful and safe method to upskill ourselves. And this symposium is one such effort. I would like to begin today's program by an invocation song where we ask the Almighty for blessings. And I invite Dr. Shweta, Reader, Oral Medicine and Radiology Department of the Faculty of Dental Sciences, Ramaiah University, to deliver the invocation song.
गजवदना बेडुवे गजवदना बेडुवे गौरी तनय गजवदना बेडुवे गौरी तनय त्रिजगवन्दितने सुजनर पोरेवने गजवदना बेटुवे गौरी तनय त्रिजगवन्दितने सुजनर पोरेवने गजवदना बेटुवे.
Thank you, Dr. Shweta, for that wonderful rendition. Once we have invoked the divine blessings, I invite the leader of our institute, our Dean, Dr. Srinivas Murthy sir, to kindly address today's gathering. Over to Dean sir.
Very good morning to one and all. Once again, I take this opportunity to welcome all the Indian Orthodontic Society members, speakers, and participants to this symposium by orthodontic and orthognathic people. And once again, I am very proud and privileged to be part of this event. And special thanks goes to Dr. Silju Matthew, who has been doing many online sessions for, of course, Indian Orthodontic Society and for all of us also. It is nice that both the Department of Orthodontic and Oral Surgery, they have come together and made this symposium and to bring the cream in this field at one platform. Today, I must say that technology has given solution to all situations in the present pandemic. Imagine, I was told that more than 1,000 people have registered for this conference. If we were to do at our place, imagine 1,000 people traveling to Ramaiah University and their travel time and the fuel and all. It is not there. Everyone is able to do at their place, and these online platform has connected all these 1,000 people with the great speakers at one stroke. Okay, this is one good thing. Once again, I welcome you all for this symposium. Have a great day and all the best. Thank you.
Thank you so much, sir, for your wonderful words and for all the support that you have offered the Indian Orthodontic Society in all its endeavors. Leadership is the ability to guide others without force into a direction that leaves them feeling empowered and accomplished. We are happy to have you as such leader, sir. Also, at the helm of the Indian Orthodontic Society is our wonderful president and the head of the department of the orthodontics section in Ramaiah University, Dr. Silju Matthew. I invite sir to say a few words to this gathering.
Good morning, ladies and gentlemen. Respected Dean, Dr. Srinivas Murthy sir, President AOMSI, Dr. Veerabahu, Honorary General Secretary, AOMSI, Dr. Preetham Shetty, Madam Secretary, Dr. Sridevi Padmanabhan, the Principal Office Bearers, the Executive Committee members, the distinguished speakers, moderators, and dear friends. A warm welcome to one and all to the Orthognathic and Orthodontic Surgery Symposium. Like Henry Ford said, and I quote, "Coming together is a beginning, keeping together is progress, and working together is success." I'm certain that coming together of two giant organizations like iOS and AOMSI for the first time in history on a virtual platform is a new beginning of progress and success. My gratitude to Dr. Veerabahu and Dr. Preetham Shetty for gladly accepting a proposal and facilitating and partnering in this program. Dean Dr. Srinivasamurthy has been a driving and guiding force behind all accomplishments of the institution. And we are grateful to him for encouraging us to think big and supporting us to achieve greater goals for our institution. I welcome and thank all the distinguished speakers for accepting our invitation and being a part of this one day of knowledge sharing carnival. I thank Madam Secretary, Dr. Sridevi, Dr. Puneet Batra for their valuable inputs. And finally, I thank Dr. Rangnath and his team of OMFS department and Team Ortho at FTS RUS and the postgraduate students for all their support extended. Wishing you all an exciting day of learning from the best in both specialities. Jai Avas, Jai Hind. Over to you, Dr. Sharanya.
Thank you, sir. And I would also like to thank you for your mammoth efforts in organizing today's events. Next on the agenda, I would like to invite the dynamic and charismatic Secretary of the Indian Orthodontic Society, Dr. Sridevi Padmanabhan, to please say a few words.
A very good morning to one and all. The Dean of Faculty of Dental Sciences, Ramaiah Institute of Applied Sciences, President of AOMSI, Dr. Veerabahu, Honorary Secretary of the AOMSI, Dr. Preetham, and to Dr. Silju Matthew, who's donning 3 roles today. One as the very dynamic President of the Indian Orthodontic Society, the organizing chairman of this wonderful symposium, and as the head of the Department of Orthodontics, Ramaiah Institute, Faculty of Dental Sciences. The head of the Department of Oral Surgery, Dr. Rangnath, and all the office bearers of both these societies who are here today, all the members, all the very, very distinguished speakers from both disciplines, and all the delegates who have joined us here today. A very good morning to you all. This last year or so has been extremely challenging for all of us. This is a terrible, terrible pandemic, but this has created a virtual space for us to all come together. And this relationship between orthodontics and oral surgery is not new, but it is wonderful that we are able to come together in this virtual space and share our thoughts. There are a lot of developments in both disciplines. Surgery first approaches, virtual planning, 3-dimensional imaging, of course, the advent of MARPE and SARPE. And it's very nice that both the teams or members from both teams learn all these things together in tandem and are on the same page. The lectures that are lined up by the organizing committee is fantastic. I see some very unique lectures, such as legal implications, which are going to be spoken about by Dr. L.B. Peters. Best wishes to the organizing committee, led by Dr. Silju Matthew and ably supported by Dr. Prashant, the organizing secretary. And I wish everybody here today wonderful day of deliberations. Thank you. It's wonderful to be part of this program.
Thank you so much, ma'am, for your kind and encouraging words. I now invite the President of the AOMSI, Dr. Veerabahu M. Sir, to kindly say a few words.
Am I audible?
Yes, sir, you are.
Good morning, one and all. At the outset, I would like to thank the Indian Orthodontic Society and the Orthodontia Department from the Faculty of Dental Sciences, Sri Ramaiah University, and the Oral Surgery Department for giving me this opportunity and also conducting this wonderful program. And this relationship between our two branches goes all the way back 25 years back, and when Dr. Kishore Nayak, Dr. Gunasilan, Dr. Varghese Mani sir, and Dr. N.R. Krishnasamy and all the people together started a FACE Foundation where we started interacting with each other and we started developing this branch. And I feel we have reached a significant advancement in this specialty. And to achieve great heights in the specialty, one need to have a good knowledge of dental background as well as the maxillofacial surgical skills. Thanks to this, both the skills which a maxillofacial surgeon achieve in his career, we are able to make a unique mark in this field. And we also know that in the last 5 years, there is a significant advancement happening in the imaging, softwares, planning, getting aids, drilling aids, and also waferless surgeries, custom splints are all developing thanks to all this advancement. So with this all thing and mutual cooperation between these two specialties, we are able to deliver the results to a maximum perfection. And this is the need of the hour to teach this cutting edge technology and these contemporary standards to our students. I feel these kind of programs where we both the specialties coming together and participating and teaching and educating our students is going to bring a real top-class experts in our both mutual specialties. So thank you, Dr. Siji Matthew. Thank you, Dr. Sridevi Batmanaban. Thank you, Dr. Preetham. And thank you, Dr. Ranganath and the Dean of the Ramaiah Dental Sciences and all the people who are involved in making this program and making it a great success. My best wishes to all of you. And there are my unique speakers, and I can see my good friend, Dr. Mustafa, and Dr. Pramod, and Dr. Divesh, and all other excellent speakers and good topics. I'm sure this is going to enlighten the young minds. And remember, to my colleagues in oral surgery, this is one specialty you have a definite edge over the all other specialty, because neither the dental specialties nor the competing other, I don't want to name plastic or pediatrics, nobody can come near you because you need to have surgical skill, you need to have dental background, need to have orthodontic background. And your orthodontics, your friend. All this, nowadays we are having orthosurgical meet in the colleges, universities, meets, and this has definitely brought a lot of knowledge to us. So with this mutual cooperation, together we will achieve the greater goals. I thank once again Dr. C.G. Matthew and Dr. Sridevi for this wonderful opportunity given to me. Wish you all the best, wish all the speakers best, wish the listeners best. Stay safe, wear mask, maintain social distance, beat the second wave of Corona. Hopefully next year we all of us meet in person. Jai Hind.
Thank you, sir, for your words of support and encouragement. And we look forward to many such collaborative efforts between both our specialties with your support. Thank you, sir. I now would like to invite the AOMSI Honorable General Secretary, Dr. Preetham N. Shetty, to say a few words.
Good morning, respected dignitaries, presidents of IOS, Madam Secretary, President AMSI, speakers, and participants. Good morning, all. I bring greetings from Association of Maxillofacial Surgeons of India to all of you. Let me first thank the Department of MS Ramaiah Oral Surgery and Ortho for bringing up such a great initiative. Like Dr. C.G. Matthew said, this is like first step of coming together. It's a great initiative. This will help us to plan a better treatment plan for the orthognathic surgery. It will help both the departments to come together. What I would request is, I think we should have, since we have a virtual platform now, it will be great if we can have a monthly meeting or something where both the association can come together and we can have a case discussion. This is for the executive committee of IOS and AMSI to decide. It will definitely bring us closer and help all of us to plan for our patients. Wish you all a very healthy year ahead. It's a very difficult year. Take care. Thank you. Jai Hind.
Thank you so much, sir, for your words and for taking the time to join our event and your support towards the same. Your ideas are definitely something we can work upon. Thank you, sir. I now invite the head of the Department of Oral and Maxillofacial Surgery, from Ramaiah University, Dr. Ranganath sir, to kindly say a few words.
At this outset, I would like to thank our respected Dean, Dr. B. Srinivasmurthy sir, for his support and encouragement in organizing this symposium. And my special thanks to all the members, honorable secretaries and presidents of the Association of Oral and Maxillofacial Surgeons of India, as well as Indian Orthodontic Society for supporting this symposium. I wholeheartedly acknowledge the distinguished speakers of today's symposium for accepting this invitation and being a part of this symposium and to share the knowledge and experience with all of us. Like Dr. Preetham was telling, I further request the dignitaries of both the associations to continue such interdisciplinary interactions on a common platform and on a regular basis, both at national as well as international forum in the future days. I'm sure today's symposium will benefit all the delegates. Without wasting much time, we shall move on with the presentations. We're already beyond schedule. I request Dr. Sharanya to initiate the program. Thank you one and all for your participation.
Thank you.
Further ado, I would like to begin today's scientific program. The first talk on our list of different topics is our talk on diagnosis and treatment planning, presented by Dr. Prashant GS. I would like to introduce Dr. Prashant sir. Dr. Prashant is a professor in the Department of Orthodontics, Faculty of Dental Sciences, Ramaiah University of Applied Sciences. He is also a member of the Royal College of Surgeons, Edinburgh. He is a guide for PhD scholars and has actively organized various CDE programs. He has multiple national and international publications to his credit. Dr. Prashant has also conducted several undergraduate and postgraduate hands-on workshop in various fields in orthodontics. I would like to now invite Dr. Prashant sir to speak about diagnosis and treatment planning involved in orthognathic cases. Over to Dr. Prashant.
A very good morning to all of you. Thank you, Dr. Sharanya, for wonderful words. At the outset, I would like to express my sincere gratitude to the Indian Orthodontic Society and its president, Dr. Silju Matthew, as well as the Association of Oral and Maxillofacial Surgeons of India, for giving me an opportunity to share my little knowledge on this diagnosis and treatment planning of orthognathic surgery in this platform. Thank you very much. Let's come to the introduction. Two of the distinct specialties in dentistry are oral and maxillofacial surgery and orthodontics. They have much in common that both are based on the underlying basic science, that is craniofacial anatomy and its growth and development. This should be the basis for diagnosis, where we identify where exactly the defect is and hence plan the treatment. With an increasing awareness and demand by the adult patients, orthodontics has taken a new outlook on orthognathic surgeries. Evidential research shows that growth itself is so varied and complex that each patient is an entity by himself. To find out the abnormal, one should know what is normal. Further, a knowledge of feasible treatment modalities is also essential. Ideal treatment planning is the recognition of such abnormalities in all the three planes of space. Most of us are very familiar with the jaw discrepancies and their malocclusion in sagittal direction. But many of us fail to recognize the discrepancies in vertical and transverse plane, which many times may manifest in sagittal direction. This is the aspect I would like to emphasize in this presentation. When the sagittal, vertical, and transverse growth components of both maxilla and mandible match that of each other, normal growth results. For a practical purpose, let's divide the head into these components, that is into cranium, maxillary skeletal, maxillary dental, mandibular dental, and mandibular skeletal. So the dotted line indicates the divergence and the glowed line indicates the profile of the patient. When the growth in sagittal, vertical, and transverse dimension happens in a proportional manner, normal growth results. Any deviations in the sagittal, vertical, and transverse dimensions can lead to facial discrepancies and imbalances. Sometimes natural compensation for these underlying discrepancies can also manifest in skeleton, dentition, or soft tissues. These compensations and decompensations we will discuss in the later part of the presentation. First, let's come to how exactly the class 2 malocclusion develops in the sagittal plane. So this is a scenario where there is skeletal class 2 malocclusion in sagittal direction because of prognathic maxilla and normal mandible. So this is characterized by straight divergence as well as the convex profile. The management is basically based on where exactly the problem is, and hence in this situation, it should be aimed at setting the maxilla back. The second scenario is the skeletal class 2 malocclusion in sagittal direction, characterized by normal maxilla, but with the retrographic mandible. So here, the mandibular jaw is retrographic compared to the maxillary jaw in the sagittal direction. This is characterized by convex profile, but with the posterior divergence. So the management is aimed at setting or advancing the mandibular in the forward direction. So here we have a situation, it's a combination of prognathic maxilla and retrographic mandible, which is characterized by the posterior divergence and the convex profile. So this is characterized, this here, the management should be aimed towards the Baija surgeries. So these are the various cephalometric parameters which will help us in arriving to a conclusion that where exactly the problem is, whether it is in the maxilla or in the mandible. So these parameters includes SNA, SNB, and ANB from the Steener's analysis, N perpendicular to point A and N perpendicular to Pogonian from the McNamara, and NA Pogonian as well as NA versus NB from the hard tissue Burstons. So at the same time, we should be able to differentiate skeletal with that of dental class 2, which is characterized by both normal maxilla and normal mandible, but with the protruded maxillary dentition. So here the management should be aimed towards retracting the upper anteriors. So these are the various cephalometric landmarks which will help us in differentiating the skeletal versus dental malocclusion. So these includes upper incisor to NA and lower incisor to NB angular, upper incisor to NA and lower incisor to NB linear, both from the Steener's analysis, as well as the upper incisor to point A distance and lower incisor to APO line from the McNamara analysis. So let's come to class 3 malocclusion, how exactly they develops in the sagittal plane. So again, in the first scenario, is characterized by normal maxilla, but with the prognathic mandible. So here it is characterized by concave profile and anterior divergence. So here the management is aimed towards setting the mandible back. So in a situation where there is a deficient maxilla, but with the normal mandible, which is characterized by straight divergence and concave profile, the management should be aimed towards advancing the maxilla forward. So here we can see a clear malar deficiency also. Coming to a combination where which is characterized by deficient maxilla and prognathic mandible, it shows anterior divergence and concave profile, and the management should be aimed towards the Baija surgeries. Again, we should be able to differentiate the skeletal with that of dental class 3, which is characterized by again normal maxilla, normal mandible, but with the retruded maxillary dentition. Management should be aimed towards advancing or protruding the maxillary dentition. Coming to the vertical plane. The discrepancies in the vertical dimension occurs in the form of long face or short face syndromes. Vertical maxillary excess brings about a clockwise rotation of the mandible and a class 2 situation. Vertical maxillary deficiency brings about an anti-clockwise rotation of the mandible and a class 3 situation. Decreased condylar growth and decreased ramal height in the vertical direction swings the mandible backward, again leading to a class 2 situation. Let's take up these situations one by one. So when there is a normal descent of the maxilla, a harmonious proportion exists. When there is an excess vertical descent of the maxilla, leads to clockwise rotation of the mandible in a downward and backward direction, and it can result in a skeletal class 2 situation characterized by posterior divergence and a convex profile. So these long face syndromes are characterized clinically by dolichocephalic facial form, increased lower anterior facial height, excess visibility of the teeth and the alveolus, steep mandibular plane angle, narrow alar basis with or without mentalis strain, shallow mentolabial sulcus with recessive chin, both maxillary and mandibular dentoalveolar protrusion, upright and supraerupted incisors, excessive eruption of the posterior teeth, anterior open bite, high and narrow palate with or without posterior frostbite. So these are the parameters, the cephalometric parameters, which will help us in differentiating the discrepancies in the vertical direction from that of sagittal directions. These includes Gonian Gnathian to ascend from the Stenus, mandibular plane angle from McNamara, effective maxillary length and effective mandibular length from McNamara, lower anterior facial height again from McNamara, ANS to Nasian, MP to HP both from the hard tissue burstons. All these parameters shows an increased readings except effective maxillary length and effective mandibular length, which will definitely show that this is not the problem in the sagittal direction, but the problem in the vertical direction. The high angle patients are usually characterized cephalometrically by rotation of the palatal plane down posteriorly, large gonial angle, short ramus height, or decreased posterior facial height, increased maxillary and mandibular dentoalveolar height, and antigonial notch. Here, the management should aim towards doing a leaf out osteotomy and superior repositioning of the maxilla. Coming to deficient vertical descent of the maxilla. When there is deficient vertical descent of the maxilla, it swings the mandible in anti-clockwise direction, that is anterior and upward. So leading to a class 3 situation and a convex and anterior divergence. So this is the classical example where there is a deficient vertical descent of the maxilla, swinging the mandible in an anti-clockwise direction. Clinically, it will be characterized by brachycephalic facial form, decreased lower anterior facial height, insufficient visibility of the teeth and the alveolus, flat mandibular plane angle, acute natolabial angle, obtuse mentolabial sulcus and a prominent chin, excessive deep overbite and deep curve of spee, and lastly, the maxillary and mandibular dentoalveolar retrusion. So the management should aim towards the leaf out osteotomy and the down fracture of the maxilla. These low angle patients are cephalometrically characterized by decreased lower facial height, normal or long posterior facial height, reduced maxillary molar height is the strongest measure of vertical maxillary deficiency. Reduced incisor height may be associated with the deficient incisor visibility. Excessive posterior dentoalveolar development in the maxilla is considered to be associated with weaker musculature in high angle patients compared to a stronger musculature in the low angle patients. Ultimate clinical expression also depends on clockwise or anti-clockwise rotation of the maxilla, as well the compensatory vertical height of the ramus, that is anterior versus posterior facial height. So here we have a plethora of vertical skeletal discrepancies based on three factors. One is the excess or the deficient vertical descent of the maxilla. Second one, the inclination of the maxillary or palatal plane. And lastly, the vertical height compensation by the ramal. Coming to another factor, which is very important in orthognathic surgeries, that is leveling SPE in the arch. Incisors are the surgeon's guide for jaw repositioning. Also, their vertical proportion at the time of surgery will determine the post-surgical lower facial height. It is very important to identify which group of teeth are at fault, whether they are anteriors or supraerupted or the posteriors are infraerupted. Incisor visibility at speech or smile, lower anterior facial height, and leeway space can be the other clinical guides. So here we have a situation which is characterized by reduced lower facial height as well as reduced incisor visibility. So in this situation, it is better to level the lower arch SPE after the mandibular advancement to avoid heavy biting forces often associated with the deep bite. Leveling should be done by the eruption of the posterior teeth and not by the intrusion of the anterior teeth following surgery. Many a times, even we can avoid the complete bonding of the lower arch if there is a fair good alignment, and we can use an arch bar for the stabilization at the time of surgery. Contrary to the previous situation, here we have a situation where there is an increased lower anterior facial height. Here it is better to level the arch SPE before mandibular advancement. Leveling should be done by the intrusion of the anterior teeth. In case of excessive SPE, subapical osteotomy after segmental orthodontic leveling can also be considered, along with the main surgeries. Avoidance of intrusive mechanics in the posterior region and concurrent avoidance of extrusive mechanics in the anterior region pre-surgically will facilitate the maximum surgical correction. To avoid excessive intrusion or extrusion of the teeth and potential adverse relapse tendencies, a careful consideration should be given to the segmental surgical procedures in severely accentuated or reversed curve space. Steps within the arches is also an indication for segmental surgeries. Coming to how exactly the skeletal discrepancies occurs in the transverse direction. Some say when there is a skeletal discrepancy in the sagittal direction, there has to be a discrepancy in the transverse direction. The study models must be handheld articulated into anticipated post-surgical class 1 dental relation in order that transverse dimension problems may be accurately diagnosed. Many patients with skeletal class 2 and class 3 will not exhibit transverse problems in their pre-treatment centric relation due to natural compensation. So this compensation and decompensation, let's discuss in the later part of the presentation. So here we have class 1, class 2, and class 3 sagittal skeletal discrepancies. So let's see how exactly there will be transverse problems associated with class 1, class 2, class 3 sagittal skeletal discrepancies. So let's take up first the class 1 sagittal skeletal malocclusion. So here the broader posterior part of the maxilla articulates with the broader posterior part of the mandible, and the narrower anterior part of the maxilla articulates with the narrower anterior part of the mandible. So a normal transverse relation exists. When it comes to skeletal class 2 in sagittal direction where the maxilla is much ahead of the mandible, it is the broader part of the maxilla which will articulate with the narrower anterior part of the mandible. So it should be characterized by kind of Caesar bite. Contrary to this, in case of skeletal class 3, it is the narrower part of the maxilla which will be articulating with the broader part of the mandible. As the mandible will be much ahead of maxilla, hence resulting in a crossbites relationship. So here we have a typical situations wherein it is not compensated, and hence in a skeletal class 2, it should be characterized by kind of Caesar bite. So even in the absence of Caesar bite due to natural compensation, it should be our objective to re-establish Caesar bite just before surgery in skeletal class 2 malocclusions. Similarly, the class 3 malocclusions should be characterized by the cross bites. Again, in absence of these kind of cross bites, if at all it happens, it should be our objective to re-establish this cross bite just before surgery in skeletal class 3 malocclusions. When considering the need for orthognathic mechanics to correct the problems in transverse direction, it is essential to determine whether the problem is skeletal or dental in nature. Absolute skeletal transverse discrepancies requires planning for segmental osteotomy or surgically assisted rapid palatal expansion, that is a SARPE or MARPE. SARPE or MARPE to be considered in cases with a severe discrepancy and when the transverse defect of the maxilla is isolated skeletal anomaly. Anyhow, this will be dealt in detail by Dr. Sheetal in the later part of this webinar. So here we have a situation wherein we have normal transverse maxilla. So here the expansion, either expansion or constriction should be achieved by tipping type of tooth movements. So whenever we have an absolute narrow maxilla, the expansion should be achieved by bodily movement of the posterior teeth. So let's see what exactly is the compensation and decompensation in case of skeletal discrepancies. In cases of severe jaw imbalances, the teeth are inclined in such a way as to partially offset the discrepancies. This is nature's mechanism to compensate for skeletal imbalances, which we call it as natural compensation and otherwise termed as natural camouflage. Sagittally, it happens that upper dentition retroclines and the lower dentition proclines in skeletal class 2, and the reverse is true in case of class 3. Vertically, this compensation happens either by supra or infra eruption of the posterior teeth. Transversely, the upper and the lower posterior dentition flares either buccally or rolls lingually. Pre-surgical orthodontics is aimed at removing this natural compensation, which the term is known as decompensation, to move the teeth ideal to their respective jaw bases so as to provide a good dental occlusion following surgery. In class 2 orthognathic cases, the greatest anchorage requirement is in the mandibular arch and the least is in the maxillary arch. And conversely, in class 3, the greatest anchorage requirement is in the maxillary arch and least in the mandibular arch. So this is a typical compensation and decompensation. So here we have a skeletal class 3 malocclusion, which is compensated. So in the pre-surgical orthodontics, our aim should be to remove this compensation, hence the term decompensation. So it happens by the retroclination of the upper anteriors and proclination of the lower anteriors, which will result in re-establishing the reverse overjet as well as class 3 molar relationship. So let's check how this compensation and the decompensation happens in a skeletal class 2. So in certain skeletal class 2 malocclusions, which are superimposed with class 1 dental malocclusion, the pre-surgical orthodontics should be aimed towards the upper 5 extraction, lower 4 extraction, and the usage of class 3 elastics. This will ensure in getting the molars into class 2 situation and increasing the overjet just before the surgery. On the other hand, in where we have skeletal class 3 malocclusions superimposed over the dental class 1 malocclusion. So the extraction pattern will be upper 4 and lower 4, and the usage of class 2 elastics. So this will again ensure us in establishing the reverse overjet as well as the class 3 molar relationship. Let's check how the compensation and the decompensation takes place in the transverse dimension. In case of class 2, upper posteriors shows the lingual rolling and the lower posteriors shows the buccal flaring as a part of compensation, and thereby offsetting the Caesar bite into a normal bite in the transverse corrections. Whereas when it comes to a skeletal class 3, so this compensation happens by the buccal flaring of the upper posteriors and the lingual rolling of the lower posteriors. So thereby again offsetting the crossbite. In both the cases, the pre-surgical orthodontics should aim towards removing this natural compensation in the transverse direction and re-establishing Caesar bite in case of class 2 and crossbite in case of class 3 malocclusions. So here we have an analysis which will give us a fair good idea about the ideal transverse inclinations of the upper and the lower posteriors in a transverse direction. Coming to relapse tendencies, pre-surgical orthognathic mechanics builds in dental relapse potential in a direction opposite to that of potential skeletal relapse, thus increasing the chances of maintaining the optimal occlusal relationship post-operatively should any skeletal relapse happens. For example, here we have a compensated skeletal class 2. In pre-surgical orthodontics, the objective is to remove this natural compensation by proclining the upper anteriors, retroclining the lower anteriors, thereby increasing the overjet. Post-operatively, mandible shows a posterior movement as a part of skeletal relapse, and the lower anteriors shows a tendency of proclination as a part of dental relapse. So this reciprocal relapse tendencies still helps us in maintaining the proper occlusion. Hence, by performing a well-planned pre-surgical orthodontics, not only helps in achieving a greater surgical outcome, but also helps us in establishing stability of the proper occlusion post-operatively. So let's come to who is the right candidate for the orthognathic surgery. So this has to be determined by, there is something known as envelope of discrepancy. The envelope of discrepancy graphically illustrates the current concepts of how much changes can be produced by the various treatment modalities. So here we have the envelope of discrepancy, which is a graphical illustration of various treatment mechanics and the quantity or the magnitude of the tooth movements produced by each one of them. The innermost circle represents the changes produced by the orthodontics alone. The second zone of yellow color shows the changes which can be produced by orthodontics as well as orthopedic appliances. The third zone of light green represents the changes that can be produced with the help of skeletal anchorage, that is temporary anchorage devices. And the outermost zone represents the changes that can be produced by the combination of orthodontics and the surgery. Obviously, only by the combination of orthodontics and surgery, we will be able to achieve a greater amount of tooth movement. Rationale for surgery. First is the aesthetic consideration. Whenever a satisfactory alignment of teeth is possible only at the expense of worsening the overall facial aesthetics, are the ideal candidates to be considered for orthognathic surgery. For example, in class 2, retraction of upper anteriors or upper lip may lead to an increase in the nasolabial angle, and inclination of the upper lip becomes negative. Functional considerations. A unilateral posterior crossbite due to symmetric construction of the maxilla and lateral mandibular shift can be easily managed by the orthodontics alone, compared to A unilateral posterior crossbite due to mandibular asymmetry. More severe the skeletal problem, the more unlikely a non-surgical approach can achieve a stable result. Lastly, the stability considerations. Skeletal open bite or the long face syndromes have been historically difficult problems to achieve stable results by treating orthodontically alone. Hence, surgery should be considered in these kind of cases. Coming to indications for surgery as the first approach, it can be class 2 or class 3 malocclusions which do not show any signs of compensation, severe vertical growth patterns with an anterior open bite and thin alveolar troughs, severely periodontally compromised malocclusions, mild crowding, flat curve of spee, and minimal transverse discrepancies. Whereas the contraindications for surgery first approach includes the patients who needs definite decompensation pre-surgically, patients with a severe crowding, arch incoordinations, and patients with a severe vertical or transverse discrepancies. So just to give you a brief idea about the conventional procedure and the surgery first approach. So here we are going to do a proper decompensation as a part of pre-surgical orthodontics and then do a surgery. Whereas in surgery first approach, it is exactly the opposite of what we do in conventional or surgical procedures. So Dr. Akshay will deal in detail with this aspect in the later part of this webinar. To ensure that orthognathic surgery is successful, the team approach between the orthodontist and the surgeon with the close cooperation is very much essential. Thank you.
Thank you, sir. In the words of the great Napoleon, to be successful, one must plan his work and then work his plan. And without this basic diagnostic knowledge, a good surgical plan would be impossible. We would like to thank Dr. Prashant for this wonderful presentation. We'd like to offer him this certificate of appreciation for having delivered the keynote lecture at this surgical symposium. I would like to now open a Q&A session. To ask, so first question, presentation of the nasolabial angle will impact the maxilla. What if the nasolabial angle, I think, is obtuse? One of the questions was. Over to Prashant, sir.
Yes, regarding this question, basically the obtuse nasolabial angle happens when there is a skeletal class 2 malocclusions with retrographic mandible, wherein the surgical plan should be to advance the mandible. So there will not be any scope for setting the maxilla back in case where there is already an excessive or obtuse nasolabial angle. The surgical plan should be aimed towards advancement of the mandible, not the maxilla.
The next question is what decides the leveling of the curve of spee? This, I think, was already discussed during the presentation. In case of full cusp class 2 molar relationship with retroclined anteriors, how will the decompensation be in this case?
Very simple, by the proclination of the upper anteriors and re-establishing the increased overjet just before the surgery.
I think, and the final question is why is surgery first approach more favorable in periodontally compromised cases?
Because when we start orthodontic approach in a periodontally compromised patients, we are going to further worsen the periodontal situation because of the orthodontic tooth movements. So hence, in such cases, a surgery first approach is always a better approach if the situation is permissible.
Thank you so much, sir, for this wonderful presentation. I would like to now invite the next moderator, Dr. Roshan Sagadkar, for the next session.
Good morning, everyone. Am I audible? Yeah, the next speaker of the day is Dr. Ratna Padmanabhan. Let me introduce the madam. Dr. Ratna Padmanabhan completed bachelor's in dental surgery in 1991 from Annamalai University. She was awarded the Best Outgoing Student Award for the year 1991. She completed her master's in dental surgery, specialization in orthodontics in 1997 from Tamil Nadu Government Dental College and Hospital, Dr. MGR Medical University. Thereafter, she joined as a teaching faculty in Meenakshi Ammal Dental College and at present holds a designation as professor. She has conducted several hands-on workshops on orthognathic surgery, and she has to her credit number of publications both in national and international journals and around 30 scientific presentations in national forums. She is specialized in orthodontic planning and treating patients with craniofacial deformities. She is also associated with the International Cleft Lip and Palate Foundation as a consultant orthodontist. She has worked as a consultant in the Ministry of Health in Kuwait from 2002 to 2004. She has been practicing dentistry from 1991 till date at Ananthan Dental and Facial Surgery, Ananagar, Chennai. And her field of interest is orthognathic surgery. Over to you, madam.
A very good morning to all of you. Thanks a lot for giving me the opportunity to present in the platform. Thank you, Dr. Shilju, Dr. Sridevi, Dr. Veerabahu, and the other team for making this a wonderful platform for me to present this topic of pre-surgical orthodontics and split fabrication. One second. Okay. Be it orthodontics or orthognathic surgery, the final ultimate goal of an orthodontics or orthognathic surgeon should be the establishment of the Jackson's triad, that is structural balance, functional efficiency, and aesthetic harmony. Now, I would like to introduce a concept called neutral zone here. If you can see in the four X-rays, there are a lot of severe skeletal discrepancies, which actually gives you a different incisal relationship and molar relationship. And if you see the picture which shows the neutral zone, it established as the perfect incisal relationship with ideal overjet, overbite, and a well-balanced lip and tongue. Now, when we have severe skeletal discrepancies, what happens is this balance goes off, and depending on the muscle and functional problem or the functional habits of the patient, the teeth keep moving away from each other, creating a imbalance in all the neutral zone. Now, this is what happens when the compensation occurs, because the teeth moves in a different plane whenever there is a chewing or any other function which it's supposed to do. Now, as we know, we should know why the compensation actually occurs. Now, we all know that morphogenesis takes place because of genetic or environmental factors. Different skeletal structures grow in different planes in different timing. And because of this, there is always a state of composite which is getting re-established every time a growth or any change taking place in the functional unit. And these complement each other and try to cause the proper function at one point, hence establishing a compensation. So even if there is a compensation, the ideal orthodontic goal after an orthognathic surgery should be always a canine class 1, which has to be established, a functional posterior occlusion. It may be a class 2 or a class 3, but a buccal cusp to groove relation should be established, and good incisal stop given by Burstone 177 degrees or by Steiners 131 degrees is necessary. Now, decompensation can be discussed in 3 planes of space, that is transverse, vertical, and sagittal. I'm very happy that Prashant has already guided you in how the compensation has occurred. So I'm not going in detail with that. Now, there is a article which says how much incisor decompensation is achieved prior to orthognathic surgery by McNeil. In that, he says, we found that adequate decompensation was more likely to be achieved in mandible 80% than the maxilla. By meaning, he says the mandibular incisors are more decompensated or are answerable to decompensation than the maxillary teeth. Now, decompensation, if not done properly, has severe implications on long-term stability also. And if not done properly, there is a lot of limited incisal overjet, then the planning is not ultimately possible. Now, considering the transverse decompensation, I would like to show you two different patients who have the same problem, that is a mandibular deficiency in a very low angular mandibular plane. Now, if you consider the intraoral features, if you see, it is severely transversely compensated because the wider portion of the maxilla is actually occluding with the narrow portion of the mandible in a severe class 2. So because of the chewing, the maxillary upper posterior teeth tend to palatally incline themselves to meet the mandibular teeth. Now, if you see in the first 3 photographs, I have done a traditional approach, and in the second photograph, we have actually done an SFOA. Now, what happens in whenever you have a situation like this, it's always better to realign your model in a class 1 situation and see where all the compensations needs to be addressed. So in this case, we can actually evidently see the palatal inclination. So the addressing of the transverse discrepancy is a must. Otherwise, we will have buccal overhanging cusp when we actually advance the mandible. Now, in a traditional approach, we generally what we do is align the teeth to a maximum of alignment with 1925 2125 wire, which actually alleviates this minor transverse discrepancies and allow the mandible to be seated comfortably. But in SFOA, as you can see, as soon as you advance the mandible, there is a crossbite which is vividly visible, and this might be termed as a hidden crossbite or a relative crossbite. And this needs to be addressed as soon as possible because the mandible is actually treated by surgery. And so the RAP phenomena is very active in the mandible rather than the maxilla. So enabling the mandibular alignment and mandibular expansion to be done very rapidly than the maxilla. So we have to support this by actually putting a quad helix to enhance or hasten up the maxillary expansion as soon as possible so that it will catch up with the mandible. But fine, in the first case, the traditional approach, after the tripoding, we just need to settle the occlusion to a proper interdigitation. So the finish of the traditional and SFA is the same, but the transverse deviation of the compensation is done in a different part of surgery time. This is done in pre-surgical workup, but this is done post-surgical. But you will have to complement it with some aid in order to do the correction. Now, let's take a class 3, which has got a severe malar deficiency and also a maxillary deficiency with severe compensated incisors. As you can see, severe proclination in the upper arch. The intraoral finding shows a mild class 3 and in the molar, a class 1 perfect occlusion in the canine, and a proper incisal overjet overbite. But it shows severe proclination and retroclination of the lower incisors. Now, considering this, we actually put the maxillary and mandibular cast in a class 2 position so as to show how much the maxilla can be moved forward to correct the maxillary discrepancy. Now, if you see here, you see a severe overjet which has to be addressed by upper premolar extraction. Now, once you see the occlusal view, we can actually see a severe crossbite. This is because there is a severe transverse discrepancy which is hidden, and this is because the upper narrower portion of the maxilla is actually occluding with the wider portion of the mandible. So the palatal overhanging cusps which actually create this should be alleviated before the surgery. Otherwise, there will be a lot of rocking in the post-surgical occlusion. So hence, what we try to do is a maxillary constriction appliance, wherein there is a contraption which you can take it from support from the maxillary 7s, which are already expanded, and put a strut, solder it, and then give buttons from the palatal cusps areas so that you can comfortably intrude the posterior section. which can bring about this constriction. As you can see in the first picture, this shows the expanded arch after the class 1 correction or the maxillary advancement, and the second one shows the constriction established. Once this is done, then you can plan your sagittal workup by extracting or by SFOA. Here in this patient, we actually did a maxillary advancement using a Kufner's procedure, which actually gives you good malar prominence, and the teeth are also corrected by upper extraction. Now, coming to vertical discrepancies or vertical compensations, most often we encounter this problem when we have a severe mandibular deficiency and a very low angle plane of space, wherein your curve of P is very high and you need to increase the vertical facial height. So what generally we do is a concept called tripoding to correct the curve of P post-surgically. Now, if you, the tripoding is a concept wherein you establish a 3-point contact, that is in the incisors and the last erupted molar, most probably in the 7s, in order to alleviate the problem by actually increasing the vertical height by extruding the posteriors. This is mostly done in a true deep bite cases wherein there is a lot of infra-eruption of molars and posteriors. Now, in these kind of cases, we generally do not correct the curve of C pre-surgically. We actually exaggerate them depending on how much of vertical opening we need to establish post-surgically. So the curve of P is not corrected pre-surgically whenever you want anterior facial height to be increased. So keep it in mind that you actually create it so as to get a tripoding effect. Once this is done, you just have to extrude the posteriors by elastics in order to achieve a full cusp occlusion or an interdigitation. Now, if you see in this case, wherein you have a severe maxillary deficiency, it is very deceptive. Sometimes you think it might be bijaw problem because of the mandibular prominence in the occlusion. Now, if we take this first CEF, it actually shows a maxillary retrognathism and a mild prognathic mandible. But is it really true? We have to decipher whether it is really true or false. So hence we do a functional examination, ask the patient to actually try and close his mouth in most retruded position, and patient comfortably establishes an edge-to-edge bite. In this maneuver, we actually find out whether the mandible is at a problem or not. So if you feel the second CEF, you actually see a severe maxillary retrognathism, but the mandible is actually normal when the patient takes it to a edge-to-edge bite. So this establishes that the problem is purely in the maxilla and not in the mandible, but the mandible seems prognathic because of overclosure due to the severe vertical and sagittal deficiency of the maxilla. So how do you go detecting mandibular overclosure? We have to do it by actually seeing whether the patient will be able to comfortably bite in an edge-to-edge position. And in most of the adults, we see wear facets in the incisors, which actually guides it into the anterior postural anterior position. Now, the patient actually presented an intraoral finding with a class 3 malocclusion and a class 3 canine, which most probably when you align the cast in the position where you intended to keep it, it actually shows what all you need to do depending on the midline, whether you need to extract one side or the other side, or how do you proceed by decompensating. Now, this is after the surgery, which is actually done by maxillary advancement, and you can see the edge-to-edge position. Posterior can be extruded because there is a severe vertical maxillary deficiency in the maxilla, which can be extruded using implants in the lower arch or opposite arch. Now, this is the patient's view after the surgery. You can see a well-established incisor overjet overbite and good incisal exposure. And the vertical opening is also improved because the new incisal stop is established, which prevents the overclosure of the mandible. Now, taking another case wherein there is a severe maxillary deficiency and severe high angle mandible, we actually go into the cephalometric data and see where the problem is. But now, if you see the intraoral pictures, you see a severe open bite, which is not very evident in the extraoral findings. Now, if you see the intraoral, there is a severe maxillary deficiency with a mandibular prognathism, but the prognathism is not shown too much because of the downward rotating mandible. hence the open bite, and there is a severe skeletal open bite. So it needs to be addressed purely surgically. And if you can see, there are 2 incisors missing in the lower. So if you want to balance the occlusion in the upper, you need to extract 2 premolars to get a class 1. So here, it actually, literature says that when you have severe open bite, wherein the incisor is on a higher plane than the molars, it is always preferable to do an SFOA, because you can pitch up the mandible more efficiently than after alignment of the incisors. So hence, we actually planned for an SFOA in this patient, wherein we did an STO, showing the maxillary advancement by 6 mm and mandibular pitch up, creating an overjet, which later is corrected by the extraction of upper premolars, and also a genioplasty, which is upward and forward to correct the vertical height of the mandible. So going ahead with this, we planned the surgery, we planned the mock, and when we do a mock, what happens is we need to ideally intentionally create a posterior open bite in these kind of high angle cases. Now, why do we do that? Is because the posterior overhanging cusps, as you see, the palatal cusp is overhanging, and whenever you occlude that after the surgery, it tends to wedge it open, and there is a severe relapse immediately after surgery. So you always tend to keep a posterior open bite of 2 to 3 millimeter, which actually you can settle it later in the post-surgical phase. So here we actually went about by actually putting an implant also to prevent further extrusion of the molar, so that to hold the molar, and we also gave a utility arch, protracting utility arch to correct the overjet and to get an extrusion in the anteriors to get a good overbite and overjet. This is how the patient finished. You can see the perfect stability when you actually finish the case, if you actually create the posterior open bite intentionally during the mock surgery. Now, having seen the transverse and vertical, we go about with the sagittal. Now, sagittal is mainly not about the mechanics in orthodontics, but it's mainly on decision of the extraction planning. So here I've put 3 CEFs, which shows different kind of skeletal discrepancies. Both 2 of them are class 2 and 1 is a severe class 3. The first one is a class 2 with the severe compensated incisors, wherein the upper incisors are retroclined and the lower incisors are proclined. And the second one is the class 2 with retroclined lower incisors with a severe lip trap, causing proclination of the upper incisors. And third is the class 3 situation, wherein there is severe proclination of the upper and retroclination of the lower. Now, when we see the incisors, we actually plan the extraction most probably with the incisor angulation. Now, in the first situation, it's always better to go for an upper 5 and a lower 4 for correcting the axial inclination. The second one, we prefer we can do a upper 4 and lower 4 depending on the molar relationship. In the third situation, it is always mandatory to go for upper 4 for proclination of the upper incisors, and lower, as you can see, there is a severe cortical boundary limitation in the lower, which is severely retroclined. And if you extract even the 5, it may become worse and it will cause resorption. Hence, it's better to do non-extraction. And whenever you plan a bijaw surgery, it is always mandatory to create a reverse overjet of 10 to 12 mm. So in this case, if you extract uppers, we will gain another 4 mm. And if you procline the lowers, we will gain around 10 to 12 mm of reverse overjet, which will be helpful to correct the bijaw AP relationship. Now, the extraction protocol can you enumerate it as extract close to the problem to be addressed. Proclination of the anteriors can be considered. Crowding is a major factor to be considered for extraction. The curve of speed, the molar mesial movement, especially in orthognathic surgeries, we actually pay more attention to the molar mesial movements and molar corrections, because we need to establish a full cusp class 2 or a class 3, depending on the skeletal malocclusion. And of course, grossly decayed teeth needs extraction to preserve the healthy teeth. Now, the other consideration may be clinical FMA, because high angle, the more the high angle, you go for 5 extractions. The nasolabial angle change also dictates extractions. Degree of convexity, smile aesthetics, model analysis should be considered for crowding. Cephalometric parameters also can be considered for extraction planning. Now, somebody asked in the question answer session, like what to do when you have a nasolabial angle. Now, see the 3 pictures of nasolabial angle. where it doesn't match with your preconception that if the nasolabial angle is acute, the upper incisors are proclined. This is what we've been taught, age-old practice, and we've been going through with that concept. But if you see in the first patient, the nasolabial angle is acute, but actually the upper incisors are pretty upright. So this is because of the nose. So every time you assess a nasolabial angle, the nose and the lips have to be taken into consideration, and not only the not the overall nasolabial angle. So in this first patient, actually we would expect you to extract upper 5, though it is a nasolabial angle which is acute. Now, when you see the second patient, it depends on the molar relationship which you want to extract, because the nasolabial angle is acute, as well as there is a proclination to match your conception. Now, in the third patient, if you see the nasolabial angle is not so acute, it's actually obtuse, and also there is severe proclination. Now here, if you consider the nose angulation, it is upturned, and also she's got a short upper lip, which gives you the illusion. So now we have to always, the paradigm shift is towards the soft tissue examination. So considering the soft tissue, even though the teeth are proclined, we prefer to go for upper 5, because the nasolabial angle change should not reflect too much on the patient. Now, coming to skeletal malocclusion class 2, usually when we decompensate, we need to ideally get a full cusp class 2 in the molar and an overjet of minimum of 6 millimeter in order to address the skeletal discrepancy. Now, taking the first patient, we see a severe class 2, which is actually compounded by maxillary excess and a severe deficient mandible. Now, here the maxillary is orthognathic in AP position, but only in the vertical it is increased. So here we see in the occlusion, we see a class 1 molar relationship and a class 1 canine. And you also see crowding and curves being the low. So ideally, the shift towards the decompensation is by actually mesializing the upper molar to a class 2 and retroclining the lower incisors and decrowding, and bring about an overjet of 6 millimeter or so. So ideally, we do this, so upper 5 extraction and lower 4 extraction to alleviate what we actually thought would compensate the teeth. Now, this is after the correction. So after establishing a 6 millimeter of overjet and a class 2 correction in the pre-surgical workup, we actually go about by the impaction of maxilla and advancing mandible with a genioplasty to bring about this change. So this is the pre and post workup. You can see, appreciate the changes achieved. Now, coming to another situation where you have a severe maxillary excess, a class 2 problem because of prognathic maxilla. Actually, the mandible is orthognathic, but it looks retrognathic because of the downward backward growth of the mandible, and there is a severe mandibular chin height, which is reflected. A severe genial retrogenia is also present. Now, in this patient, since the patient is not incisively compensated, she has a very good proclination, which has to be addressed. Hence, we took this F. When we saw it, then there is a severe cortical boundary limitation in the upper. So what we actually study is, there is an article by Handelman which shows how to do cases when there is a severe cortical boundary limitation in these incisors. So what happens is, when you actually draw the F with the limitations and try to cut a portion of, trace another sheet wherein you can actually trace a incisor and try to move it within the cortical bone. But if it moves and then if it comes out of the labial cortex, that means it causes resorption. So in these kind of cases, instead of an orthodontic movement, you tend to go for a surgical retraction. So in this patient, we actually did a workup and we decided to go for a AMO and a leaf foot impaction, because we didn't want to create a resorption in the anteriors. So the pre-surgical workup was a segmental workup with an anterior and posterior sectionally done, and preserving the premolar for extraction on table. And also the lower 4 was extracted and decompensated to achieve the overjet responsible for the AP correction. Now, the patient also went through an impaction of 6 to 8 mm, and it literature says 6 to 8 mm impaction can cause 3-degree change in the auto-rotation. So the chin can come forward, and also the molar can be corrected finally with an advancement brought about by auto-rotation. And a chin genial advancement upward and forward can bring about reduction in the height of the mandibular height. So this is the final occlusion after impaction and auto-rotation and genioplasty. So since we plan for a surgical retraction of the anteriors, we can actually see that there is not much of resorption in the anterior segment. Now, the third situation I would like to discuss is patient wherein she came for an maxillary problem. Actually, she said she had a forwardly placed upper teeth. Looking at her, we suspected maxillary prognathism and a little bit of retrognathism. But seeing the CEF, it was ruled out, and she had a severe retrognathic mandible. And seeing the intraoral occlusion, she has an asymmetric mandibular molar relationship, wherein you see in the right side a class 2 and a left side which is totally an end-on, or you can say a 4 mm class 2. Now, in these kind of situation, our ultimate goal is to get a full cusp class 2 in the canine and molar area with an overjet of 6 mm. So because of asymmetric molar, we went for upper 4 and lower 4 extraction in the right side and upper 5 and lower 4 in the left side. Because we took advantage of the 5 for molar mesialization and a little bit of retroclination in the upper to correct the end-on relation to a full cusp class 2. And also in the right side, we actually wanted more retraction and midline correction, which was possible by 4 extraction. Now, once this was done, a tripoding was done, and the mandible was advanced, and the genium was also corrected by advancement genioplasty. You can see the aligned arches and a good occlusion after the surgery. Now, coming to skeletal class 3 malocclusion, we have a high angle situation here, a severe maxillary deficiency and a mandible prognathism, showing a vast difference in the molar relationship, showing a full cusp class 3 and a severe reverse overjet of 5 mm. Now, here we need to establish 10 to 12 mm of reverse overjet in order to go for a bijaw surgery. So what do? Is we go for upper 4 extraction for maxillary incisor correction, and lower we need to do a non-extraction. And if you see in the lower, we have actually used multi-looped peg archware for proclination and aligning, so that now most of the situation, when you have a fan-shaped incisor and severe retroclination, the night eye will not be able to help you in proclining and aligning of the teeth. So we have to resort to some other methods, and though that time we resorted to the multi-looped archware, which was open looped and constricted and pushed inside to deliver the proclination and the axial inclination change of the incisors. And this is how we finished the pre-surgical workup with a 10 to 12 mm of reverse overjet. Patient was corrected with maxillary advancement using the Kuskner's procedure for malar deficiency, and also a mandibular setback to establish a full cusp class 2 molar and a class 1 canine. Now, in this situation, we see a deficient maxilla, slightly looks like normal mandible, a severely crowded incisors in the upper. The lower is actually proclined, if you see in the CEF, and we need to address the proclination in the upper as well as the proclination in the lower. And considering the mandible being orthognathic, we decided to go for only maxillary correction or a single jaw procedure. So hence our goal was to establish a class 3 in the molar and a reverse overjet of 6 mm or 4 mm in order to advance the maxilla by 6 mm. So we went ahead with upper 4 extraction and lower 5. Lower 5 because we need to mesialize the molar into a full cusp class 3, and also mild proclination correction in the mandibular anteriors, and maxillary 4 for retraction of the teeth as well as to alleviate the crowding. Now, after establishing 4 mm of reverse overjet, a 6 mm of correction, we advanced the maxilla by 6 mm in order to establish the ideal overjet and overbite. Now, in this situation, we see a different kind of circumstance wherein we have a deficient maxilla and a mandible which is prognathic. Now, here we have a situation wherein the maxillary teeth are severely proclined. Ideally, now we should have considered what I did in the previous stages because of the cortical limitation in the maxilla. And this is pretty old case, so we never thought about it. And we just went ahead with upper 4 and lower 4 extraction because we already had a full-fledged cusp class 3 on the molar. So we didn't want any molar mesialization. So hence we went ahead with upper 4 and lower 4 extraction to correct the proclination. Luckily for us, we never encountered much of a resorption, but you can actually see the upper incisors a little ahead of the cortical bone. And we established the class 3 here. And since he also had a mandibular deviation, so it was mandatory to do a single arch procedure because the maxillary soft tissue was pretty thick, taking care of the maxillary problem. So we went ahead with a single jaw procedure, a mandibular setback with the rotational BSSO and a chin upward and forward to reduce the height of the chin. This gave a complete class 1 Malocclusion situation after the surgery. Now, this was an interesting case. What we planned and what we ended up was totally different. I would like to share this to you. Here we have a patient where we had a severe maxillary retrognathism and a mandibular prognathic situation. She was compounded by a severe proclined upper incisor and also severe crowding in the maxilla. Now, ideally, we wanted to do a bijaw procedure, so we extracted only the upper 4 to alleviate the crowding and proclination, and mandible, we did a non-extraction and proclined the lower incisors. Now, if you see, after pre-surgical workup, she actually shows a severe class 3 in pre-surgical phase extraoral. And in the SEF, if you see, we never got ahead to create an overjet or a reverse overjet of 10 to 12 mm. So ideally, and the molar relationship, if you actually take a note, it was still a class 1 and the premolar is still class 1. Now, the most of the space was taken up by the decrowding and not by the proclination. So sometimes it is never possible to correct both proclination and crowding when you have such a situation. So since we had a limited amount of overjet, as the article always says, literature says that teeth are the template on which you can actually guide the skeletal components. So here we never had a chance to do a bijaw surgery. So we went ahead with doing a soft tissue workup. And when we saw that, if you see in the first comparison, when we advanced the maxilla, it actually gave a bimaxillary situation because the upper teeth are proclined. And when the maxillary is advanced, the nasolabial became more acute and it worsened the profile. Then the second soft tissue or the STO was BSSO. Now, because of the BSSO setback, what happens is the lip started everting because we proclined the lower incisors, and the chin being deficient, it created a class 2-ish situation with an everted lip, which again was not very pleasing to the patient. Hence, we came across by deciding to do a subapical osteotomy. And this was like considered like a camouflage surgical procedure. By doing a subapical, what we actually got is, because since the lower incisor was corrected and retroclined, the lip position was better. And because of the subapical, automatically the chin button is enhanced. Hence the soft tissue chin actually looked better. And we also augmented the malar deficiency using a graft. So sometimes we need to take a different stand, even though we decided to do something ahead when we planned the orthognathic surgery. But always consider a pre-surgical workup before we actually attempt the surgery procedure. Now, non-extraction is pretty simple. So whenever you have a class 3, it's mandatory to have a class 3 in the molar and the incisors. So if you have that, and if you have the space to actually procline or retrocline the teeth, And if you have spacing, you do not need to extract unless it is warranted by a soft tissue. So I'm not going detailed into your pre-surgical class, non-extraction treatment. Now, having seen the transverse vertical and sagittal decompensation, I would come back to the old slide wherein the compensated occlusion shows so much of discrepancy and no neutral zone. Now, once we correct it by surgery and orthodontics, we are able to ideally put it onto a neutral zone as much as possible to prevent further relapse or any, and also to give long-term stability to the patient. Now, having completed one part of my presentation, I would now go ahead with the model surgery for precision orthognathic surgery. Now, any model surgery, first step is to do a phase 4 transfer. This phase 4 transfer actually is mandatory in order to relate the maxilla to the cranial base, in turn to the mandible to the maxilla. Now, if you see, excuse me, in this picture, you see an articulator and you see a self. Now, if you actually draw a cranial base reference line, this FH plane actually matches with the maxillary, articulator's upper member, and the occlusal plane is actually perfectly recreated in the articulator. Now, this is done only with the phase 4 transfer, and this phase 4 transfer enables us to record the pitch, roll, yaw, all the relationship of the maxilla to the cranial base efficiently. Now, once this is done, we need to scribe the lines using an Erickson platform. Now, let's see what are the lines we need to mark during mock surgeries. So this is an articulator which shows all the articulated models. And now we first draw the horizontal line, which is in purple, which is called the model Frankfurt line. This model Frankfurt line is drawn parallel to the upper member of the articulator. Now, the other line, which is in the purple, is otherwise the impaction line. If you want to consider an impaction, you actually measure and make a parallel line so that it will indicate impactions. And later, you have to do the sagittal lines, which are the existing molar relationship. And also, if you see on the red, there is another red line which doesn't come through and through. That is the advancement line. So we actually measure it with the divider and see how much of advancement is needed. Once we do the STO, we will be able to record the advancement and then transfer it into the articulator. Now, posteriorly, you need to draw the yaw line, which is actually gives you an insight whether you've actually created a yaw shift in your occlusion. If you need a yaw shift, then actually the lines shift. Otherwise, it should not change after you do the mock surgery. And on the frontal preview, you actually see the midlines, which are taken into consideration after your facial midline is connected, and mark the midline consistent with your facial midline, and you need to understand which you need to shift and which you do not need to shift. Now, once we before we articulate, I would like to insist that once you get the models, you actually pour a base with a green stone, not a big base, a small base, wherein it makes it a flat surface of the model so that there is not irregular surface on the base of the model. And actually, you actually apply a Vaseline in the central portion of the model. And then after that, you articulate. Now, I will tell you the advantage in the following slides. Now, once the articulation is completed, the lines are drawn, the midlines are drawn, the advancement lines are drawn. What we do is, the yaw lines are drawn. What we do is just tap on the model, the upper member in the base, and so that it just opens up as if it is neatly separated with a flat surface to each other. It doesn't have any indentations. Now, this is possible only if you put the Vaseline, and now you can advance the existing maxillary molar line to the advancement line, creating the 6 mm advancement, if you see on both sides. This anterior portion, actually, if you measure the stone in the anterior portion, it will actually be 6 mm, whichever it actually shows that you're actually advanced it by 6 mm. Once this is done, you'll have to fuse it either by using a glue gun, a silicone rubber material, or you can use it with sticky wax. If you're using a sticky wax, you'll have to ideally heat the spoon side of the wax knife nicely, and then just put the sticky wax onto the spoon surface of the wax knife and allow the wax to pour into the crevices and fuse the cast to the upper member. Once this is done, you reattach the upper cast to the articulator and just make sure the yaw line matches if you're not correcting the yaw relationship. The midlines have to be rechecked, the advancement line have to be rechecked, and then the intermediate splint has to be fabricated. When I do the intermediate splint, I always use a Vaseline. Some people use cold mold seal. I use Vaseline because the Vaseline does not spoil the occlusal cusp relationship, because in sometimes when you use cold mold seal, when we remove the splint, the undercuts actually hold so tight that the cusps break and we're not able to do the second part of the mock in the same cast. So it was advised, or I suggest, that you use a copious amount of Vaseline on the upper and lower occlusal surfaces. Once you apply that, then the toe stage of the acrylic is placed on the lower cast and the upper member is closed onto the lower cast. The splint is now adapted and allowed to set. Now, before you allow it to set, you actually hold the acrylic onto the upper member and start closing and opening your articulator, which actually gives you the guidance to the archeal closure of the mandible. Now, this enables the surgeon to place it more easily on the table. Once the intermediary splint is constructed, we now down fracture the mandible. Once the mandible is down fractured, here we have actually used the pitch up of the mandible and the posterior open bite is established, fuse it, and then construct your final splint. Now, once the first and the second splint are ready, it is mandatory to number the splints accordingly. 1 and 2, the one indicating intermediary splint and the second being the final splint. And it's also important to mark the midline and also an arrow which indicates the maxillary side, and then so that the surgeon does not fumble with it. Now, most of the surgeons have different way of putting it on IMF. Some people use power chains, some people use ligature wires, some people use intermaxillary fixation screws. So it depends on the surgeons. So you need to ideally prepare the model or the cast or the occlusion depending on the surgeons who's working with you. Now, the purpose of model surgery is to verify whether planned movements are possible, to define the compensated position of the teeth. That means you can actually measure them, to relate cast in positions where occlusal wafer splints for surgery will be made. Now, the checklist before we proceed with model surgeries are second molar interferences. Now, whenever you have premature interferences, when you actually ideally align the cast in your hand, you will see some rocking. Now, when you see those rocking, don't correct it in the models. Please correct it in the patient before you proceed to the next step. And once you correct it in the patient, make another impression after the correction of the prematurities and then use them for the splint fabrication. If not, the splint will not sit when the surgeon is doing the procedure. And you'll have to check for intercanine width compatibility, your cross bites, your overjet, space for interdental osteotomy cuts, if in case of subapical or AMO procedures. Now, the model surgery, what it does is to enable dimensional movements directly to the patient. So it actually translates it, and also it obtains a quantitative data for surgical movement. So you actually give a 6 millimeter or a 7 millimeter advancement. All that's possible only by mock surgery. And model surgeries are performed to provide accurate dental templates to enhance accuracy of surgery, to obtain distortion-free occlusion, and also patient should have been stabilized arch wire of 21-25 or 1925 in a no to slot. And in case of SFOA, you can actually go for a stainless steel wire, which is pre-bent, or no wire with only just consolidation. Now, the accuracy of the splint depends on the splint material should be removed only after the material is completely set, and arch closure of the articulator, as I said, should be done by opening and closing of the upper member in order to relieve undercuts and also to create the guidance of the mandibular archeal fashion, and always store the splint in water to prevent evaporation of monomer leading to shrinkage, and splint trial should be done separately on individual arches in patient before the surgery, and check for rocking of the splints when you try the splints. Now, splints can be of different material. We use acrylic splints, polyvinyl siloxane splints. Now, when we did polyvinyl siloxane splints earlier, it actually, when we actually bring about the IMF fixation, it actually was flexible. So after the removal of the splint, the occlusion was totally different than the splint, the occlusion which we actually gave. So because of the not rigid fixation, not rigid splint material, it's always advisable to go for acrylic splint, which is more rigid and more reliable. Now, when you have a single procedure, you do have a single splint. The other one can be a bi-jaw procedure where you have an intermediate and a final splint. Now, advantage of a surgical splint, maybe the teeth can be placed in any directed direction and no judgment done during surgery. So whatever planned is actually executed on table, so there is no surprise after the patient comes back after the surgery. And it's easy to access midlines and also will avoid posterior asymmetries because of improper fixation. Now, I would like to just finish by showing the comparison between making a manual splint and digital or a CAD/CAM splint. I have taken a patient where we did a very similar movement of bi-jaw rotation because of OSA. Now, this patient had a posterior facial height which was less than the anterior facial height, and there was severe airway problem. So we had to do a maxillary mandibular rotation. Now, in the first patient, we did a STO using a FACAT software by 2D planning, and the second patient was totally digitized. And if you see the movement we predicted for the first patient was 2 mm back, 2 mm up, and 4 mm downward grafting of the mandible. And in the CAD/CAM also, we had the similar movements which had to be done for the maxilla. Now, in case of manual splinting, in these cases, during bi-jaw rotation, we actually have a mandibular procedure which is done before the maxillary procedure. So mandible has to be stabilized in the new position, and then the maxilla. So we actually have two casts which are face bow transferred. And so namely, we have a maxillary cast 1 and a maxillary cast. Both are class 2, which are actually done separately and transferred ideally. Now, once you take the maxillary cast 1 and you actually perform the movements, that is 2 mm back, 2 mm up, and posterior 4 mm down. This was what it looked like at the end of intermediary maxillary repositioning. And this was how it looked like in CAD/CAM also. So it is very similar movements. Now, after that, you actually dismember the mandible and get it into occlusion. So here we have a maxillary mandibular pitch up in the anterior and downward in the posterior. So ideally, if you see the CAD/CAM also, it is brought into occlusion and we get a very similar result. Once we get this, we actually make the splint in this position, but this is the final splint and not the intermediary splint. So in order to make the intermediary splint, we'll have to actually remove the maxillary cast 1 and shift the maxillary cast 2, which is the ideal relationship of the maxilla. And then in the newer position of the mandible, we keep it. Now you actually see a posterior open bite in the occlusion. And similarly in the CAD/CAM also, you see the same movements. So this was actually the intermediary splint, which actually helps to position the mandible. So this is how a difference in mandible in a manual splinting and digital splinting is done. But either way, the occlusion is perfect. This is what we established. So whoever plans it has to be meticulous in planning, whether it is digital or conventional. It is the same, but the result should also be the same. So this is how the patient looked after the surgery, what we did manual planning, and this is the CAD/CAM splint. This is the surgery pictures or the cephalometric after the surgeries. Now, if you see in the second sub, you actually see so much of a airway opening. Now, we did a study in the Department of Oral Surgery, and in that we actually compared the CAD/CAM splint with the normal manual splints, and we checked for all these parameters, and it was obviously found that CAD/CAM splint were much superior to conventional splint, and this is how it was tried and it was graded. This was positioning it in the same patient using a CAD/CAM and a manual splint. Now, I thank all the people who have helped me and keep me going, my postgraduates and my surgery staff who actually are in hand with my planning and execution. Thank you.
Yeah, thank you, ma'am, for this wonderful presentation. There are a few questions.
Yeah.
What is tripoding effect and how it will work?
Can I go back to the slide? Okay, tripoding, it is mostly done on a mandible, which is retrognathic, first of all, and which is a severe low angle, and which needs a increase in anterior facial height. So when we see such a patient, as in this kind of patient, where you actually do a VTO, and the moment you see a VTO, the mandible actually comes forward, the patient looks good. But intraorally, if you check, you will actually see edge-to-edge incisors or 1 millimeter of incisor overjet, but a posterior open bed totally, and only your last molar touching the occlusion sometimes. So if we actually do this, most often this actually is as a result of a true deep bite, wherein there is a lot of infra-eruption of molars and sometimes extrusion of anteriors. So when you have such case, we are actually supposed to exaggerate or keep the curves P similarly to what it was existing before and not correct the curves P pre-surgically. Because once we correct the curves P, what happens is the curves P is corrected by actually proclining the lower teeth and also by supra-erupting, which is not possible because of the musculature. So what happens is you end up proclining the lower anteriors and also closing on the overjet, which you already have. Now, if you see in the first picture, you have a overjet of 6 millimeter. Now, if you actually procline the lowers, you will be ending up in only 3 millimeter of overjet, but then you cannot advance the mandible. Hence, you keep the curves P intact and allow it to, after you position your mandible forward, it is in edge to edge and it is in contact with your 7. And this 7 establishes a 3-point contact. So bilaterally 3 to 7 and 1 incisor edge should contact minimum in order to get a stable occlusion post-surgically, after which the infra-erupted molars can be extruded. So this is the importance of tripoding, and it is not done in all the cases, only when you need anterior facial ITPs.
Thank you. Madam, one more question is there. How do we address the tongue size in case of mandibular setback?
Okay, when you have a tongue size problem with a mandibular setback, usually check whether the maxilla is also in problem. Now, even if you have maxillary problem, even minimal to a minimal account, it is always better to do a bi-jaw procedure so that you can accommodate the tongue by advancing the maxilla and give it room for adapting. But if not possible, then we have to it is very difficult because it creates a lot of relapse if you don't address the tongue problem. And most probably in high angle cases, it is always do a bi-jaw procedure when you have a severe tongue issue with the mandible, along with the mandibular prosthesis.
Okay, ma'am. Madam, one more question. When you do a sagittal movement like a setback or advancement, how much of rotational movement is expected and how do we incorporate this in the splint?
The rotation is means that means you're meaning yaw correction.
Yeah, the
If you
rotation
mean-
when doing a splint. Yeah.
Yeah, if you
do a
actually
setback.
getting a yaw correction, suppose in a case of mandibular rotation, maybe you have a genial shift and you want to correct the mandibular rotation. So what you do is in the splint, you actually shift it. So you draw the midlines, right? So you have two midlines. One is your facial midline and one is the midline you need to recreate. So actually you in the splint, you have to actually move the mandibular arch, rotate it such that you create the rotation in the model and see whether your molars are in ideal position and the canines are in ideal position and the midline, anterior midline is corrected. Once you achieve that, you transfer it to the splint. Now, when you take it to the surgery table, once the splint is placed, the mandible is supposed to go for a rotational BSSO. Now, when you do a rotational BSSO, they generally align it differently or they remove some amount of bone on one side in order to accommodate the rotation. So it is up to the surgeon to actually rotate it, but the splint is fabricated the similar way. And when you check, you actually check for the yaw line, which is shifted in the mandible.
Okay, there are certain few questions also. I think you can type the answer in the Q&A section later, ma'am.
Okay,
thank you, ma'am, for the wonderful presentation. And I'll be presenting certificate on behalf of this company.
Thank you.
Thank you, ma'am.
Thank you, Dr. Ratna, for a wonderful presentation, a wonderful insight into
Thank you, sir.
pre-surgical preparation.
Thank you.
Good morning, everyone. I welcome all the delegates and the participants to the third lecture for the day by Dr. Mustafa Kader. It is indeed my pleasure to introduce Dr. Mustafa Kader. He is a practicing oral and maxillofacial surgeon. He is presently the director of Kanachur Institute of Craniofacial Anomalies at Mangalore. He is an eminent surgeon and a teacher with nearly 30 years of experience. His areas of expertise being orthognathic surgeries, clefts and craniofacial surgeries. His short CV reflects his humbleness and modesty for a person who has achieved greater glory in his profession. Today, sir will be presenting on bi-jaw surgeries. Sir, I invite you to start your presentation by sharing your slides, PPT. Thank you, sir.
Thank you for that introduction. Good morning, ladies and gentlemen. Before I start, I would like to say this, that together we can always prosper. In isolation, there is always a possibility of being perished. So with that starting note, it reminds me of another statement recently made by our own Prime Minister, Mr. Modi ji, that A square plus B square into bracket square is equal to A square plus B square plus 2AB bracket square. Okay, so you get that added effect. I'm not so good at simplifying things like our Prime Minister, but this is my attempt to do so. Okay, I vividly remember just when I finished my post-graduation, when Dr. Krishnan Nayak gave me this opportunity to do a mandibular setback for a case of mandibular prognathism. And since then, it was the initial stage of my career. I was overwhelmed by that response. And as you all know, most of you are orthodontists, that Krishnanak is like a banyan tree, which gives a lot of shade in the area that he is and the surrounding. And also I had opportunity to work with other orthodontists like Dr. Bishwas, who's an astute orthodontist, and Dr. Nilan Shetty. So by my association with these people, I did learn a lot of things in my career, particularly the things I should not do. And also, of course, my knowledge about orthodontics and the minor aspects, which adds great value to the surgical outcome. Of course, they don't work with me anymore because they have all grown too big into their shoes. Probably they don't want to work with a poor man surgeon like me. At present, I have these 4 young orthodontists who add great value to the work that we collectively do. As far as the future is concerned, I do not know, but think about the bridge when you have to cross it. So let me start with the terminology. There are other terminologies that you can use: bi-jaw surgery, double jaw surgery, twin jaw surgery, PIMAC surgery. Surgery, it is basically surgery involving the midface and the lower face. Indications: sagittal discrepancies. Okay, my predecessor has simplified a lot of things, has gone into the details, so I won't dwell into it much. When you talk about sagittal discrepancies, it's not just the quantum of movement. The quantum of movement may be very less, but you have to take into consideration aesthetics, airway, speech, particularly in cases with cleft maxillary hyperplasia. There are vertical discrepancies which necessitates bi-jaw surgery. That is class 3 with vertical maxillary deficiency, class 3 with VME, class 2 deformity plus VME, class 2 with vertical maxillary deficiency. You can also, there's also an indication when you have a class 1 deformity with bimaxillary protrusion or VMB. Then facial asymmetry requiring correction of roll, pitch, and yaw. I will come to what roll, pitch, and yaw and try to simplify it a little bit as much as I can. Cleft maxillary hypoplasia, though not all the cases, but there are certain definite indications which I would cover warranting a bi-jaw surgery. And then there are cases where occlusion will limit linear movements, therefore you will have to do a bi-jaw surgery. How much setback is feasible? Because there is always this fear from a patient's point of view and from an orthodontist's point of view, sir, do a single jaw surgery. Whether you do a single jaw surgery or a bi-jaw surgery, the risk factor remains the same. You know, surgical risk, anesthesia risk, they don't alter at any point of time. Okay, well, Jacobson et al. In 2011 said that a mean mandibular setback of 6.9 mm can be considered relatively stable. So he's talking about stability. But of course, there are other aesthetic considerations that you need to take into account, particularly the cervical length. Okay, if it is not taken into consideration and you do a single jaw surgery, you can invariably in the future land up with a double chin, which would be aesthetically very unpleasant. Okay, that is one aspect. There are airway considerations. Of course, it is not necessary that reduction of the pharyngeal airway can subsequently lead to OSA, but there is an elementary risk which should not be ignored. So there is no hard clinching evidence to suggest that all the patients undergoing a mandibular setback will eventually lead to airway problems. But those who can subsequently become obese definitely will run the risk of this problem. So this problem needs to be taken into consideration when you plan sagittal discrepancies. Of course, a point that I would add is whatever setback you would do, but when you do a clinoplasty, a larger gain was possible, especially in the hypopharynx region, which I will subsequently demonstrate. So mandible versus bi-jaw surgery, okay. Most of these articles favor the very concept of bi-jaw surgery. I won't go into the details of what each one is saying, but they are all favoring, okay. And this particular article points at the subsequent airway problem one can land up if you just do a single jaw surgery. Okay, here is an example where a mandibular setback of 6 to 7 mm was done. But look at the post-op. You see the soft tissue sag there, and the lip chin throat angle, which was acute, has become considerably obtuse, and this patient definitely runs a risk of a double chin in the future. Of course, if you look at this, anybody will say a fantastic result, but always look beyond the occlusion. See what has happened. The anterior facial height has increased. Probably a genioplasty would have helped in a case like this. Now, I would like to briefly touch upon asymmetry because there are a few asymmetry issues that I'm going to speak about. What is it? It is a skeletal excess or deficiency in the vertical, sagittal, and transverse planes involving one half of the face. And of course, there is a soft tissue component which could be a contributing factor. Now, for example, this case has a skeletal component as well as a soft tissue component. And this particular entity is called as Parry-Romberg syndrome. Okay. Here is another example. This is an hemifacial microsomia. Similar problems where there is a hard tissue component and a soft tissue component. But one should make a distinction between the two. Hemifacial microsomia is a congenital disorder. You will see the asymmetry by and large during birth. Whereas the progressive facial atrophy, otherwise called as Parry-Romberg syndrome, you will see after the first decade of life. So history will decide and distinguish between the two entities. Now coming to roll, pitch, and yaw, say this is how the picture of the aeroplane is compared to the face. Okay, roll is up and down deviation around the transverse axis. Pitch is up and down deviation around the AP axis, that's the sagittal axis. Yaw is a rotation or deviation around the vertical axis. So pitch, coming to the pitch discrepancies, here is an example. This is a case of a maxillary deficiency, mandibular excess. Look at the occlusal plane, look at the steep mandibular plane, and look at the open bite. So basically, this patient may need an altering of the pitch, which would establish aesthetics and function. Roll discrepancy, as I mentioned earlier, here is an example of, see, there is an occlusal cant. And when you have an occlusal cant, you should distinguish between what is an upward cant, what is a downward cant. Whenever there is deficiency of the ramus condyle unit, it will create an upward cant. The reason? Because the ramus and the condyle in that area will not grow to its fullest potential. So this is a case of condylar hyperplasia, which I showed. Here is a case of condylar hyperplasia, where the ramus has grown, has descended downwards because of the excess growth in the region of the condyle, which you can see in the OPG. And if you see the lateral septum, there is an overlap. In condylar hyperplasia or hyperplasia, in both the entities, the OPG findings will remain the same. There will be an overlap, but one should make a distinction between what is an upward cant, what is a downward cant. Upward cant, where there is deficiency of the ramus condyle unit. Downward cant, where there is an excess in the condylar region. Yaw discrepancy, here is an example. One second. Okay. Now, this case, there is a significant discrepancy, or the patient will require alteration of yaw, which you can see the lower face asymmetry, which you can consider it as yaw. Also, there is pitch and roll. All the three components are there, which needs to be altered in this particular case. So this is just for you to get oriented. The next speaker, my good old friend, Dr. Pram Subhash, will talk to you about it in detail. I hope he doesn't accuse me of hijacking his lecture. So these are various designs for a Lefort 1 osteotomy. So when you talk about bijaw, you need osteotomies for the midface. So you can have a standard Lefort 1 osteotomy and the various designs as depicted in the line diagram. The commonly used osteotomies of the mandible, you can do a BSSO, which is the workhorse of orthognathic surgery. You can do an inverted L. You can also do a modified inverted L if you want vertical increase of the entire ramus, which I will show you to you subsequently. Now coming to the idea of bijaw, here is this case which was orthodontically well prepared, but the patient wanted me to do only a single jaw. And I explained to the patient the overall result will not be very good. But despite that, I went ahead and did a mandibular setback and a genioplasty for this case. And that is the outcome. And she was not happy at all. Since I had pre-warned her, I was in a position to convince her that we should do a Lefort 1, which I subsequently did. Okay, this is the occlusion after BSSO and genioplasty. You can see there is a mild relapse there, because I did an 7 to 8 millimeter setback. And you can see the changes that have happened because of the Lefort 1 osteotomy, which I did subsequently. Because if you don't look at the face holistically and do what you call cherry picking, then you will do a job that is half-hearted and less than what is desired. So explain to the patient as much as possible, show them evidence vis-a-vis photographs and the work that you have done on other patients. By and large, you would be able to convince them. That is her profile picture after Lefort 1. And that is the settling of the occlusion. Okay, that is the X-rays from the beginning till the end. Here is another case. For example, conversely, you should not do a single jaw maxillary surgery. This patient had severe midface deficiency. I did a high Lefort 1 osteotomy. She had a very short cranial base. But if you look at her postoperatively, though it looks good, but she has a mild bimax profile. Ideally, I should have distributed it and done the Lefort 1, high Lefort 1 plus a BSSO and genioplasty. Look at that. But of course, from an occlusion standpoint, she looks all right. Now coming to pure sagittal discrepancies requiring linear correction. Okay, here is a patient with a mandibular excess, an anterior open bite. Okay, they had done pre-surgical orthodontics, corrected that open bite, and the orthodontic plan was to do only a single jaw surgery. But I put my foot down and said, no, because she has a mild maxillary deficiency. If she has to look good, then we will have to address both the jaws. And we did a Lefort 1, BSSO, and a genioplasty for this patient. So, of course, orthodontically very well prepared. It is just a difference in concept. But more often, if you are logically able to explain to the patient and the orthodontist, then things become rather easier. So that's her after decompensation and after the bijaw surgery. So that's the result we could achieve after much consultation. Obviously, it requires some amount of convincing. So these are things that you should imbibe, not to feel disheartened whenever you are faced with stiff opposition. So consistent focus will always lead to an enhancement in your skill and in your intuition. So here is another case which was orthodontically prepared very well. We did a Lefort 1, high Lefort 1, and a BSSO and a genioplasty. And the outcome, one would agree, has been reasonably good if you look at it carefully. Okay. Here is another case which was orthodontically very well prepared. Okay. the case details. There is upper crowding, lower crowding. All 4 premolars were extracted. Okay, decompensation done. So that's after pre-surgical orthodontics. Post-orthodontic decompensation, you can see the negative overjet that is created, and you can look at the palatal bar that I have used. That's what a smart orthodontist will do, so that it will prevent any mesial migration, or otherwise called as loss of anchorage. So detailing of the case is very important, be it surgical, be it from an orthodontic standpoint. So treatment plan was a high effort one, linear maxillary advancement by 5 mm, a settling BSSO, mandibular setback was done just for 2 mm. And a midline correction was achieved, that is yaw correction, an augmentation genioplasty, and we did a little bit of a nose job. So this treatment was planned with the help of a 3D articulator, and you can see this is the result of post 2 months after the surgery. Look at the result. Quite balanced, I would say. And in this case, since we did a high effort one, there were a little bit of issues in fixing the maxilla, especially in the piriform region. So therefore, we retained the splint in the maxilla. So here is this video of the splint retained. Okay. So as my previous speaker said, that CAD-CAM splint is very good, maybe, but not true all the time. This is not CAD-CAM, this is handmade, Atmanirbhar, okay, but it works very well. If you look at the video, you will believe what I am saying. Look at the splint. This is just to demonstrate how the stability can be maintained by retaining the splint. Okay, this is the post-op X-ray of the patient. And look at the hardware that we have used. And if you look at the upper fixation, you would realize the difficulty that we had, because we did a high effort one osteotomy for this case. And orthodontically, it is well settled. You can see the post-op occlusion. And here is another case with maxillary deficiency and mandibular excess. In this case, the arches were well coordinated, but look at the pre-operative occlusion. Sorry, pre-operative occlusion. There is severe crowding and an attempt at natural compensation. Despite the fact, since the arches were well coordinated, we went ahead and did a surgery first approach for this. And look at the results. This is the post-op. And we were able to complete this case within 7 months. So that is one of the advantages of doing SFO surgery first, which Dr. Akshay Shetty will elaborately cover. It is just to give an idea that you can do a bi-jaw surgery, especially if you're planning to do a surgery first approach, if the arches are well coordinated. And of course, if you have an orthodontist who would be very cooperative and carry out the necessary task on time to enhance the or to hasten the treatment time. One more thing I would like to add. One of the other reasons why I would advocate surgery first, because it is easier to convince the patient for post-operative orthodontics, because pre-operatively it takes an enormous amount of time. Once a certain changes is done, we can tell the patient, see, the changes that we have achieved right now, if you're not prompt with your orthodontics, then it can relapse. So we have been able to do a lot of these bi-jaw surgeries and finish it by reducing the treatment time considerably. Okay, that's the post-op X-ray of that patient. You can also have vertical discrepancies, which will need a bi-jaw surgery. So here is this patient with a Bimax profile, with PME, with increased incisal and gumminess. That's her lateral ceph. Look at the mandibular plane. So what we did for this patient is surgery first again here, followed by orthodontics. Litho 1, AMO, lower subapical plus stereoplasty. And we could finish this entire treatment much faster than what we would otherwise achieve. So there are definitive indications for a surgery first approach, including bi-jaw surgery. When you combine both the concepts together, you can hasten the treatment time. Okay, that's our profile view. And that is the occlusion settling. And that's the pre and post. You can see the mandibular plane is drastically changed and her face is reasonably balanced. Now coming to pitch discrepancy, which I mentioned earlier, this is the same patient, maxillary deficiency, mandibular excess with anterior open bite. Look at the lateral ceph and look at the occlusion. Okay, this is what we could achieve. What we did is we did a clockwise rotation of the maxillomandibular complex. Okay, that's her. Look at the profile view. The face is adequately balanced. There is adequate support, skeletal support for the upper jaw. And look at her chin. And the occlusion well settled. Okay. In the aftermath of the surgery, even in this case, we did surgery first. There was a mild anterior open bite, which we could settle with elastics. How does the elastics help? Because since we are using semi-rigid fixation, the elastics will permit certain kind of movement and it will settle the problem. If used the proper elastics with adequate force, also most important thing is constant monitoring. And of course, patient compliance is also an important factor. So this is a small video to demonstrate the concept of clockwise rotation. One second. That is about clockwise rotation. And here is another patient with a complaint of increased incisal show, gumminess, and retrogenia. Is it visible on the screen? Organizers?
Yes, sir. Yes.
Okay. 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 I'm sorry for a little bit of a technical hitch. Okay. Look at the pre-op images. There is a mild cant this patient has. This is the three-quarter view. Look at the interlabial distance when she smiles and at rest. Profile view. And look at the interlabial distance when she smiles. Now, in this case, the preoperative orthodontics, they had done a single premolar extraction or a unilateral extraction. Ideally, for a case like this, you should have done the lower premolar extraction, retracted, given an increased overjet, then the case would have been straightforward. You could have done a LFO1, osteotomy, parallel impaction, advancement of the mandible, plus genioplasty. But when we were confronted with a case like this, look at her occlusion, there is hardly any scope for linear movement. But her mandible has to come forward, maxilla has to go backwards. So that's her preoperative PSF and lateral CEF, and that is her OPG. So the treatment plan for this was a counterclockwise rotation. What I showed you all previously is a clockwise rotation, where we did. Now, what is, before we go into rotations, I think I should have mentioned this. What is basically rotation? Rotation is differential movement of the maxillomandibular complex in such a way that if you do a counterclockwise rotation, the maxilla will go backwards and the mandible will come forwards. If you do a clockwise rotation, the maxilla will come forwards and the mandible will go backwards. So previously what I showed is a clockwise rotation, and here we have an example of a counterclockwise rotation. So we did a differential maxillary leaf out 1 impaction, anteriorly around 7 millimeter, posteriorly left side 3.5, so right side 1 mm. So we also did a bit of a roll correction here, a settling BSSO plus a genioplasty. So this is the VSP for that patient pre-op. So differential leaf out 1 impaction, and then the intermediate splint, and then we got the mandible in its final position. You can see that. But if you look at the lower border, you see that gap is widened. So normally I would put 2 plates there, one at the external oblique superiorly, one at the inferior edge, just for additional stability. So this is the final splint in place, and then an advancement genioplasty for around 4 mm. So this we planned in a 3D articulator. This is the mounted cast. Okay, maxilla in its original position. Okay, counterclockwise rotation of the maxilla with the mandible in its original position. Now the mandible is in its final position. So just to demonstrate a little more about what we have done. So you can see the pre and post-operative changes that is happening in this particular video, including the smile, the amount of show, gingival show, as well as the incisal show. Okay. In the semi-profile view, you can see the changes which are quite evident to the naked eye. And I'm sure you could appreciate the changes that we were able to bring about, though it did not permit much linear movement, but just by doing a counterclockwise rotation, where the maxilla has gone backwards, upwards, and the mandible has come forward. Okay, and look at the occlusion. There is a little bit of correction of the midline as well. So we have done a yaw correction, roll correction, and pitch correction in this particular case. But we didn't go to correct the midline further because that midline discrepancy is more because of the big crown there on one of the incisors, which we will manage it prosthodontically in due course of time. So that's a pre and post-op lateral cephalogram. Look at the fixation. You see the two fixation for BSSO. Some of the surgeons may not agree, but we can have a debate on another day on that. Now, that I think settles the very idea of clockwise and counterclockwise rotation. The first case, clockwise rotation, was managed by my orthodontist, Dr. Ashit, and the other one by another orthodontist. But both the videos were done by the junior most orthodontist, Dr. Shreyasi Tiwari. The point I'm trying to make is a little bit of contribution by everyone makes a huge difference in the outcome. So coming to, clockwise rotation is comparatively stable when you compare it with counterclockwise rotation. Okay, but counterclockwise rotation has a positive effect on the airway. Okay, selective occlusal plane alteration, be it counterclockwise or clockwise, using rigid fixation or semi-rigid fixation are stable procedures. We need not worry much in terms of stability if the temporomandibular joint apparatus is healthy. So now coming to this case of asymmetry, okay, he came with us with a complaint of asymmetry. Look at this case. Look at the occlusal cant there. Now, how to decide whether it's a downward cant or an upward cant? When we studied the case, if you look at the, right side, right or left? Okay. If you look at the left side, the ramus condyle unit is underdeveloped. You can see a mild antigonial notch there, which is indicative that it is condylar hypoplasia. So it is obviously an upward cant. This case was done around 7 years ago. At that point of time, we didn't have the tool of what is called as a spec scan, okay, which will give you percentage-wise if there is any growth spot in the condyle. So which we use it now very often whenever we come across a case of condylar hyperplasia. So this case is a condylar hypoplasia. Okay, so what we did is we did a phase 4 transfer, studied the occlusal planes. Okay, there is a cant, an upward cant, and there is also a steep occlusal plane. There is pitch correction that requires, so which we managed by, we did the model surgery, level the mandible first. And in this case, the occlusal cant was proportional to the shortening of the ramus on the affected side. That was around 6 to 7 millimeter. So correcting of the cant invariably helped us to correct the ramus condyle discrepancy. It may not be true in all the cases. So the plan was a differential Lefort 1 osteotomy. Right side, a little bit we intruded, and left side extrusion. Okay, rights. Then we went and did the sagittal split osteotomy and an inverted L osteotomy and rotational genioplasty. So this is the modified inverted L, because with this you could bring the entire ramus inferiorly. Okay, that is the post-op outcome. Of course, we have ended up by increasing the show a little bit. Probably a BSP for this case would have been more beneficial in terms of planning. So that's him, pre and post. Okay, here again we did surgery first, and the settling of the occlusion is going on. And look at the pre-op, post-op OPG, and pre-op and post-op lateral ceph. That if you look at the lateral ceph, that the overlapping of the ramus and the body is you are not able to witness it in the post-op lateral ceph. And if you look at the PSF, a kind of a symmetry we have been able to establish. And look at the cant. So here is another case, okay, with maxillary hypoplasia, mandibular prognathism, asymmetry. Occlusal cant, here it was a downward cant. Okay, look at the kind of negative overjet the patient had. And look at this cephs and the OPG, and look at the quantum of movement that is required. And this is the CT of that patient. And we did a, what we call as a SPECT scan, a single positron. This scan will give us percentage-wise how much there is bone uptake to assess whether there is still activity in the condyle to do surgery or not to do. So if it's a growing patient at 16 years, then you can address the condyle. But if it is after 19, 20, you can address the condyle and do the orthognathic surgery simultaneously as described by Woolford, which has beneficial effect as far as the function and the aesthetics is concerned. So as far as the diagnosis is concerned, asymmetry with class 3 mandibular prognathism, maxillary hypoplasia, left side condylar hyperplasia with right side hemimandibular hyperplasia. Okay, so what we did is a transmyelohead intubation. Left side, we did a high condylectomy because it showed growth, enhanced tracer uptake there. That means it is still growing, so that has to be primarily addressed. Superior repositioning, and then we went on to do the bilateral cuts without separation, and a high Lefort 1 advancement of 7 millimeter. Superior repositioning on the right side, the point of rotation on the contralateral premolar molar region to correct the cant and level the occlusion. And we used the intermediate splint and fixed the mandible first year. And then we did a BSSO setback by 7 mm, of course, with repositioning the disc and fixing the BSSO with left condyle in its favorable position. So that is the where condylectomy was done on the high condylectomy on the left side, followed by a Lefort 1 and differential movement. The lateral pictures depicting the same after Lefort 1 differential movement. Then we did the mandible. You can see there is a bit of roll correction there on 1.2.57 mm and a setback of around 7.4 mm. So this is a lateral CT depicting what we have done. Okay, that's it. We didn't do the genioplasty, so that was phase 2. Of course, because of COVID, this matter is still pending. So whenever you address the condyle and do the orthognathic surgery, it is advisable to keep the correction of chin at a later date, because if some amount of growth is still remaining or still takes place, it will manifest in the chin region, and deferring the genioplasty to a later date makes sense. So of course, we have not done the chin. Once you do the chin, it will significantly improve the aesthetics. Okay. Yes, here again, we have done a surgery first approach. That is the post-operative, immediate post-operative occlusion. And look at the pre and post ceph. Most of the skeletal issues we have managed. It requires a bit of settling. And here is another case. I was talking about upward cant. Here is another case of an upward cant. Okay, this is a case where there is asymmetry. There is a roll problem. You can see the occlusal cant there. There is yaw. Look at the CT And look at the ramus on the right side. So the entire ramus condyle unit is underdeveloped. From the history and other things, we established or we arrived at a diagnosis of an hemifacial microsomia, that is class 2A. Though the ramus condyle unit is underdeveloped, but integrity is still maintained. So the skeletal problem list: normal maxilla, asymmetry of the mandible. The ramus length is totally reduced by 20 mm, whereas the canting is only 7 mm. Now, if you go to correct the ramus, taking the dentate component into account, you cannot do a 20 millimeter ramus lengthening. That will obviously result in a reverse cant. So you can lengthen the ramus by distraction or by osteotomy up to 7 millimeter. So what we did for this case is, I will come to it. There is also a soft tissue problem, bulk deficiency at the zygomatic buccal and mesenteric space, increased width at the commissure on the right side, canting by around 7 millimeters. So diagnosis is at Tessier number 7 with skeletal involvement, features synonymous with hemifacial microsomia, that is class 2. The integrity of the ramus condyle unit is well maintained. So treatment plan: horizontal ramus osteotomy, okay, plus BSSO on the left side, inferior repositioning of the entire ramus by 7 millimeter and intermediate splint, IMF, okay, then followed by fixation of the horizontal osteotomy with interpositional bone graft, BSSO fixation. Then we used an additional alloplastic material in order to augment that additional 12 millimeters. Okay, so with that, most of the asymmetry pertaining to the mandible we have been able to correct. Then we did a Lefort 1 down grafting, left side by 7 millimeter, final splint with interpositional bone graft, and augmenting the zygoma from the root to the eminence with an alloplastic material. Phase 2, we did an extended genioplasty with inferior repositioning on the left side and commissuroplasty. Phase 3 is still pending. We have to do a free graft, a fat graft, because this patient has a soft tissue component which needs to be addressed. Okay, that's the pre-op CT. Horizontal osteotomy, okay, increasing the ramus by around 7 millimeter, fixing it and fixing the BSSO on the other side. You have leveled the mandible, intermediate splint, okay, and the ramus is further augmented with an alloplastic material. Followed by Lefort 1 differential movement, left side down grafted by around 7 millimeter, fixed with plates and interpositional bone graft. Sorry for that. Organizers, could you tell me how much time do I have at my disposal?
Actually, we are beyond schedule, sir.
Okay, no, how much time do I have? As per the 1 hour 15 minutes I was given, how much did I cover?
Another 5 minutes, sir. 5
okay,
minutes.
Fine. So 1 minute. Okay.
Sir, can we take some questions meanwhile?
Yeah, I can answer some questions if there are any.
I'll check, sir, please. Yeah. So there's one question. Is there any prediction tracing method for cant correction during cant correction?
Prediction, when you do a VSP or when you do it on a 3D articulator, it is more or less predictable. But in terms of soft tissue, how the show will be exhibited in the future, that is something which you need to study and calculate. But you can.
But not on the radiographs, sir. It's on the articulated models only.
Models.
Yes,
and then calculating whether when you do this kind of movement, how much the show will increase. Because
correct.
You should not either increase the show or decrease the show.
Correct. One more question, sir.
So am I visible on the screen?
No, not right now, sir.
1 second.
Yeah.
Sorry. Okay. So that is the horizontal osteotomy. Let me quickly go through it. Okay. And you can see the intermediate splint, and then the alloplastic material is fixed, and the Lefort 1 and a downgrafting of the maxilla, plus a genioplasty subsequently, plus a commissuroplasty. And that is the outcome that we got in this particular patient. Let me quickly go through. So within another 10 minutes, I'll wind up. We have been able to correct the occlusal cant. Okay, I'll skip this case. I'll come directly to cleft maxillary hypoplasia, which needs, it is often necessary to do a concurrent setback. This was said by Figueroa and others ages ago, somewhere in 2000, considering stability as an important factor. But there are other reasons why you should consider, because when they have multiple problems like this, it requires a bijaw surgery, because there are other concomitant problems within the mandible, like a steep mandibular plane, an increased anterior facial height, increased mandibular divergence. Therefore, it is, from an aesthetic standpoint of view, it is better to do a bijaw. If not in all the cases, at least in a lot of cases. Other things that needs to be taken into consideration is the cranial base. If the cranial base is short, and if you advance the maxilla, say 9-10 mm, they will look like a horse. Aesthetics I already covered. Stability is another issue, because cleft maxillary hypoplasia has a high risk of relapse. And another important thing is speech, because if you advance more than 6 to 7 millimeter, there is a risk of creating a future velopharyngeal dysfunction. And then the concomitant mandible problems, which I just addressed. Here is a case. She has a mild occlusal cant. Show is not adequate. Maxilla doesn't have adequate projection. Look at the maxillary deficiency. One side is more hypoplastic than the other. The lip step, which is quite evident in most of the cases of cleft maxillary hypoplasia. And you can see the midline shift there. Hyperdivergent facial pattern. There is a bit of yaw, there is a bit of roll that needs to be altered. So clockwise rotation of the MMC, high Lefort 1, advancement by 4 millimeter, anteriorly by 3 millimeter, and downgrafting, plus left side 5 millimeter and right side 2 millimeter impaction for cant correction. Settling BSSO, augmentation genioplasty. So that's it. And here is the mounted cast. Maxilla in its original position. Now you see counterclockwise rotation of the maxilla. Mandible in its original position, and clockwise rotation of the mandible, and the final occlusion.
And subsequently, we did a lip revision and a rhinoplasty for her, and that's the outcome. So let me quickly go through just to give you a sense of what can be achieved when you do a bi-jaw surgery for a cleft maxillary hypoplasia, even though the fact that the occlusion is limiting any further movement. So this is another case where there is a good occlusion, you can see that, but though occlusally stable, still there is a glaring maxillary hypoplasia which is not addressed. And we did a clockwise rotation for this patient and look at the outcome. Okay, look at the X-ray, which is quite evident of what we have done and what we have achieved. So another way of addressing the maxilla is AMD. Okay, so here is an example. We did an AMD and a mandibular setback and genioplasty, and that is the outcome. So let me quickly go through, and this is how we settled with this patient. Here is another example. We did an AMD for this patient, but with the AMD, we also did a bit of a yaw correction, because this is still under study. So that's why we are not diverging the details. But if you look at the pre and post, you can see that a part of the yaw has been corrected with the AMD appliance. Okay, here is another, see, this is the pre and post OPG, and look at the profile changes. We have also been able to advance the maxilla to the desired amount. So innovation is always advisable, but if you are doing innovation with the motive trying to be different and not making the real difference to the patient concerned, is tantamount to arrogant and hubris. There is Dr. Mustafa who himself quoted this some time ago. Here is a case where we managed it by severe maxillary deficiency, mandibular excess. This patient was managed initially AMD to increase the perimeter of the arch, subsequently by a bi-jaw surgery. So a combination of AMD plus bi-jaw surgery goes a long way in establishing a good profile. And here is another girl who had come at the age of 10 with a severe maxillary hypoplasia and a large palatal fistula, which we managed with the tongue flap. Okay, subsequently arch expansion, alveolar bone grafting. We did a RAD on her, advanced the maxilla by around 25 millimeter. Subsequently, we did a BSSO on her and soft tissue augmentation with the help of a Abbey flap. Look at that, RAD, post BSSO and post Abbey. We have been able to normalize the profile to a large extent. And look at the kind of orthodontics. Look at the arch and the arch expansion. And the orthodontics was done none other than by the great Ashok Utreja. So together, we can achieve a lot. And this is a glaring example to what I'm saying. So that is pre, post RAD, BSSO, and post Abbey. Look at the profile. And she's pursuing a career in modeling. That's her. Okay, I would not go into that. Let me skip all these things and go directly to the last. Okay, a brief, without complication. See, surgery is all about managing complication. If you don't do that, you're as good as a butcher. So this is a case of a Lefort 1 plus BSSO. Okay, pre-op. We did a high LIFO 1 osteotomy and a BSSO, everything as planned. But within a week, the patient came back with a big ulcer there. The flaps opened up, bone denuded, suggestive of an avascular necrosis, a devastating complication for the surgeon. Of course, we managed this by doing wound debridement, subsequently subjecting the patient, I won't go into the depth of it, for HBO therapy, and we could successfully manage this patient. That's how he was progressively improved with HBO therapy. Okay, see that, the improvement. And even I went there, got a little bit of HBO therapy done along with the patient, and that's the post-op result that we could achieve. Here is another patient with BIMAX surgery. On the third post-operative day, he aspirated, and late in the night, we lost him. And that created a huge problem. It was reported in the newspaper. There were, the aftermath of it was pretty bad. There were allegations that was hurled at me and my team. Of course, there was an inquiry that is conducted, and it came as likely cause of death in this patient is ARDS due to aspiration, in spite of all corrective measures taken in terms of ventilation, fluids, antibiotics, inotropes, and other drug support. They could not revive. There is no case of negligence here. That's what the commission that inquired this case reported. So why I'm putting this case is there are a couple of lessons that I learned from this case. Number one, when the chips are down, even your best of friends will disown you. Okay, so be prepared for that. Number two, it requires great amount of courage. Sometimes complications will happen. You need to face them. And there were a lot of things that have happened along with this case, but we could face it boldly, because as long as you know that you have not done anything grossly wrong or detrimental to the patient intentionally, then there is no cause to worry. But of course, it is a difficult thing to psychologically face when you're encountered with a situation like this. So these are two cases. I'll quickly finish. A case of ankylosis, release done at 6 years. She comes back after 20 years with relapse, mouth opening nil. Look at that. One side of the ramus is short because the ramus has not grown because of the ankylosis. That's her. So this is her planning. Okay, the CT there. So upward maxillary cant of around 4 millimeter, ramal length deficient by around 16 millimeter. So you can do the rotation on that side around 4 millimeter, not more than that. Okay. So that's her occlusion, very bad teeth. Treatment plan sequencing. So what we did is we did a gap arthroplasty. Okay. And then we did a coronoidectomy on the other side. Then we did a unilateral sagittal split osteotomy on the normal side. Mandible was advanced by 3 millimeter. Okay. And with the intermediate splint, we fixed the TJR. And then maxilla was advanced by around 3 millimeter and down grafting on the left side where the TJR is placed by 4 millimeter. And that's the TJR in place. These are the models. Phase 2, we did, and because maxilla came forward, it required an AMO to be done and a genioplasty. So these are the intra-op pictures, gap arthroplasty. Okay, mouth opening, TJR in place. That's her now. This AMO was done just less than a month ago. That's her mouth opening. That is the semilateral view and the profile view. And we have retained the splint. If you see here, the ramus shortening is more because we got that extended TJR to compensate for the ramus shortening. Okay, you can see the leveling of the ramus unit. And if you look at the OPG, you can see that both the ramus are at the same level. And look at the OPG. There is no overlap there. Okay, and this is another case. 6 years, when she was 5 or 6, I did her bilateral ankylosis release. And she comes, she's 28 now with a face like this. Okay, I had done a BSSO advancement for her when she was 18, 19. But in ankylosis cases, because of the impact of the supraoid muscles, there's a high relapse rate. That's why distraction is one of the recommended methods. Okay, that is her mouth opening. Okay, there is a bigonial width is severely compromised, hyperdivergent facial pattern. Okay, I won't go into this. So phase 1, mandible right and left gap arthroplasty did in phase 1, and then maxilla we intruded it by 6 millimeter and downgrafted it by 2 millimeter, and we put the intermediate splint and did the fixation of the maxilla. Step 3, with the final splint and mandible advanced by around 3 millimeters. So basically what we did is a counterclockwise rotation of the entire maxillomandibular complex and fix the TJR. So that's the BSP, gap arthroplasty, maxilla, differential movement, intermediate splint. You can see the incisal inclination being changed. Therefore, we could maintain the incisal show without compromising it. The inferior downgrafting of 2 millimeter posteriorly. And we used a preformed, pre-designed plate for the maxilla, so that will establish that the maxilla is in the right position and the intermediate splint. So it's the double safety. So with that bar, we fix the maxilla with the intermediate splint. And then we fix the TJR with the maxilla mandible in a clockwise rotated position. Okay, I won't go into that. Okay, that's it. And subsequently, we did a genioplasty by 8 millimeter. So the linear movement in this case was just 3 millimeters. So when we did the counter clockwise rotation and TJR, in the second picture, if you see, the mandible has come for, or the POG has come forward by around 13 millimeter. That means 4 millimeter, around 3 to 4 millimeter linear. Rest of the 8 to 9 millimeter is because of the counterclockwise rotation. And then an additional 8 millimeter we got because of the advancement genioplasty. That's even this genioplasty was just done, it's not even a month. And see the mouth opening from 26, we have got around 38. Semilateral, post genio, you can see that. See the mandible, how it has changed, and the entire profile change, and the occlusion. So we have been able to advance it linearly by around 3 to 4 millimeter. That is the TJR in place. Okay. Now, before I end, I would like to acknowledge my teacher, Dr. Kishore Naik, who had been a guide, mentor, and at times a tormentor. And also my other colleagues who have in a great way contributed to whatever that I have presented today, and even otherwise in my entire surgical career. So my acknowledgement to them. A normal human being does not know what to do with his life, but he always has the desire to have another life which doesn't end. The cost of inaction is high, so don't go to your grave with your best work inside you. Therefore, I choose to die empty. Thank you very much, ladies and gentlemen.
Thank you, sir. Thank you for the wonderful presentation. Sir.
You're laughing.
That was good, sir. Very nice. Very nice. Thank you. Sir, we have some more questions, but however, because of lack of time, we'll mail those questions to you personally, sir. Probably we can attend to them at your leisure.
Yeah. We are simultaneously answering the questions.
Exactly. So thank you. Thank you so much, sir. Thank you. Sir, I'm very happy to hand over this certificate of appreciation to you.
My pleasure.
It has to be reflected.
Thank you.
1 second, sir. 1 second. We'll just yeah. So this is a certificate of appreciation. Thank you, sir. Thank you. So moving on, the next speaker for the day is Dr. Pramod Subhash. The moderator for the session is Dr. Kavita Prasad, who is a senior professor in the Department of Oral Maxillofacial Surgery at Faculty of Dental Sciences, Ramaiah University of Applied Sciences. I'll hand over the charge to Dr. Kavita, who is going to moderate this session. Thank you. Thank you.
A very good morning. It is my pleasure to introduce Dr. Pramod Subhash. He will be speaking on orthomorphic surgeries and management of asymmetries. Dr. Pramod is currently the Chief of Craniomaxillofacial Surgery at Amrita Institute of Medical Sciences, Kochi, Kerala. He has completed his BDS from AB Shetty Institute in Bangalore, Bangalore University, and MDS from the same institute, but affiliated to Rajiv Gandhi Health University. And he also has a residency in oral and maxillofacial surgery from the University of Maryland Medical Center, Baltimore, in the year 2008. He is a diplomat of the American Board of Oral and Maxillofacial Surgery and a diplomat of the National Academy of Examinations, New Delhi. And he is a fellow of the International Board of Certification for Specialists in Oral and Maxillofacial Surgery. He is a member of the American Society of TMJ Surgeons. He has a membership diploma in oral and maxillofacial surgery from the Royal College of Physicians and Surgeons, Glasgow. He is a member of the National Academy of Medical Sciences, New Delhi. His areas of special interest include pediatric craniofacial surgery, craniofacial deformity correction, minimally invasive craniomaxillofacial surgery, which includes endoscopic assisted craniofacial trauma and deformity management, and TMJ arthroscopy. Dr. Pramod, I invite you to now give your guest lecture. Thank you.
Thank you so much, Dr. Kavita. Am I audible?
Yes, yes.
So at the outset, I would like to thank Indian Orthodontic Society and our own Association of Oral and Maxillofacial Surgeons of India, and all the organizing team for putting up such a program. And it's very, very important that orthodontists and surgeons have combined programs like this where ideas are shared, because the viewpoints can be different from a surgeon's point and the orthodontist point, and the best outcome to the patient occurs if we work together. And these kind of programs help us to understand each other better. I would also at this point acknowledge Professor Dr. Maria John Kuriakos, who is the orthodontist who works along with me, and many other orthodontists whom I have not mentioned here, but there are, and we work together. Move to the next slide. So I would also like to thank Dr. Mustafa Khader for having gone through all the principles of asymmetry, which is my topic today. So that makes my job much more easier. He has also very well described what are the clinical presentations of various types of asymmetries as well. So these are just few slides, initial slides, which I will run through. So the causes of asymmetry can be a lot, many, including developmental, pathologic, traumatic, or functional. And the simplest classification that was offered is by Obigeser, hemimandibular hypertrophy, hemimandibular elongation, condylar hyperplasia, and of course, many times it is difficult to differentiate between asymmetries. It's primarily happen, what we see in daily practice happen with the mandible, but then craniofacial asymmetries can affect the skull, the orbit, the midface, and the mandible. But primarily, we will be talking about mandibular asymmetries and associated compensatory changes during this talk. So it is, for a novice, it is not easy to distinguish between hemimandibular elongation or hemimandibular hyperplasia, or between a mandibular hypoplasia. So these are typical presentations of condylar hyperplasia, where you can see that there is a laterognathia, where the mandible and the midline is shifted towards the right, and then hemimandibular hyperplasia, where the midline is on, but you can see that there is a increase in the vertical height of the body of mandible, and there is a transverse gap Now, if you look at the condylar hypoplasia on the affected side, the mandibular occlusal plane goes down, creating a downward cant. But in a hemimandibular hypoplasia, you can visualize that there is an increase in the height and width, and both height and width of mandible, where the alveolus goes up, creating a transverse cant, and the midline usually remains normal. So this is one way to differentiate between condylar hypoplasia and hemimandibular hypoplasia. And I have just mentioned about Laterognathia. So there is a very detailed classification by Wolford, but Dr. Mustafa has gone through all these previously. So it can be condylar hypoplasia type 1, bilateral, unilateral, which is the most common that we see. But we, of course, also see mandibular asymmetry due to tumors like osteochondroma, then tumors, malignant tumors. So these are the typical clinical features of a condylar hyperplasia, unilateral type 1B mandibular asymmetry. So obviously there is facial asymmetry, there is chin deviation, lip incompetence, low setier, and the prognathic mandible. There could be reduced malar prominence on the affected side, but it's not necessary. It depends upon what age the mandibular asymmetry sets in. Paranasal hollowing, convexity of angle region on the affected side, minus convexity of the angle region on the affected side. Again, what Dr. Mustafa has mentioned very beautifully regarding downward cant in the maxilla, but one also needs to look at the mandibular occlusal plane, because there can be a mandibular cant as well, which we have to consider, because it may cause problems when we try to get good occlusion intraoperatively and then postoperatively. So look at the midlines. Remember that the nose can be deviated. There will be a cant which needs to be measured. Now, in a downward cant, you will most probably identify a gingival show or a gum show on the affected side. Whereas this is a typical presentation of a condylar hypoplasia where there is facial asymmetry. Again, orbital dystopia, you can see the orbits are at 2 different levels, the eyebrows are at 2 different levels, the ears are offset, ears are at 2 different levels. There is flattening of the zygomatic bone, that's a malar region on the affected side. There is a soft tissue lip cant and a deviated chin, and flattening of hypoplastic side of on the mandible, as compared to the other one where there was a convexity, there is a concavity on the side. So, and if you look at the X-ray, you will see an increased inclination of the mandibular anterior teeth and a reduced chin prominence. There will be an occlusal cant. Now, this is an upward cant, as Dr. Mustafa very well mentioned, when there is a decrease in the size of the ramus component that prevents the development of the maxilla. So there is the maxilla does not descend down, so it creates a upward cant. Now, if you look at the right side in full smile, his gingival show is correct, whereas on the left side, the gingival show is less. And you will always make out you can also make out that there is a mandibular cant. So reduced tooth show on the affected side during smile. Malar prominence these are again facial features that will tell you whether it is hypoplasia or hyperplasia. There is a deviation of the nose, exaggerated antigonial notch, and hollowing of the angle region. These are very, very classic features of hypoplasia. Now, these clinical features on radiographs, they will be exaggerated antigonial notch, which we are very, we know what are the features of ankylosing deformity. So it's somewhat a milder version of ankylosing deformities that you see. Antigonial notch, there is a condyle which is smaller in size, and many a times due to the reduced body or the occlusal table available, there could be impacted teeth as well. And CT scans are very, very useful. Now, hyperplasia versus hypoplasia. you can see whatever features that we have gone through. On the left, you have a hyperplasia where there is a prognathic mandible, and on the left, you have a hypoplasia where the mandible is retrognathic. It can't. You see, this very well shows the upward cant and the downward cant. On the left side, there is a downward cant in a hypoplasia, and in hypoplasia, there is the lower border, again, the convexity on the affected side in a hyperplasia, and the concavity on the affected side in a hypoplasia. Dentition, of course, there is a class 3, true class 3 or a class 3 tendency in hypoplasia, whereas there is no prognathic dentition or mandible in a hypoplasia. Now, we will go through some case examples of how to deal with asymmetries. Now, this is a girl who was 14 years old, undergoing orthodontic treatment, and she was due for debonding, at which time she said, she reported to us saying that, she feels there is a shift in her chin. She feels that her mandible is moving towards one side, which was evident. And you can see that the dental midline on the mandible has moved to the left side, and there is a chin deviation as well. So what would you do? And X-ray showed there is a inclination of the lower anteriors. There is a difference in the size of the ramus length, and there is, of course, there is a asymmetry in the lower border in the lateral cephalogram. So Dr. Mustafa also has very elaborately spoken about SPECT, the use of SPECT. So this is standard practice where we also have done a SPECT scan, and then you can see there is a glow in the right side, which says that it is a right condylar hypoplasia. So what would you do at this age? She is growing, she is 16 years of age. At this stage, you would just do a condylectomy or a high condylectomy or a condylar shave. And in this, on the picture on the right side of the screen, you can see the cartilage cap still is present, which says that it is still a growing mandible. What you do is remove only the cartilage cap and then just leave the patient alone. And after 5 months, you can see that her facial form is symmetric now. The deviation is gone, and the dental midline has returned back to normal. Nothing else was done, and then she went back to her orthodontist, after which she was debonded, and of course lost to follow-up. But this is her. Now, another girl who is 15 years old reported with a complaint that she's had this issue for some time. Her face is asymmetric. On the left side, she feels that her jaw is more down on the left side, but she was comfortable with her occlusion. She was only concerned about the fullness or asymmetry on the left side. What would you do in these kind of situations? Again, when the occlusion, she has a functional occlusion, which she's comfortable with. So in such situations, again, the role of just high condylectomy or condylar shave is very, 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 very important. These are her X-rays, and you can see that this is a case of hemimandibular hypoplasia, where the condylar head is thickened. There is a kind of a transverse cant. There is increase in the lower border length, and a significant amount of deformity. So we did the bone scan again, SPECT scan, and it said there is left mandibular condylar hypoplasia. So the plan was to do a high condylectomy and then do a condylar, the body shave to make the body height symmetrical, even while preserving the inferior alveolar nerve. So these are the guides that were made. That's the guide for the high condylectomy. In this case, it's more or less a condylectomy itself, not high condylectomy, because you have to take out the entire part of condyle that glows. This is intraoperative. You have very specific saw blades which can be used, reciprocating saw blades which can be used, which allows one to do this procedure intraorally, and even while preserving the in mental nerve. So that's intraoperative pictures. And on the right side, you can see how a guide helps to resect the condyle exactly as planned. And in the middle pictures, how a guide helps to resect the lower border exactly as that it has planned. And 1 month post-operative occlusion is this. And this is at 1 year. That's at 1 year. That is again at 1 year. This is her occlusion still maintained, no orthodontics at 1 year. 1 year x-rays. And this is her mouth opening. This was probably about a month later. There is mild deviation to the left, which has settled now. And these are her 3D images, which show reasonably good symmetry. Right. This is not just one-off, mind you. This is another lady who was slightly older. She was about 18 or 19 years old, who had a very similar complaint that she felt that her mandible is growing on the left side and lower jaw is growing, and there is asymmetry that she says that it is developing. So same plan, and you can see this is also a hemimandibular hyperplasia case. And as you can make out from the CT scan, the coronal picture on the left side, where there is a difference in the height of the body and difference in the length of the ramus. Again, SPECT scan was done, and our people started reporting the percentage, which was actually in borderline, because 45 to 55 is compared to be within normal range. But then she said that you do not take SPECT values alone as to make judgment. You always have to combine it with clinical findings and patient's history to make a judgment. So in this case, we again decided to go ahead with the same procedure that was done for the previous patient, lower border shave and condylectomy. This is immediate postoperative occlusion, even after removing almost a centimeter of the condyle. And you can see the sutures in the mouth. That's immediate post-op, immediate post-op. And this is her 6 month postoperatively. Good outcome. Occlusion is maintained, no orthodontics. 6 months, 6 months. And this is her mouth opening. She deflects a little bit at the end, but there is no pain. Occlusion is stable. And that's her 3D scan, which shows good symmetry. Now, is it always okay to do just a condylectomy? Now, this is again a girl who had reported with midline shift of mandible, gummy smile, and she said it was deviating more. She was getting taller, and then her mandible was deviating. These are the X-rays. So in these cases, it is difficult. You see that the left side condyle looks a little smaller than the right side, which looks elongated. So it may throw in a little bit of confusion. So the best thing is to again get a bone scan done. The bone scan says that there is an increased uptake in the right side. So right mandibular condylar hyperplasia, condylectomy was done, and that's post-op. And this is her occlusion. She did not undergo orthodontics for 1 year, and there is a definite improvement in her facial appearance post condylectomy. Right? Nothing was done. There is a definite improvement, but then she was not happy with it, so we started orthodontics. And after which she underwent the 4-1 osteotomy, superior impaction for her vertical maxillary excess, and a sliding genioplasty. And this is 1 week post-operative photograph. COVID times has not allowed us to take reasonably good post-operative photographs, but this procedure was completed almost 8 months back. And that's settling, and that is the outcome. So only a condylectomy, and then condylectomy, you wait, and followed by Lefort-1 osteotomy and genoplasty. These are her x-rays. Now, the problem with doing only a condylectomy and waiting is that some patients may say that this is good enough for me. The expectation level of patients may be different. So gentlemen, again in the 17 to 18 years range, who has significant facial asymmetry, as you can see. There is an occlusal cant. SPECT scan shows right condylar hypoplasia. Condylectomy was done. And he was again left alone for some time. This is his mouth opening after condylectomy. And this is immediate postoperative occlusion. See that you can see that in patients who have a significant cant after condylectomy, they're usually open upper left anterior left open wide on the affected side. And orthodontics was started. This is orthodontics and continuing phase. Again, continuation of orthodontics. And this is him with just condylectomy and orthodontics. Now, the problem is he's happy. I mean, the problem with me is that he's happy. I would definitely be able to improve his appearance. Now, he has gum show. He's not smiling completely. He has gum show, and he has a deviation in the chin. And what throws him away is that he's still sporting a beard. It's not a great beard to sport, but then he never shaves, right? So we will come to this later, but then you can see that he keeps the beard because there is a deficiency in the chin, right? But this is him with just condylectomy and almost 2 years post condylectomy with orthodontic treatment alone. That's him. That's his occlusion. Initial post-op, just condylectomy, and let's see if it plays. Yeah, that was his 3D. So this is one. We have gone through various situations of condylectomy and what can be done, followed with Lefort-1 osteotomy or just do nothing. Now, this is another boy who has a typical appearance of a left condylar hypoplasia, right? All that we have described, but there is a significant convexity on his right side. So there is a concavity on the left side, and there is a convexity on the right side. And you look at his occlusion, he has a cant, which is typical of condylar hypoplasia, and look at his left, it looks very small, but then right condyle good, it looks slightly elongated. And look at the position of his right condyle, it is almost out of the glenoid fossa with a significant convexity in the ramus body angle region and a significant concavity on the opposite side, which is visible in all the views. So again, SPECT scan was done, which said there is a condylar hypoplasia on the right side. So a condylectomy was done on the right side, and this is his intraoral photograph showing occlusion immediate postoperatively. There is a reasonable amount of malocclusion there, but his orthodontics was continued. The brackets were placed before the procedure, so that we could guide his occlusion. And this is the patient after almost, I think, 8 months post condylectomy. And there is an improvement in his facial appearance for sure. That's the basal view, and this is his orthodontics going on, but he has to migrate to another country. So the question is, what can be done further, right? So these are his x-rays. That this is the on your left side of the screen, you have the pre-condylectomy, and on the right side, you have the post-condylectomy CT scans. So then we come to the one of the part of the topic that I have to discuss today, morphometric basis for orthomorphic correction of mandibular asymmetry. Now, it's to me, at times it sounds like wordplay, but then, if you look at it carefully, what does orthomorphic mean? Orthomorphic means to change, to morph bone, right? So if you look at the dictionary, it's an adjective which says that to bring about change in increments, okay? But if you look at what the authors have described here, is that they have given the word orthomorphic a new dimension, or opened up a new spectrum for the word in which the word orthomorphic can be said. So the surgical correction consisting of an osteotomy aimed at restoring the morphology, which of course most of the orthognathic procedures are that, which surgical correction of an osteotomy aimed at restoring the morphology. Is denoted the term orthomorphic to distinguish it from conventional orthognathic surgery. Now, this is where the authors have opened up a new spectrum for the word orthomorphic to be deciphered from conventional orthognathic surgery. Now, then a lot of procedures can be brought under whatever is not conventional. That is again a loose term, but whatever is not conventional, I would call bilateral sagittal split osteotomy, leaford bone osteotomy, genioplasty as the conventional orthognathic surgery techniques. Anything outside of that would become an orthomorphic procedure. So let's see how we can, look at orthomorphic in a much wider spectrum. So coming back to this case, so what was planned was a typical orthomorphic procedure that has been described by the authors. This is a short video which shows how the cut goes. So you have your mental foramen there. So you have an extended genioplasty cut that goes beyond the mental foramen, and then genioplasty cut. And once you come to the opposite side or affected side, mental foramen, your instrument goes vertical. Your cut is sagittal now, like a sagittal split osteotomy. You run posteriorly, get medial to the external oblique ridge, and then cross. In a BSSO or sagittal split osteotomy, this cut would go medially, right? So, but in an orthomorphic, this cut would go laterally, and this is intraoperatively how the segment looks like. Posteriorly, much beyond the mental foramen. The nerve is intact, as you can see. The midline is brought back, and that's the kick out of the lateral segment. What it allows you to do is you can increase the transverse width of the ramus, which actually is the convexity. The convexity that can be corrected by kicking out the ramus angle segment of the mandible outward. Now, what additionally was done for this patient was to take out the lateral cortex in the right side ramus, which was very convex, was removed. Only the outer cortex, and what you see down here is the outer cortex, which was taken out as this, drawn, and this was used to augment the deficient side in addition to the orthomorphic procedure or the extended reverse BSSO cut. So and this is the outcome, right? So condylectomy, orthodontics, followed by orthomorphic procedure, along with a lateral cortex graft, right? And this is his X-ray. That's again his X-ray. This is initial, after condylectomy, and after orthomorphic procedure. Good reasonably good contour of the lower border there. The occlusion is settling. He's still undergoing orthodontics. Orthodontics is not over yet. You can see that there's a reasonably good lateral fullness. This is just one month. What you see now on the left side is the post-condylectomy 3D. And the post orthomorphic 3D. This is another patient who has undergone a similar procedure. This is actually Dr. Mustafa Khader's patient which we operated together. And you can see there is a significant amount of deformity. This is a hemifacial microsomia with a occlusal cant, a maxillary cant, mandibular cant, deviation in opening, and mandibular hypoplasia, retrogenia, and it's a Prusansky type 2B kind of mandible. Now, this is the scenario in which classically described orthomorphic is done to achieve this kind of outcome, which is reasonable. But then you have to keep in mind that you're not changing the occlusal table, you're not changing the occlusal plane, you're not changing the cant. The problem with the smile will still persist. The problem with the deviation will still persist. The only correction that is done is to the lower border and to the ramus region, which in more severe cases will be inadequate. So done alone, as a standalone procedure, orthomorphic procedures are more or less camouflage. Orthomorphic procedures are more or less a camouflage procedure. It does not correct the complete spectrum of the deformity, as you can see here, because there is a limit to which the bone can be moved. In this patient, the bone-to-bone contact at the genioplasty anterior was so small, and if you see the anterior movement of the segment is very minimal. You have to have some amount of bone-to-bone contact. So the stock bone available makes a difference, whether it allows you to move more or limits your movement. So that is the one drawback of a classic orthomorphic, is that it addresses only the body angle chin region, and it does not address the dentition, and it is at best it is a camouflage procedure, right? So can we do something different? Now this patient also can be treated with a straight upfront orthomorphic procedure, and it will give her a reasonably good outcome. She is also a hemifacial microsomia. You can see that the ear is missing on the right side. Microtia, there is all features of mandibular hypoplasia, and maxillary malar hypoplasia as well, because this is a case of hemifacial microsomia. And she is also a Prusansky type 2B condyle, where it's small. So the plan was to do mandibular distraction, vertical lengthening of the ramus of the mandible, which was done using endoscope assisted method, where there is no neck incision. There is only a small port where the activation arm comes out. So you continue distraction, and when do you stop distraction? You stop distraction when the dental midline coincides with the facial midline, because you cannot take the maxillary midline. Maxilla is also off, right? So you have to stop the distraction when the mandibular dental midline coincides with the facial midline, and then consolidate. That's the amount of distraction that was achieved post-operative scan. And this opens up again a lateral open bite. Orthodontics is continued with extractions, followed by a Leaford 1 and orthomorphic procedure. So a Leaford 1 cant correction, midline correction, settling osteotomy was done. Now, what we have done with distraction is that we have corrected the mandibular occlusal plane. We have leveled the mandibular occlusal plane. The mandibular cant, which was there, was corrected. The mandibular midline was corrected, and following which orthodontics was done. And now the maxilla was settled into the mandibular occlusion, which comes to the facial midline. And at the same time, an orthomorphic procedure to correct the mandibular skeletal midline and to address the ramus deficiency. And you can see here how much kick out has been achieved in the angle ramus region. And there's a small graft which is placed there and then fixed with multiple plates. So at the same time, alloplastic implant was placed in the right malar region to compensate for the malar deficiency on the right side. And this is the immediate post-operative occlusion. X-rays. The angles are almost symmetric, as you can see from the PA cephalograms, and that's her post-operative. See, the difference here is that you have used the orthomorphic procedure in combination with conventional surgeries, right, to get the best possible outcome that can be achieved, as opposed to a standalone orthomorphic procedure. Right. So there is an element of soft tissue deficiency in hemifacial microsomia, but you can compensate a lot for that using your bony augmentation, and if required, some fat graft later. Now, this is moving on from orthomorphic procedures. This is a patient, we will move to asymmetries per se, and most of these scenarios have been covered very well in great detail by Dr. Mustafa in the previous lecture. So I will run through this. Again, a young man with severe facial asymmetry reports what is possible. You see there is a right side condylar hypoplasia, laterognathia. SPECT did not reveal anything. So the question is, what do you do then, right? Can you do surgery first? Surgery first can be done. The best way to assess that is to get a set of models and see if what is the best fit occlusion that you can get. If you can get good occlusion with good amount of anterior space between the anteriors, of course, your orthodontist will tell you how much he needs to settle the occlusion, but you can yourself see if you can get a reasonably good occlusion, and there is not much of transverse issues, or there is no significant crowding. So in such situations, you can do surgery first and get good outcome with lesser time of treatment, as Dr. mentioned earlier. So that's his X-rays. I will run through these scenarios quickly, as most of it has been covered. Another gentleman with facial asymmetry. He is reasonably good looking, but he is not happy with his smile and his occlusion the way it is. So you have a cross bite, significant cross bite. What can be done again? That's X-rays. Intraoral, the lateral surface slightly stretched, I think. The plan was clockwise rotation of maxillomandibular complex, Leaford 1 advancement by 3 millimeters, bilateral sagittal split osteotomy with mandibular setback, and the genoplasty. So virtual planning helps you to visualize what you do on your articulator. So I know a lot more people are doing this, but it actually helps you to see what kind of movement is possible. Now, this is the maxilla coming straight forward by 3. And then you have to know the point of rotation. There can be multiple points of rotation. I'll just play this again so that you can see the point of rotation of maxilla is usually described along the palatal plane, right? Posterior, anterior, or middle. So, but if you don't want the posterior teeth to move up at all, right, then you keep your point of rotation at the posterior molar, the lowest cusp of the posterior molar, where the posterior maxilla stays put and it doesn't go up, which allows the mandible to rotate clockwise more posteriorly. So you get more sagittal movement in a sagittal movement and vertical movement, right? So this is again, and then the mandible is set back, followed by a genoplasty, right? So this is what is possible pre-surgical. Now, we always, whenever there are complex cases like this, always model surgeries are performed on articulator. So this is done as a mandible first. So what you need to do is you need to have 2 sets of mounted maxillary models. First, the maxillary movement is done, and then the mandible is set into that occlusion. And at this point, the maxillary member is removed, and the uncut maxillary model is placed, and this becomes your intermediate splint, which lets your mandible into position first, followed by the final splint. So that is possible. This is 1 week post-operative. At the end of the procedure, he was strapped up after that. And then now his orthodontics is going on and he's settling reasonably well. I will not step on the patient's foot, but significant asymmetries. Dr. Mustafa mentioned about the need for bijaw surgeries in cleft maxillary hypoplasia. Bijaws are definitely indicated in cleft maxillary hypoplasia with true mandibular asymmetry. Right? But otherwise, it has to be taken according to the merit, depending upon what the quantum of movement is required and the patient's facial profile. But in a definite true mandibular asymmetry, a bijaw in cleft maxillary hypoplasia is required. This patient had a huge overjet discrepancy, so underwent AMD, occlusal, then after which the decrowding was done, and that's him. Even now, there is a reasonably good amount of discrepancy and an anterior open right and a mandibular shift, and that's him just before the surgery. There, and this is maxillary advancement and mandibular setback. That's him. This is immediate pre-op, post-operative. That is post-operative occlusion. And this is him at the end. The occlusion was settled. Of course, some RPDs and FPDs were given for the anteriors. And he underwent rhinoplasty and some hair transplant for his lip and beard. Now, asymmetries are not always corrected by surgery, conventional orthognathic surgery alone. And sometimes, as I mentioned earlier, there is the convexity on one side, which does not get addressed with conventional VS systems. So the patients can be left with some amount of, this is pre-operative and post-operative. The AP discrepancies are corrected, but see, the angle issue is still there because the ramus is convex, still convex on that side. So in such situations, you can place alloplastic implants. He underwent malar implant as well as angle implant, which almost gave him a harmonious appearance in terms of symmetry. Now, orthomorphic is not only a, I will quickly run through. I think this is probably the last case. How am I? Yeah, I'm okay. 10, 15 minutes left. Okay, good. So orthomorphic procedure, as I mentioned earlier, orthomorphic word can be attributed to not only mandible. I'm trying to widen the spectrum of orthomorphic here. So anything other than conventional can be an orthomorphic procedure. So this is a girl who presented to a friend orthodontist in this situation. So that is her occlusion, significant amount of crowding. So upper premolar extraction and alignment was done, which left her with almost a 16 millimeter overjet discrepancy to get the best possible occlusion. And that is her. Now, it's not only a maxillary problem, and it is not only a mandibular problem as well, right? If you look at her nasion to the menton, the mandible is not that prognatic, right? If you look at her chin throat length, that the mandible is not that prognatic. What is deficient is the maxilla, but then you have to take the mandible back as well, because you cannot bring the maxilla forward by 16 millimeters or take the mandible back by 16 millimeters. You have to divide it. But what about the malar deficiency here? If you look at the zygomatic regions, they are very, very deficient. They lack width and they lack projection, right? Where piriform region is also very, very small. So what can be done? is to, and this is her post just pre-surgical overjet that is available. It was assessed on when oral surgery was done. This is pre-operative. The plan was to do a quadrangular Leaford 1 osteotomy with an advancement of 8 millimeter plus midline correction and a bilateral sagittal split osteotomy to set the mandible back by 8 millimeters, followed by a genioplasty. So that is pre-op. This is maxilla millimeters and mandible move back into the best possible occlusion with correction of midlines. Now, see, just moving the maxilla and mandible is not going to give her the best possible outcome because the malar is so deficient. And one option is to place implants there. But quadrangular Leaford 1 osteotomy is a very, very good alternative. This is the cut that is placed. Instead of going through the buttress, the cut curves up, goes along the zygomatic bone and cuts out posteriorly. And see, that is the cut. And this can be moved forward by 8 millimeters, right? The usual thickness of a malar implant is somewhere around 7 to 8 or 9 millimeters. So you can get the same movement, same augmentation, which you would get with a alloplastic implant if you do a zygomatic wing osteotomy or a quadrangular osteotomy. Right. That's the movement with the intermediate splint, then the mandible setback and the genioplasty. Right. So this is what is possible. These are intraoperative photographs which show the line on the left side that is marked, which going up into the zygoma. This is done intraorally. You don't need any other incision. It can be done intraorally. And that is the fixation. So there is a fixation at the pyriform region and a fixation at the zygomatic region. It's not easy, but it is possible to fix it onto the zygomatic arch. Now, this is different from high Leaford 1 because the high Leaford 1 is a higher cut on the pyriform region, but the posterior cut goes along the buttress, right? So it should not be confused with high Leaford 1. High Leaford 1 and quadrangular Leaford osteotomies are two different entities. That is her outcome at 1 month. As you can see, the malar region is very well projected, good profile and good harmony. And even in the bird's eye and the worm's eye, the malar region and the pyriform region fullness can be well appreciated with when you do a quadrangular osteotomy. The X-rays. Now, this is just another case example to show the use of quadrangular osteotomy. Once you start doing quadrangular osteotomy, there's a lot of scope for quadrangular osteotomies in orthognathic surgery because the amount of malar hypoplasia we see in a mixed class 3 with a mandible with a hypoplastic midface. This is a typical appearance that you would see. Significant amount of malar hypoplasia, and he was undergoing orthodontics for a long time. The compensation was not completed. All premolars were still present, and COVID situation, he couldn't travel. He wanted the treatment. So then this is him just before going on table, and you can see that he holds his head in a very peculiar way, right? If you look at his is on the right hand most side, what you see how he holds his head, that is his neutral head position, and the middle one I have asked him to bring his chin down, and that is his adjusted neck position. So that is him, and even here you can see there is significant amount of midface hypoplasia. So in this scenario you can still do a clockwise rotation where the max, as you can see with the occlusion, there is not much scope for movement here. So you have to do a clockwise maxillomandibular complex rotation in order to get good outcome. So the maxilla is moved forward a few millimeters, say 2 or 3, but then with a posterior differential impaction, and that will allow the malar region to come out more, right? Even though your movement anteriorly is 3 or 4, the movement at the malar region, because there is a rotation, it becomes 7 to 8. So it comes forward significantly. And so you can see there is 6.3 to 7.7. So there is an average of 7 millimeter movement in the malar region, and followed by mandibular setback and genoplasty. So this is him at the end. And again, if you compare with his pre-operative picture, you can see that there is a good contour of the malar region on both sides. So this can be achieved with a quadrangular osteotomy. That's the X-rays. Now, last one. Again, expanding the scope of orthomorphic surgery, which is not conventional orthognathic surgery. This is a girl who had presented to us with TMJ pain, reduced mouth opening, and she said that she feels her mandible is receding, and there is an increased overjet, as you can, excuse me, as you can see. The condyles doesn't look great, but it doesn't look that bad either. But gradually, on follow-up, you see that her condyles are losing size and shape. This is on the left side, the condyle has almost degenerated into nothing. Right and left, as you can see on the CT scan. So this is a case of idiopathic condylar resorption, and she said that she feels her mandible is receding, which is actually visible on the X-rays. In 1 year's time, the mandible has receded significantly. So MRI was done, but her primary problem was pain. Her primary problem was TMJ pain. So arthroscopy was done, level 1 on the left side, and level 3, where a disc repositioning and discopexy was done arthroscopically on the right side. She was okay for some time, but then again, she reported back again with a reduced mouth opening, receded mandible, bilateral TMJ problems, and increased overjets. You can see that her chin has further receded. And in the CT scan, the sagittal images, there's hardly any condyle left, almost everything has gone. So the diagnosis is bilateral symptomatic idiopathic condylar resorption, and the plan was bilateral TMJ TJR, total joint replacement, with an advancement to compensate for the mandibular recession that has occurred as a part of the disease, and to do a segmental 3-piece maxillary osteotomy to get an occlusion. Right. So this is her occlusion, with after which the maxilla was advanced. Now, in order to get mandibular advancement into occlusion, it was the maxillary advancement was also required. Otherwise, a TJR advancement possible into the maxillary occlusion was only 4 or 5 millimeters, but that was not enough to compensate for the recession that had taken place. So a maxillary 3-piece osteotomy to correct the arch width discrepancy, and mandibular advancement was done. So these are the bilateral TJRs. Now, there is a technical thing here is that this is called a dog's keg. It's not a typical customized design. The condylar neck is curved posteriorly. It's called a dog's keg to compensate for the position of the mandible in relation to the glenoid fossa. And that is her postoperative. In occlusion, we, as Dr. Mustafa very beautifully mentioned earlier, retaining the splint postoperatively is very, very important in segmental surgery and in cleft procedures. It allows your fixation to heal well, and it gives a stable base for the mandible occlusion to get into during the healing period. And that is her immediate postoperative. These are her X-rays showing positioning of the TJRs and the maxilla. We usually put them on IMF for a few days and then elastic guidance till the time the new joint settles in its position in the TMJ. and that's her now. Pain-free, which was her primary complaint, and she's also reasonably happy about her appearance as well. So to conclude, I would say that orthomorphic procedures can be any surgical procedure that is going with the new spectrum that has been created. Orthomorphic procedures can be anything that does not conform to the conventional orthognathic surgery. Now, what might be conventional for you might not be conventional for me, but in the larger context, I would say that Lefort 1 BSSO genoplasty comes into the conventional range. So it's a wide spectrum, and there are a lot of things which could have been included, but for lack of time, and many of that has been covered very well by Dr. Mustafa Kader in his previous lecture. So he made my job easier, and even Deepesh's job easier, I think. So thank you so much for your kind invitation, and I'm honored to be a part of this.
Thank you, Dr. Pramod.
Yes.
I just had one or two questions for you.
Sure.
The first one is regarding the condylar hyperplasia cases. Condylar hyperplasia?
Yes.
Yeah. Is there a specific age at which you would operate, or you would operate at any age the patient presents with?
Where did this go? Just a second.
You wait for the
No,
growth
just a
to
second.
be
Just a second. I'm
completed?
just trying to get the screen here. Okay, fine. See, when you it depends upon the clinical presentation, and it depends upon the imaging that you do, right? If you see a child, say 12-year-old child, if you see a 12-year-old child who says that there is a visible deformity, and then there is a shift that you see on X-rays clinically, and you get a bone scan done, and it says there is significant activity on one side. You know that if you leave the child alone, it is going to establish as a deformity, right? But you have seen from my presentations, and this is not my work, I would say that you should read the articles by Dr. Nitsan, NIT is a Dayan, who first proposed condylectomy as a standalone treatment for condylar hyperplasia. I wouldn't completely agree with what she says. It cannot be used as a standalone procedure, just like the orthomorphic, but then you can combine it with. Doing a condylectomy makes a difference because it will prevent a full-blown deformity from getting established. So it can be done earlier. The youngest I have done is at 12 years.
So would you have to do it again after the growth period is completed? Do you have to review the patient and probably, will they require a procedure again after the growth period is completed?
Such patients will usually undergo orthodontics. Now, young children, they will have malocclusion. So they will be with your orthodontist. And if you have taken you don't take the entire condyle away. You take only as required. In such scenarios, in young children, you need to take only the cartilage cap. That is only 3 to 4 millimeters of bone away, right? And that usually arrests the growth issue. So I have not had to go back and redo a condylectomy.
Okay, thank you.
They may still have some amount of, like little bit of vertical maxillary excess, a mild facial asymmetry, which they may accept, right? Or we may need to go back and correct, but then it will prevent the very gross deformities that you see as grown-ups.
Right. Thank you. The second question was like, for post-ankylosing deformities, I mean, you did not share any of your cases. I mean, do you do orthomorphic surgeries for post-ankylosing deformity?
Well, we do distractions and TJRs more now, but I wouldn't do mandibular orthomorphic procedure as a standalone for post-ankylosing deformities. Dr. Mustafa has shown a lot of asymmetry-related ankylosis cases where there are alternate osteotomies available, but mandibular orthomorphic procedure as a standalone treatment for post-ankylosing deformity is a camouflage. So you have to distract, you have to correct the occlusal plane, and then followed with a TJR or an orthomorphic would be an option with a maxillary procedure as well. Yeah.
Yeah, there are particular indications for that.
Yes.
There is one question from the audience. They want to know, like in biomax surgeries, which jaw should be corrected first, and what is the deciding criteria and advantage for the same?
See, conventionally, most people do maxillary procedures first, right? Though we make the mandibular cuts, we do not split. We make the mandibular sagittal split osteotomy cuts, but then go then to the maxilla, finish the maxillary cut, maxillary movement, maxillary fixation, and then come back to the mandible, because it is easier and more predictable to place the maxilla, and also to look at the the nose position and the lip position and the the incisal show that you are going to leave if you do a maxilla first. But having said that, there are a lot of people who do mandible first, right? And there are specific indications where you do a what I showed is a very specific indication where you're doing a clockwise rotation of the maxillomandibular complex, where we have not taken the posterior maxilla up. The posterior maxilla remains where it is, and followed by, and then the anterior maxilla is brought down. Okay, so it is not easy to do a moral surgery, and it is more predictable to do a mandibular procedure in such situations, right? Because your mandible is going to rotate downwards when you fix the splint. Instead, you take the mandible back. It is more predictable to do a mandibular procedure in such situations, not always in my hands. But having said that, there are many people who do mandible first as opposed to maxilla first. It's a personal preference in most cases.
Thank you.
Thank
you again for the excellent presentation. Please accept this e-certificate from us as a token of our appreciation.
Thank you so much.
Thank you. I now hand over the proceedings to Dr. Rajnikant, Associate Professor in our department, and he will introduce the next speaker and the topic for the day.
Namaskar. I'll introduce our next speaker for the day, Dr. Dipesh Rao. Dr. Dipesh Rao completed his BDS in 2006 from Maharashtra University of Health Sciences, then MDS in 2010 from SDM College, Dharwad, under RGHS. He did his cleft fellowship from RGHS in 2011. He got his dual qualification status by completing MBBS in 2017 from RGHS Karnataka. He went to do his fellowship in pediatric maxillofacial surgery from Royal Children's Hospital, Melbourne, Australia. Fellowship in craniofacial surgery in 2020 from John Radcliffe Hospital, UK. Became fellow of International Board for Certification of Specialists in OMFS in 2016. He has many academic achievements and received award for academic excellence in 2010 from Dr. Virendra Hegde at Dharmasthala. He is presently working as consultant craniomaxillofacial surgeon at Bhagavan Mahavir Jain Hospital, Bangalore. Now I welcome Dr. Dipesh to share his knowledge. I welcome you, sir.
Thank you so much. Good afternoon. I'm really grateful for this opportunity by the Indian Orthodontic Society and also the Association of Oral Maxillofacial Surgeons India. I think the previous two speakers, Dr. Mustafa and Dr. Pramod, are stalwarts in the field of orthognathic surgery, and to share this space with them is an honor. And I personally extend thanks to Dr. Preetham, who, from being my mentor and now colleague and friend, recommended me for this talk. This morning, Dr. Prashanta explained the diagnosis and treatment planning aspect in detail. Then Dr. Ratna explained how to go about making splints and do the model surgery. And then Dr. Mustafa sir and Pramod sir, with their vast experience and beautiful illustrations, have now left the audience in awe of what is possible with good collaborative work between surgeons and orthodontists. So it leaves very little for me to convey. But I have one point to say, after having completed 10 years after finishing my maxillofacial surgery residency of MDS, going to different units, I think we are in a very good position now to comfortably say that we as maxillofacial surgeons and orthodontists can give comprehensive care, world-class care to our patients. And that is where I think we have made great inroads. And this is why we have to work collaboratively to try and get ourselves better. Of course, learning is continuous, and we will never stop at that. I represent my unit, Bhagwan Mahavir Jain Hospital in Bangalore, which is a comprehensive cleft care unit under the leadership of Dr. Krishnamurthy Bonantaya. We now have 2 orthodontists, a pediodontist, a speech and language therapist, and of course, we also take 2 fellows every year. This is a place where we can offer free cleft care procedures for all our patients, including the orthognathic surgery procedures. So it is something that is, allowing us to try and get the stigmata of cleft maxillary hypoplasia sorted in patients with cleft. So diving into the topic and not having to waste any more time, why is this hypoplasia? So, this has been plaguing researchers for many years on what contributes to the cleft maxillary hypoplasia. And in the past, a lot of speakers have discussed this elaborately. I will just touch upon these points. Again, this is a beautiful article published in the year 1976, where they researched about, took 135 males and 120 females of unilateral complete cleft lip and palate. And, they found out with cephalometric analysis that there is an overall downward or vertical growth pattern. The cranial angle was flattened. The maxilla was smaller. The ramal height was shorter. The chin was retrognathic. Skeletal profile showed less convexity. The upper facial height was less and the lower facial height was greater. So all these points show that there is a skeletal deformity. Now, why does this skeletal deformity happen? Also, there were researchers who said that the anterior alveolar region remodeled more, whereas, nothing, without much changes in the anterior nasal spine region. And it did not differentiate between the cleft lip and palate. So the impact of lip repair or palate repair, to find out what the growth retardations were like, was still controversial. In fact, they have mentioned that some researchers felt that a subperiosteal dissection caused that problem. The 2-flap technique of the palatoplasty caused the growth retardation. Doing a gingivoperioplasty caused that problem, or an active pre-surgical orthopedic appliance caused growth retardation. There are so many elements, and not a single researcher would ever be able to pinpoint the exact cause for growth retardation, because there are also hypotheses that there is an inherent growth retardation in cleft patients. So to blame a procedure and identify what has caused and what to change in your primary care will be very difficult. However, the scars of early surgery, the facial dysmorphology, and the inherent growth retardation is definitely the reason why we have cleft maxillary hypoplasia. Now, the cleft maxillary hypoplasia just compounds the problem, and this is where we need to work and try and get the maxilla in a better position, or also, of course, try and address the mandible when associated with that. There are a few problems, and cleft orthognathic surgery, if I have to say correctly, is one of the most challenging procedures. You have to understand, if you do an aesthetic procedure, you want the end outcome to be aesthetic. And it is very rare to get a series. We will all have a few patients, 1 or 2 patients, which we can show in our presentations, but to get 20 consecutive patients where we can say, yes, this is what I wanted, this is what I've achieved, because there are some facial aesthetic imbalances already existing in these patients, and there's so much to do. The touch up, say for instance, in a patient with a scarred lip, tight lip, non-dynamic lip, secondary to the lip repair, or cleft, secondary cleft nose, and also just the dentition. We can't show these beautiful occlusal pictures that you orthodontists are obsessed about, to show post-operative care, where we take these pictures after debonding and there are missing teeth, deformed teeth, multiple caries tooth. Even if we do a good prosthetic rehabilitation, they're never as close to having a normal arch with good teeth. And of course, there is missing bone causing the lack of migration of teeth into the cleft alveolus, or there might be a premaxilla which might not be in the right position. So there are so many problems of cleft. It is not just the skeletal discrepancy, but there are associated problems. They present early. They start presenting early. They start presenting around the time of mixed dentition, and this is where a lot of orthodontists around the world are trying to address the cleft maxilla, so as to offer treatment at this point of time, and do growth modulation procedures. So you could use a face mask, and this is something that you could do to try and protract the maxilla. There are some good outcomes. Having said that, 11 patients were followed up to the completion of growth in a paper by the Japanese group, and they said that despite feeling that it is working in the early stages, as a good alternative and to avoid orthognathic procedures at a later date, 5 patients still eventually required orthognathic procedure, and they had large variations and conflict in the amount of correction that they would get. So although the sample size is small, but remember, this is a group where they have followed these patients up until completion, growth completion. So 11 patients gives you a significant number on what is happening to that. Of course, they also suggested, there are other groups which suggested that it works better in patients who have had the alveolar bone grafting. So if you have alveolar bone grafting and you do a face mask therapy, the outcomes are marginally better. Having said that, Eric Liu, when he published this technique about Ultramac, where you break the sutures and then do the face mask protraction, he was convinced that this is it. This is what is going to prevent patients from having any further orthognathic surgeries. And they had very stable results for 2 years follow-up. Miazzini, who is another famous orthodontist from Italy and who's been doing comprehensive work in patients with cleft, she did a long-term study using the Eric Liu's Ultramac and found that although they gave satisfactory results early on, apparently in the long-term results were not so convincing, and they were not able to predict the percentage of patients which would eventually require orthognathic surgery. So yes, we are trying to get good growth modulation techniques with our orthodontic colleagues, but it will not obviate the need for collaborating together and providing orthognathic care when at growth completion. So I will not explain the assessment in detail because this has been done in the first lecture. But in a unilateral cleft, the missing tooth, which can be the lateral, a canine, or sometimes the central, will not allow you to have a good midline. So this is something that you need to understand. The missing tooth. Also, because of the lack of a bone grafted segment, you may not be able to orthodontically move it there. So how do we deal with all that? How do we try and identify where we go from here? So maybe first, if you get these patients early, in a good time where the canine is yet to erupt, it has found 2/3 completion, probably get the bone grafting done and then try and do your orthodontics. Also, once a grafted maxilla would be beneficial for your orthodontic movement, and also for in future when the maxilla has to be addressed for an orthognathic procedure. Having said that, these patients also have cants, so this is also something that you need to identify. Most likely, the lesser segment, which is the cleft side, is higher, and the greater segment, which is a non-cleft side. The greater segment is basically the part of the alveolus which has more teeth in the unilateral, is slightly lower. So that itself, the cant needs to be looked at and documented. So when you look at a patient with cant, see whether the patient has had a bone graft. If not had a bone graft, this will also allow the orthognathic surgeon to probably do a multi-piece osteotomy and address the cant at the same time of surgery. Instead of orthodontically trying to deal with the cant and probably disrupting the way the teeth sit on the basal bone, we could let the surgeon do the cant correction using a multi-segment osteotomy. Of course, crossbites also are possible in unilateral patients, and it could be just on one side. Again, this allows you to see and detect early and plan, put it on your paper or document it for future procedure. In bilateral, all the other points are similar to unilateral, except the fact, yes, the premaxilla complicates the issue sometimes, and it is very, very distressing to see them, where surgeons of the past have mutilated or chopped off the premaxilla. So the segment which is right in the center in a bilateral cleft. So you have the lateral alveolus and the premaxilla, which has the central and at times the lateral incisor, is taken away or chopped off. And that, when it is absent, it is very difficult to treat because there is no bone, there is no dentition. And also, it also causes a lot of growth disturbance. So in patients with premaxillary segments, absent premaxilla, orthodontics at the onset becomes challenging. Also, because of the way the bilaterals are designed, the Bolton's ratio is always compromised in bilateral cases. So this is something that we will have to address when we are planning our procedures in future. So you can see this premaxilla is not only deviated, it is also slightly low. So we now, there is no right time to set the premaxilla up, but we could always do the premaxillary osteotomy. Now we are transitioning the premaxillary osteotomy to what we believe is slightly more precise than the previous fiddle that we used to have with the premaxilla. So we do it using a virtual surgical planning. So we can quantify the amount of the bone that we need to osteotomize. We can also predict the direction in which we have to take it and correct the deviation of the premaxilla. So this way, if you see the colored portion is the preoperative portion, and the postoperative position is in good dental harmony and in good position. This virtual surgical planning also prevents us from over-correcting the premaxilla, which can happen when we are doing model procedures, where we might set it up higher than required and end up in an open bite, or sometimes change from deep bite to a cross bite. So all that would happen. Of course, good model surgery, good virtual planning is required, and this is where we collaborate together. 3D printing allows us to make cutting guides, although not essential sometimes if you know the quantum of bone required, but of course, good surgical splints can be designed and help in stabilizing the premaxilla segment, which has been osteotomized and put into a new position. So this is something that we do surgically. This is where, again, the orthodontists sometimes find it hard to manage the premaxilla and intrude the premaxilla with the orthodontic forces. So this can be corrected surgically. Now, the planes of growth retardation, like explained in the previous lectures, is in all three planes. Whereas, so you have anterior posterior deficiency, you have transverse deficiency, and you also have the scan. So this is where cleft orthognathic surgery becomes an interesting domain. It's something that I really like because it's challenging enough to think about how you're going to correct the anterior posterior discrepancy in most patients, in normal patients. But here you also add the element where it's not just the anterior posterior discrepancy, it is also the three-plane discrepancy where you have the transverse and the vertical problems. So we have a good assessment sheet where we document everything that we have when we see a patient. So most of our patients come for a workup where we take good pictures, fill in this orthognathic clinical assessment form, and we also do a Facebook transfer. This highlighted portion is where we have to make sure that we definitely document it. Remember, these patients are patients with cleft lip, and they're definitely going to have some amount of element of shortening, so of the upper lip. So if the upper lip is way off the normal, please accommodate a lip revision in future. So when you plan and take the incisal displays at rest and smile, account for the future lip revision correction that would take place either by just a routine lengthening procedure in a unilateral lip, or with an Abbey's flap in a bilateral cleft lip. So this is where an assessment form is important, because we now know not just the incisal display and at rest and smile, but also the length of the lip, and this is important to document. The other points that are relevant to us is, a very simple illustration that has been described very well and in detail in Johan Reinecke's book, where the cheekbone, nasal base, lip form a gentle curve. Now, if there is a break in the curve, like shown in the first picture at the maxillary level, you know that one break is only because of maxillary deficiency. However, if there is another break, that is, if the line is more convex at the corner of the mouth, then it might suggest that there is a maxillary deficiency and a mandibular prognathism. So understanding this very simple cheekbone, nasal base, lip curve complex allows you to eyeball. I would not say it is the most accurate assessment, but eyeball whether this patient requires unilateral or a single jaw or a bi-jaw procedure. The other beautiful, simple technique is using the Andrews facial profile line. So, using the forehead, identifying what forehead the patient has, make your fall line, and then you have your goal anterior limit line, and the discrepancy between the two will allow you to understand whether this patient requires. Basically, it will help you to judge the maxillary level. If the maxilla is at the right level, of course, it is not going to be right level in cleft patients, but where to bring the maxilla, and if you bring the maxilla into that position, whether you need any mandibular procedure. The other line is to make sure that you have a perpendicular line from the nasion, perpendicular to the Frankfurt horizontal plane from the nasion, and based on that line, you can see that most concepts of facial beauty suggest that the upper lip is slightly a millimeter or two ahead of that line, and the lower lip is on that line, whereas the chin falls on that line. Now, remember, the assessment points in cleft are going to be always tricky, because it's not just the midlines that are deviated, it is also the nose. So the nose, most patients will require a cleft rhinoplasty, and this will happen after the skeletal correction. So the nasal labial angle might not be accurate. The way the nose sits will mar the assessment points. The malar prominences are deficient. So all these points make assessment of cleft patients that much difficult. However, having said that, because these patients have been receiving treatment for so many years, they also are a little forgiving, in the sense they're not as demanding as our patients. In fact, the surgeons now are more demanding about what they can achieve and how much final aesthetic balance that they can provide the patient. So when we are documenting our assessments, it is important to document the patient's chief complaints as well. So if after having discussed the assessment points, I'm just diving into most points quickly so as to just illustrate the concepts. I don't have too many photos to show how clever I am, but I have some points that I can keep highlighting. Now, in this patient, it's a cleft maxillary hypoplasia, and we've managed to do a bi-jaw correction. The profile is slightly better, and it could have been probably better. But you know what bothers me more, and I know this is something that is prevalent in most patients after the procedure, is the eversion of the lower lip. And this everted lower lip actually compromises what you would think is a good outcome. Now, this is a 3-month or 4-month follow-up from the time of surgery, which was done early this Jan. Although we did a multi-piece osteotomy, although we could predict a good facial balance, the lower lip was everted and was sitting right there. And when I looked into the literature, I realized that it is not just our problem. It has been well documented, and it has been over discussed. Most surgeons believe that a genioplasty is the answer to that. Having said that, there is no literature evidence to it, and it is basically just the fact that the upper lip is short, the maxilla is retruded, and the lower lip has been compensating for that for so many years. So now the lower lip architecture is like significantly thicker than the control patients, and it is more thicker when compared to unilateral patients. So unilateral have hypertrophy, and bilateral patients have more hypertrophic lower lip. So it definitely then points out to the fact that it is an inherent problem of a short lip and a maxillary retrusion that causes this hyperactive mentalis and hypertrophic lower lip. Now, to correct the cleft maxilla, the procedure are anterior maxillary distraction at the leaf-out level, conventional orthognathic surgery, and distraction in combination with conventional osteotomy. Now, all this is in favor, in flavor at some point of time. Having said that, most of our cleft patients cannot afford significant, expensive internal distractors, or for that matter, external distractors. And that is where I think this anterior maxillary distractor gained a lot of popularity. It was described first by Dr. Gunasan and Rajan in 2007. And from the time it was described, it gained a lot of popularity, especially in our population, where we could correct with just the tooth bone palatal distractor, we could correct the maxillary hypoplasia, and not just correct the maxillary hypoplasia, but also correct the arch discrepancy. Although it was described before Dr. Gunasan described it, it did not become popular elsewhere in the world. But when I tried to ask other surgeons about why this has not picked up, I realized that nobody ever actually had the cost issues. So it's mainly the cost issues that allowed us to flirt with the anterior maxillary distractor and has gained a lot of popularity. So having said that, we still are now trying to restrict the use or not allowing it to become our main workhorse. So we have now said that these are the indications where we will use the anterior maxillary distractor, and we will still have a role for conventional orthognathic surgery or internal or external distractors in other cases. So main indication, it is the where there is where you want to increase the length of the arch in a severe crowding and you want to fit the arch, so you give an occlusal table. You also have patients where you have missing teeth. By increasing the arch length, and especially at the distractor segment, and it has been made possible, and we have done it in the past, where we have been able to put implants into the newly distracted space. So we can address the occlusal table. And also, because we are addressing only the anterior maxilla, if there is a presence of a pharyngeal flap, or there is a good speech which you don't want to compromise, you would think in theory that by letting the posterior palate or the soft palate intact and not disturbing it from its anatomical position, the speech would not vary. In fact, if at all, the articulations will become better because you are now giving space in the occlusal table. So this is how a distraction result can be seen. Both my previous speakers have touched upon the beauty of anterior maxillary distraction. Simple cuts are given between the premolar and the molar region, which are banded into the tooth bone distractor. It is just the conventional Hyrax device which you routinely use for transverse palatal expansion. This now Hyrax is placed in an anterior posterior direction, and you just look at the arrows and keep turning activating the key in the direction of the arrow. Our cuts are basically between the teeth, the premolar and the molar, which has been banded, and of course the horizontal level is like the Lefort line. So we give a latency period of 5 days, activate it twice a day to about 1 millimeter a day, and then wait for 8 to 10 weeks for consolidation. It allows for large advancements and improves the skeletal foundations, and it also takes the soft tissue forward. So it is definitely a good procedure. Having said that, there is also a functional advantage of the fact that, like I mentioned, the arch perimeter is increased. Now you can easily put some prosthesis, or you can put fixed prosthesis, or you can put implants. It also allows you to improve the compromised masticatory table. I think the most discussed disadvantage, and this is a disadvantage which I personally hate about the anterior maxillary distractor, is the development of an anterior open bite. The design of the Hyrax does not allow the maxilla to go just in a linear motion. It makes the anterior maxilla go up in front and up. So what happens is the open bite keeps on increasing. Of course, the solution to that is callus molding, which with elastics you can mold the callus. But we have noticed in the past that the callus molding sometimes cause extrusion of the dentition, and thus compromises whatever remaining teeth we have. Also remember, the osteotomies can be very close to the teeth, and this can also compromise the periodontium of the teeth adjacent to the osteotomy site. So there are disadvantages and has to be used. That's why I said this is not a procedure that can be now fixed for every cleft maxillary hypoplasis. We've had very good results in some patients, and we all often show our best results. This is, although the correction does not look dramatic, this patient did not have a premaxilla, had missing anteriors. Dr. Akshay Shetty, who's one of the speakers in today's planned this procedure where we used a temporary acrylic prosthesis to give us the reference range of how much we need to move, and then to that acrylic prosthesis we soldered the anterior maxillary Hyrax and got a good post AMD result. We improved the occlusal table. We provided a fixed prosthesis. You can appreciate that the dentition is severely compromised. Not just the fact that there is anterior missing teeth, but also the remaining teeth are not in the best of health. So, having said that, the challenges are many in cleft maxillas, and we get away with good results when we do anterior maxillary osteotomy. Now, coming to conventional orthognathic surgery, based on the previous descriptions of assessment, we can do single jaw corrections where you can move the maxilla forward and get a good harmonious result, or you can do a bi-jaw correction to get maxilla forward and the mandible setback. Having discussed this with a lot of surgeons, and of course as a part of a WhatsApp group, I get to learn a lot from Dr. Mustafa and Dr. Pramod, and of course my own mentors, Dr. Krishnamurthy and Preetham. And I know that the cleft maxilla, although it looks like it's a linear advancement, it is never a linear advancement. You have to make sure that with linear advancements, you try to do what has been now described very eloquently about the clockwise rotation. So you downgraft the maxilla slightly, take the mandible along with it, so you have a settling osteotomy, and that will quantify for this setback as well. So when you're assessing these patients, because of the cleft maxilla, which is hypoplastic, there is a tendency for overclosure of the mandible. Now, the assessor or the clinician has to ask the patient to keep the lips in repose, so gently try to disocclude the patient from the overclosed position, and then check the level at which the chin lies. Now, accounting for a downgraft, when you look at the chin moving lower, you will notice that the chin now goes into a more retruded position. So that is where, if you find a patient where the chin goes in a retruded position, the treatment plan for that cleft maxilla would be anterior maxillary advancement, downgrafting, mandible settling or setback with a settling osteotomy, and a genioplasty advancement. This kind of fits most patients. Having said that, this patient had a good chin prominence, and we managed to get away without doing a genioplasty in this patient. Multi-segment osteotomy is definitely required, and it is something that we all should have in our arsenal. If you notice, when you keep the cast in occlusion and you feel that two teeth or whatever teeth are in a crossbite, that has to be addressed by doing a multi-segment osteotomy. The reason why I chose this particular cast is to show that we now have done multi-segment osteotomies to just settle two teeth, that is the first molar and the second molar on the left side, and we've got into the corrected position. By trying to do this, by showing this case, I'm driving this point that multi-segment, even for a small segment like that, is relatively safe and can be done. So it is good that orthodontists obsess about occlusion. And if we start obsessing about occlusion, which is very difficult to achieve in cleft maxillas, in cleft patients, it'll be a good thing to do for the larger benefit. Virtual surgical planning is now gaining a lot of popularity. There are many Indian softwares providing this for at slightly affordable prices. Of course, I would love to get the prices lower so that we can provide it to most of our patients. Also, there are many 3D softwares available in the market which you can buy and then start using. So in the next 5 years, I think virtual surgical planning will take over. It allows you to play with the position of the maxilla. Of course, you can have a 3D photo over it, and then by the overlay, predict roughly about what profile changes this will cause. What I personally like about the virtual surgical planning is that when you do midline corrections and when you do the yaw corrections, you can actually see if the molars are in the same line when the midlines are corrected. And this will allow you to have a better occlusal table. And this is where, of course, that can be done in model surgery as well. But this is where virtual surgical planning adds a little bit of niche and precision. Cleft orthognathic procedures have always been related with speech, stability, relapse, and vascularities. There is a lot of talk about, as soon as you say a leafletward advancement, people will speak about speech, stability, and relapse and vascularity, oftentimes jumping out of the seats to say that this is not possible because this would compromise A, B, C. So when you look at the literature, contrary to the belief that speech is compromised, in fact, speech improves because the articulation, so speech is not just hypernasality, but it is also a combination of articulation, the language development, and speech. And that's why we have a speech therapist in our unit. It's just an interwoven, this entity where a lot of things have to be taken into consideration. So compensatory changes, can happen sometimes because of vilopharyngeal function alteration, but the articulation improves, and this is what this paper drives home. And they in a paper in this paper, although the sample size again is small. Remember, most of these papers coming from Western world will have small sample size, but they will also have long-term follow-up, and they drive home this point that maxillary advancement did not have any impact on the velopharyngeal competency, and some patients, a small population, deteriorated. So when we try to then dwell upon why these patients have had deterioration in their velopharyngeal competency, there are the hypothesis is all those patients in borderline tend to get worse, but the patients who have good velopharyngeal function remain good. So that is something important. So basically, we have to when most of these papers discuss about what is a predictor of velopharyngeal insufficiency, the baseline of the speech has to be documented, and that's what needs to be done again in your assessment form. Enter the baseline speech, and this way we know whether the speech is deteriorated. And if the patient has good speech, the chances are the speech will not get affected. Stability and relapse, again, a lot of discussion. Distraction gained a lot of popularity in the mid 2000s due to the fact that there were surgeons who said that conventional orthognathic were not stable in cleft patients particularly. And having said that, they started doing distraction early, and even before skeletal completion. So this paper mentioned that by doing distraction osteogenesis early, you do not negate the growth disturbance, and the inherent deficiency still remains. And at least you have to encounter for the growth that will happen in future, and you have to accommodate that in your distraction if you are doing it early. There is a meta-analysis where they said maybe the orthognathic surgery causes speech disturbances, but the distraction does not cause speech disturbances because there's a gradual stretch of the soft palate. Having said that, when the meta-analysis was concluded, they said that there was no difference in velopharyngeal function. And of course, there was no difference between the surgical relapse. So both distraction osteogenesis and conventional osteotomy provide good facial aesthetic improvement, but there is no advantage when you weigh one over the other. Adi Rechmel, who was trying to drive distraction osteogenesis for most of their patients, he did his, in his paper where they mentioned clinical controversies in cleft care, and there he said, oh, if you do conventional osteotomies, there is a relapse of 31%. And I hear that all the time when people speak about procedures, they factor in relapse, and the talk is mainly on relapse. But many authors and authors with good reputation have done large advancements of up to 1 centimeter and have had stable results. So without significant problems. So in fact, David Precious, he did a small audit and study with the surgeons in the UK, and they said that when you compare the osteotomies with conventional osteotomies with distraction osteogenesis, there is no difference, and they were able to achieve stable outcomes with large advancements. So this paper I already mentioned. So now coming to the multi-segment problem. So this is a paper by one of my mentors, Professor Hagee, who's a fan of multi-segment osteotomies. And when I was with him for a year in Melbourne, I realized that he made multi-segment osteotomies look very easy by just understanding the vascularity, and also suggesting that even if you have minor relapses after doing a multi-segment osteotomy, they are very easily correctable orthodontically. And that is where, in cleft patients especially, multi-segment osteotomies really redefine our work. There have been long-term studies, where they've discussed whether the multi-segment osteotomies are not as favorable, skeletally stable as conventional orthognathic. But the conclusion of this paper from the 2014 mentions that the outcome is very similar. So yes, there might be some relapses, but these relapses can be managed orthodontically, and these minor relapses do happen in conventional orthognathic surgery as well. I do notice that there is a speaker who will be talking about SARPE and SAME, which is surgically assisted palatal expansion. I like to call it maxillary expansion. So the procedure acronym for me will be SAME. So SAME is again has a very vital role in cleft patients because most of these patients have severe transverse discrepancy. But one of the other elements that I would like to throw in here with SAME is the fact that it has a delayed flap phenomena, where because of the osteotomy, like in plastic surgery, we have a delayed flap phenomena where you do a procedure and fix it back to that same position. It actually increases the choke vessels. Now this improves the vascularity. So even if the vascularity is compromised in a cleft patient, the end result is improved vascularity, which will probably allow you to do the surgery without causing the vascularity in the subsequent procedure, as a subsequent procedure. The important points are interceptive orthodontics, bone grafting, and a combined plan when possible. Talk to your surgeon, discuss. These patients are not immune to surgery. So I mean, not immune is not the right word. Not are aware of the surgery and what surgery can do. Unlike our regular patients who come to a clinic where driving home a surgical intervention would be difficult, but these patients have had surgery since infancy. So you explain these proposition of meeting a surgeon, discussing having a combined plan, and this would be the right way to go forward. The orthodontic corrections can be based on the segments, greater segment, lesser segment. Think about multi-segment osteotomy. This will help. Large discrepancies, not just orthognathic surgery alone, conventional orthognathic surgery and distraction. Also think about the fact that we could do a staged Leaford procedure. So if the discrepancy is 13, 15 millimeter, and the unit does not have distractors and the patient cannot afford distractors, I think much more cheaper is to just bring the Leaford segment as anterior as possible. Maybe if you are a good surgeon, you bring it to 10 millimeter, 12 millimeter, but you're still short of that 5 millimeter. That 5 millimeter can be addressed as a second procedure when you're doing an advancement with a bijaw. So, the possibilities with osteotomies is immense. You can do stage Leaford 1, you can do segmental osteotomies, you can do an AMD, a distraction, or a bijaw. But that is why each cleft is different. Treat with special interest and together with an orthodontist and a surgeon. It is not always just the maxilla coming forward in a patient with almost class 1 type of a presentation where there is a straight profile or mild convex profile. You have to bring the maxilla and the mandible forward. In a patient like him, where the profile is pleasing, it is not very bad, but there is transverse discrepancy. Just correcting the transverse discrepancy by a SARPE might improve his mild malar hypoplasia, and he might get away with just an expansion. So each patient is different. Try to identify them. Work with a team. There is a lot of possibilities that can be achieved when you work in good collaboration. Thank you so much. It was a pleasure talking to you all. I hope I was audible all throughout.
You're audible, sir. You're very much audible.
Yes. Okay.
So we have two questions here. Can anterior maxillary distraction using hyrax can also be used if there is a poor bone support? Basically, they're asking if
I would
compromised.
So I would be reluctant to do that. Like I mentioned in the presentation, that it does compromise the periodontium during the procedure as well. So if there is mobility of the teeth, poor bone support, just we could modify the device. So you could take anchorage from all the teeth. That has been done in the past. So you can make a splint and cover all the teeth, which are all of them if they are periodontally compromised. So you have a splint-based anterior maxillary distractor device. So yeah, you could modify the device, but yes, it is always a problem and a fiddle when you have periodontally compromised teeth.
Okay, sir. Thank you. The second question is, it's kind of a doubt whether you can use an intraoral distraction, because they feel that it fails in many cases because it's specialized in endocondylar in origin.
No, I don't think that is right, because I have seen a lot of good intraoral distractors, and I mean good, they have to be slightly low profile, good load sharing, bearing. They work well, but the good intraoral distractors are very expensive. Each of them costs 2.5 lakh rupees per side, or 1.5 per side. So that does not work well. Having said that, most distractors are not standalone procedures. You might get away in a very straightforward case by distracting it and just advancing the maxilla forward, but oftentimes then not, you have to do a settling osteotomy, which means you have to do a final correction, and it can be bi-jaw as well. So yes, it is for the resource that we have to spend on intraoral maxillary distractors, it is questionable from our patient population point of view, because a lot of people in the West do internal distractors and then do settling osteotomies at the second stage. But it works. It does not fail if you use the good distractor.
Yes, I think it cleared all the doubts that is related to intraoral distraction. Thank you very much for sharing your knowledge, experience with a lot of literature backup. I think most of the articles probably you are seeing for the first time. So it was a very nice presentation. Thank you, sir.
Good afternoon, one and all. Thank you, Sunil sir, for the introduction. It gives me immense pleasure to introduce our next speaker for the day, Dr. Akshay Shetty, for the lecture on Surgery First Approach. Dr. Akshay Shetty has done his graduation from Government Dental College, Bangalore, and his master's in dental surgery from Bapuji Dental College and Hospital in Orthodontics. He is also a member of Royal College of Surgeons of Edinburgh, Fellow of World Federation of Orthodontics, member of American Association of Cleft Lip and Palate, and American Association of Functional Orthodontics. Apart from these, he has done clinical and research fellowship in advanced craniofacial orthodontics at Chang Kung Memorial Hospital, Taiwan, where he has received special training in nasoalveolar molding, craniofacial orthopedics and orthodontics, surgical orthodontics, implant-assisted orthodontics, and sleep medicines. Apart from so many academic achievements, he has also been awarded the Nod of International Scholarship for Craniofacial Orthodontics in 2006, and also an award in Excellence in Education by Rashtriya Shikshan Samiti Trust in 2006, 2007, and 2008. Welcome to the dais, sir. We look forward to your lecture. Over to you.
Yeah. Thank you, and a very good afternoon to all of you. At the onset, I would like to thank Dr. Silju Matthew, President, Indian Orthodontic Society, and the fellow members of the Indian Orthodontic Society for giving me an opportunity to present. Also, thanks to the Ramaiah team of Ramaiah, my good friend, Dr. Prashant. And it's very heartening to see my fellow panelists, a lot of whom I've worked with, interacted with, and seen some of you grow. So it's great to see Deepesh. Special hello to Dr. Pramod, Dr. Mustafa, and Dr. Ratna Madam. So my topic today is on surgery first, orthognathic approach. My introduction to this approach was way back in 2006 and 2007 when I was on a fellowship program. My mentor, Dr. Eric Liu, and the team of surgeons present there, in particular, Dr. Yurei Chen, who is considered as one of the 5 living legends in plastic surgery, were the key instrumental in me honing my skills in this particular approach. I graduated from Bapuji Dental College under the mentor, the legend, Dr. K. Sadashiv Shetty. When we were postgraduate students, we were schooled in very traditional but very, very high quality orthognathic surgery curriculum. I think almost all our seniors, juniors, and our batch in particular had a lot of variety of orthognathic cases, which we worked on. And it'll be, I have to admit, Dr. Shetty was way ahead of his time. His concept of facial aesthetics, his concept of occlusion, his concept of traditional surgery in totality was, he was really ahead of his time. And this was a key foundation for me. Thereafter, my fellowship stint in 2006 at the Changang Memorial Hospital introduced me to this. To begin with, I was skeptical, and here was a bunch of orthodontists and surgeons who were very shy of this approach back then, but nevertheless, we're doing a lot of cases with this approach. Like they say, as they mentioned, anything new in science has a fair share of criticism. Anything new in science goes through criticism, then there is skepticism, and then there is acceptance, which is what we see today. A lot of schools all over the world and a lot of clinicians and a lot of orthodontists are adopting this approach. So my content of today's surgery first approach, the topic which I've been assigned to, is going to be talk about a brief introduction, a bit of history, and then how I do it and how we do it here in Department of Orthodontics at DAPM, RV Dental College, what we follow, what we teach. And then I'm going to wind up the presentation with a couple of interesting cases. Okay, so the first is to understand what is surgery first approach for the benefit of those of you who have not listened to my presentation before. So this is for you. As the word says, the surgery first approach, orthognathic surgery is performed first, followed by orthodontic treatment. The surgery first approach treats facial aesthetic first and then the occlusion, unlike the conventional approach which treats occlusion first and then facial aesthetics. The surgery first approach is to proceed with orthognathic surgery in the beginning with minimal or no pre-surgical orthodontics, absolutely nothing. And most of the orthodontic treatment is performed post-surgery. Now, when we look at literature, it's interesting to see that Bell and Finn call this a paradigm shift in orthognathic surgery. This was reported in the Journal of Maxillofacial Surgery in 2011. Eric Liu, my boss, said that treatment duration was shorter by a year and a half and called this approach as a surgery first accelerated orthognathic surgery. But if you look at literature, it'll be interesting to see that way back in 1977, it was Epker and Fish who first this approach. And they felt following this surgical procedure should be performed prior to orthodontic treatment. And this would ensure an aesthetically pleasing result and easily accomplished tooth movement. But if you dig in literature even further, you'll find literature which was reported in Plastic Surgery and Reconstructive Journal and some orthodontic journal way back in 1947, that was almost the year of our independence, that they used to form these surgeries without orthodontics. So are we looking something like an old wine in a new bottle? In my interaction with a lot of surgeons across India, I had the privilege of doing a lot of cases, working with Dr. Varghese Mani, who's a legend himself in orthognathic surgery. Sir has mentored a lot of textbooks, and he said that he was very often doing a lot of surgery first procedure quite a few years back, and he would jokingly call it as marriage osteotomies. Now, surgery first approach can be carried out by two different approaches. So this is a very important point to be taken. One is an orthodontic driven. This particular technique was popularized by Dr. Junju Sugawara and a team from Japan, and eventually named it the Senadai surgery first, that is SSF. What we practice, or what I've been trained in, is surgery-driven approach, which is a concept of, which is another form of surgery first approach. This is beautifully given in a book written by Narayan Gandekar, a very dear friend and a former colleague at the Changang, and my former boss, Eric Liu. They've authored a book, which is a beautiful book to understand this particular approach. it is often, we tend to be very verbatim when we say surgery first approach. And if you have a lot of people questioning that, if they see braces, they said, hey, you can't call this surgery first approach. So in our quest to understand, is there a protocol of surgery first approach? This is a very interesting article written by Dr. Daniel Huang, who is a former chairman of the Changang Orthodontic Department, and he did a systemic review article to understand what is the concept behind surgery first approach. So what they did was they did a Medline search way back in, I think it was 2012 or 14, and they selected articles. They found about 18 articles which referring to the word surgery first approach. And they needed to understand what was the protocol these guys had followed, because there was no established given protocol back then. So most articles recommended that orthodontic appliance should be fitted prior to surgery, even when using the surgery first approach. Studies have shown that it can be placed 1 month before, immediately before, or a week before, or 1 or 2 months before, prior to treatment. So there was only one paper which said that you don't put braces at all. You can carry on surgery first approach without orthodontic treatment. So what this clearly states that is there was no one particular approach. Whatever suits the clinician and the orthodontist, or the surgeon and the orthodontist, he could follow. He could either place the brackets 1 month before, just get a fair bit of alignment, or 1 week before, or just no braces at all. Now, surgery first approach uses osteotomy to solve skeletal problems, and a temporary occlusion called a transitional occlusion is set up post-surgery. Now, this is best understood by a concept called one patient, two problem concept. Now, what do we mean by this one patient, two problem concept? Here, the skeletal and dental are two separate components which need to be addressed in one patient. Orthodontics in surgery first approach is a post-operative adjunct treatment to transfigure the temporary occlusion into stable cusp to fossa occlusion. So orthodontics is usually carried out post-surgically. Now, the advantages of surgery first approach are both psychological and biological. One of the biggest drawbacks of traditional, what they say, was worsening of the profile because of decompensation. So as we know, when we decompensate, we remove whatever camouflage nature is provided, and this particular decompensation leads to worsening of one's profile. So one of the bases for surgery first approach was this point, which most of the clinicians harped, saying that decompensation was leading to worsening of the aesthetics, thereby making the patient more mentally upset. Now, psychological advantages were the patient's chief complaint was addressed at the beginning of the treatment. In other words, when he or she walked into the office, they would say that my jaw was prominent or my jaw was deficient. And because of surgery first approach, this particular aspect, the patient's main complaint was addressed right at the beginning. The biological advantages were post-surgical, some degree of relapse is inevitable. So maximum relapse takes place in. So minor surgical inaccuracies and relapse tendency accurately addressed in the orthodontic phase. The biological advantage were total duration of treatment decreased. Why? One was because of role of soft tissue, and the other was a RAP phenomena, also called as regional accelerated phenomena. This was mentioned beautifully by Eric Liu in the Journal of Maxillofacial Surgeon, the year 2011. So when you come on role of soft tissue, if you take a class 3 case, let's say because of a mandible being prominent, when we set it back, it becomes a class 2. Thereby, the resulting improvement in the tone of the upper lip and the tongue increases force on both arches, improving the efficiency of incisor decompensation. And this may be a factor in reducing total treatment time. So this is a diagram which represents that. So to begin with, this is a class through. When we set it back, it becomes a class 2. and encroaching the space on the tongue, and the tongue pressure from the tongue helps in decompensation. The other, as we know, is the regional accelerated phenomena, which leads to faster tooth movement, thereby decreasing the treatment time. This was given by Harold Frost in 1903. They said the bone turnover adjusted to the site of surgical trauma increased. The candidate markers for tooth movement, the alkaline phosphatase and ILCLP, were increased post-surgery, leading to increased osteoclastic activity. So what are the best indications for surgery first approach? The best cases for those of you who are starting fresh is to take well-aligned or mildly crowded anterior teeth, flat to mild curve of speed, normal to mildly procline or retrocline incisor inclination. The surgery first approach is also indicated in which decompensation is needed. Then the question is, how to position these jaw bones properly without compromising the surgical results in such cases. Now, this was made possible by using replacing certain pre-surgical orthodontic treatment with surgical modifications like the rotation of maxillomandibular complex and the segmentization of maxilla. Now, this is best understood by the term 6 degrees of freedom. Now, as we know, the maxilla can be moved in 3 different planes, added to the other components like the roll, pitch, and yaw. So, to see what are the movements that the maxillary 6 degrees of freedom can be ascertained, as shown: translation, the roll, the vertical movement, and the cant correction, and the yaw correction, which is shown over here. And the maxilla can be translated inferiorly and superiorly and from side to side, as shown in the picture. So this 6 degrees of freedom allows us to chain the cant of the occlusal plane, thereby influencing the surgery. Now, the rotation of maxillomandibular complex, when you see in this cross section, is the rotation can be the fulcrum of the rotation can be at different points. It can be at the anterior nasal spine, it can be at the incisal tip, and which, when we alter these occlusal planes, we have a backward rotation of the chin position, or forward rotation of chin position based on the rotation. This best maxillomandibular rotation complex is beautifully given in the textbook by Reneke, where he mentions how maxillomandibular rotation can influence facial aesthetics. So I urge all of you to look through it. Now, in preparing a case, what we follow at the RV Dental College Department of Orthodontics is we follow both conventional methodologies of surgical treatment objectives. So we do paper surgery, followed by model surgery and splint fabrication. A full bonding and banding may or may not be placed before surgery. So like I mentioned, we do conventional paper surgery. I'm not going to go into detail of that. We also follow a 3D planning. I think we were very early in our careers to take the help of Dr. John Neeson, who's also a surgeon, and he had this C-Stars, which was a Chennai-based company way back. I think we did his first case maybe something in 2007 or 10, I can't remember. So this is a basic outline of how a CAD-CAM technology works. They use a 3D MD. I think in India, 3D MD is only available with Dr. Kosla Srinivas Reddy. And then we have intraoral shape scanners, CBCT, and all these things can be integrated. And then a treatment plan can be done, and a wafer can be printed, and then with stereolithography system, and the surgery be done virtually, followed by actually. Now, usually what is required for 3D surgical planning is soft tissue. So in the department, we are actually, working on this. This is one of our former, he's a present PG, he's a former student of Ramaiah. So he's working on a particular software or soft tissue application in 3D. We have a CBCT in the college, and we also have advantage of having the iTero scanner because there's an Invisalign program running in a postgraduate curriculum. And this 3D MD system is what is available. I think right now, as I mentioned, is only available with Dr. Kosla Srinivas Reddy in Hyderabad. So first thing what we do is we look at pre-surgical measurements. My pre-surgical measurements are, just a minute. My pre-surgical measurements are precisely this. I look at for the cant, and then I look at whether mandible and maxillary midlines and the chin is on the facial midline. I look at the smile on rest. I look at the smile incisor position on smile and rest, and put all this into data into the model surgeries. We have the facial midline. I think Dr. Ratna Madam is nicely mentioned as how to go about this. We take a bunch of intraoral photographs, radiographs, and then we do model surgery. I'm not going to go detail of model surgery, but I'm giving you a brief insight of how this is done. So what we do is there's an option to use 2 articulators. This particular case was a bijaw surgery, and we use 2 articulators. One articulator which actually houses the current model with the malocclusion, and the other articulator is housing the Kessling setup of a corrected malocclusion. And this actually gives us an idea of how to place the models, how to place the skeleton rightly, and then we interchain the models and then fabricate the splint. I don't do that. I find it too laborious, but a couple of our postgraduate students do that in the first half of the presentation. First half of when they're starting new, we ask them to do Kessling setup and check in the department. How I do it is a freehand surgery. I place the models to the desired occlusion, what I need to do. Please remember, this is a temporary transitional occlusion. And from here, I need to understand where the interferences are. So I do a freehand surgery model and then plan the surgery accordingly. So this freehand model kind of gives us an idea of what all things to be anticipated post-surgery, what all interferences. I'm going to go in particular in detail of this particular model case, which I featured here a little later in the presentation. What I do is I place brackets. We in the department, we place brackets. We don't bend the wire as it is shown. What we do is we anneal the wire. We take a good 1725 stainless steel wire. We anneal it, and then we thread it into the tubes and the bracket, and we use finger pressure to have it. So it gives us enough rigidity, and most of our surgeons who I've worked with has found this pretty useful. So the idea of annealing is there's no stress distribution, there's no unwanted tooth movement. So when you make the wire dead soft, it's easy to manipulate the wire into the slot, even without any alignment. So if you can actually look at the intricacies of the bends in this particular thing, this is what we do. Once we do this, that is how we do it. But some of them use only Kobayashi hook, mostly in my former college. They use Kobayashi hook without any wires. The other option is to use the surgical brackets. I think this is by Tommy. So it's available in the market by Ortho Systems. And this is also a very good surgical bracket. So what I'm showing you is a pre-surgical setup. So this is a case where we've used surgical brackets in certain sections so that the surgeon, it's easy for the surgeon to stabilize the segments. And let's look at this case. This is prior to surgery. This is how the malocclusion was. And I'm going to show you, once we anneal the wire, we actually manipulating using a condenser to push the wire into the slot. So this is remember, this is a rectangular stainless steel wire, but annealed, which helps us to place the wire into the slot. And if you actually, if you can see the bends of the wire, see how the intricate bends that are being adapted into the wire. So that's how a wire looks. And this particular thing was published in the Surgery First Orthodontic Management as how we set up. So you can actually see how the wires are placed prior to surgery. So please note, in these cases, we did not do decompensation, but we managed to place a 1725 wire annealed without any leveling and aligning. So this is another methodology. We can use a zero tip, zero torque brackets with the hooks. This is what one of my surgeons who I work with, I think Dr. David Toro, he likes this particular approach where he doesn't like hooks to be crimped onto the wire. He prefers the brackets itself. So coming to the cases presentation, I'm going to show you a variety of cases which I had the privilege to work on with a lot of good surgeons. Cases from our department who I worked with in conjunction with our senior colleagues, Dr. Dinesh, Dr. Amarnath, Dr. Dharma, and Dr. Prashant, who's the current HOD. So the first segment is showing you the surgical first approach in class 2 skeletal deformity. As we know, we have different varieties of class 2. You can see I'm going to show you each of these cases as how we went about it, what are the kind of case selection we considered for surgery first approach. The first case of this is a case when I just finished. This is not a fully documented cases, but whatever records I have, I'm going to show you. This was actually, the surgeon was Dr. Krishna Shamrao. He was very, very instrumental me in honing skills of surgery first approach. Maybe he was the first among the surgeons to encourage me to adopt this approach regularly in his practice. So this was his case. And this lady was flying off to Australia. She was getting married and flying off. And they were very keen on seeing this case. This was a class 2 open bite. So you can see this problem list was posterior maxillary excess, a retrusive mandible, a class 2 open bite, and procline upper and lower incisors. So the surgical treatment objectives was something like this. So it was a Leafort 1 osteotomy. It was a segmental osteotomy and a mandible advancement. So this is what was the plan. We executed the plan, and this is what we got. This is how the patient looked at the end of the treatment. If you see good facial aesthetics, good chin prominence. And this is the same patient before and after surgery first. If I rightly remember, this patient's treatment was finished in 10 months. And this is how she ended following treatment. If you see a good facial balance, she had a prominent nose. So it's very important to plan her lower facial height. So this is what we achieved at the end of the treatment. The next patient of ours, this is a very recent case. The surgeon was Dr. David Toro, and both of us sat and we saw this individual. He was a man who had very low self-esteem. He wouldn't make eye contact, but he wanted something done with his face. So when Dr. Toro and me planned for this case was a simple single jaw surgery. This is how we looked: deficient mandible, deficient chin. If you see a decent prominent nose, but his lower part of the face was not complementing. So this was the occlusion. He was treated with braces prior, and he had a root canal treatment. He had a missing 5 on the lower. I think his 3-5 was missing. This was his occlusion prior to treatment. And these are the x-rays of the very individual. Deficient mandible I've shown you, and there's a missing 5. And added to that, there was a collapsed lower arch where his lower laterals were missing, and the entire bite had collapsed, and the bite was deeped. So this was the end of the treatment. This is what we achieved following surgery. We placed a passive wire. We did a surgery. And this is how his profile looked at the end of surgery. His chin prominence, as I mentioned. For a good face, you need a good chin and a good nose. This was his how he looked at the end of the treatment. And this was his occlusion. We had opened up space. And this is kind of occlusion we achieved. We finished this case in good time. I do not have a post-demounted picture because this gentleman, because of the pandemic, has not been reporting. But this is what the last we saw him was. He looked like this. If you see a comparison of before and after, within 6 months, this entire treatment was finished. We took the advantage of wrap, opened up space, managed the bite. The bite was mostly taken out by the surgery, but we had to create space because he had a collapsed lower arch because of missing teeth. And orthodontally, we managed what I've shown. This is another lady who came to our office, and she was very particular that she was flying out and she wanted something done for a treatment, for a face, for her teeth within 5 months. That was a stipulated time. After a lot of deliberation, we looked at her teeth. This is how she looked like. Her teeth were flat, spacing, a bit of gummy smile. And this is the treatment prior to surgery, prior to whatever we planned. And this is what we ended up with. What we did in this case was we put her on braces. What we did, we figured out that this is what she looked like at the end of 5 months. This is the basic orthodontic treatment we could achieve. And this is how we finished the case. If you actually look, there's a significant difference in the lower part of the face. What we did was a wide genioplasty to get the fullness of the lower face. And this actually created a lot of changes in her facial balance and muscle. And she could actually close her lip very easily. And this is the same, this is a profile of the same patient. Within 5 months, she was done, and she left India. This is what we did. This is an X-ray of the same patient. A simple case of genioplasty was done. This is a before and after picture of the same patient, a profile of this patient. So an advancement genioplasty can bring about a lot of changes. It can change the tonicity of the lips. It can change the prominence of the chin. It can change the entire balance. This was a tip which was drilled into our us by my former teacher, Dr. K. Sadashiv Shetty. He always mentioned that for a good face, you need a good chin and a good nose, and that gives you a good profile. So this is a very, very interesting case. This particular class 2, I think she flew from Bihar, and she was looking out for somebody who could fix her face. She wanting to settle down in life. She got in touch with Dr. Taro, and Dr. Taro and we worked on this case quite a bit. And if you actually see, she was treated before. She had a problem in all different planes. She had a vertical problem, an anterior posterior problem. She had a deficient mandible, an excess maxilla vertically and anterior posteriorly. And somebody tried to help her, correct her by extraction, but since it's being a skeletal problem, they could only move so much. They also, a lot of IPR was done with this case. Apparently, that's what the patient told us. Try to push the teeth in more further. So there's a lot of spacing also we encountered between the teeth. So what we planned for this particular case was, this is how her x-rays looked. If you see, she had a vertical descent maxilla, anterior posteriorly big, and also a deficient chin. So what we did was we put on braces, we put on a passive 1725 wire, and this was the surgery. What we did a counterclockwise rotation of the maxillomandibular complex. Please remember, the maxillomandibular complex is both maxilla and mandible. So this is what we did. And if you actually see the X-ray, if you see a Leaford 1 osteotomy to correct the vertical problem as well as the anterior posterior problem, and then we did a BSSO advancement with the genioplasty. And this is how the patient looked immediately, I think post-op, about 2 weeks after surgery. And this was a before and after picture. Once the swelling reduced, if you actually see the change in the patient's face. This was the occlusion prior to surgery and immediate post-surgery. This is what we saw. We saw a tripoding effect of what you commonly encountered in a surgery first, a 3-point contact. This is the same patient before and after. The profile, if you can look at the profile, look at the change in facial balance, a prominent chin, an entire facial aesthetics drastically improved. This was the post-surgical occlusion. We almost finished it. We settled it like this. Unfortunately for me, I couldn't debond the case. However, the patient was generous enough to share a lot of her pictures. This is how the patient looked. And this was she apparently went back, and I'm told that she's married. And this was just prior to whatever spacing to be built up. This is how the patient looked at the end of the treatment. If you see the change in gummy smile, the change in her smile, a low change in her facial aesthetics. This was the occlusion we managed. Apparently, she was just about to get in a build-up. So with a little space, good occlusion. And this is the comparative picture of before and after. This is what surgery first could approach. We took about a year to finish this case. The only thing was this is how she looked. So very satisfying to see this particular individual, a big change in a self-esteem outlook. Well, now, this is a very interesting case. I think this particular case was planned by Dr. Sanjay Ganeshkar and me. This modern day orthodontics involves a lot of youngsters. This was an individual who was about 21 years age. He did not want any braces. So when we examined him, Dr. Sanjay Ganeshkar sir and me, we worked on this case. We felt that this particular individual had a deficient mandible. This was his occlusion. There was hardly any overjet. There was a sufficient overjet, and it was a class 2. Pre-treatment X-rays, you see very square-shaped face. This individual had one criteria. He said, I did not want braces. And when we told him that there was surgery involved, he said, I don't want braces. What I need is aligners. So this is a case I'm going to show you. Class 2 cases treated with aligners, clear aligners. So this is the basic outlook of the case. Now, usually with surgery first protocol with clear aligner technique involves, just a minute. So it involves a case selection is first maybe assessed by setting up a surgical jump at stage 1, evaluate a 3-point occlusal contact. Thereafter, once the jump is established on your software, you use a clin check to move the teeth into and remove all the dental decompensation and position the teeth over the basal bone. Once that is established, then you plan the orthognathic surgery either using a 3D CBCT and a virtual surgical planning software, or we use a conventional model technique. Now you compare these immediate post-surgical occlusion with the surgical surgical models or your software. Then you modify the clin check accordingly, and thereafter you manufacture the aligners. Post that, once the surgery is completed, the aligners are inserted. 3 weeks post-surgery, the patients have to change the aligners every 5 days to take the advantage of the wrap phenomena. So this is the general outline of how we need to do. I'm going to show you a video of what we planned this case. So if you see, the first thing is the surgical jump. Once you establish the surgical jump, then you use the ClinCheck software to correct the occlusion, remove all the decompensation which are interfering, and then you settle the occlusion. So this is another jump. Yeah, you can see the first jump, establish, look at the 3-point contact, and then settle the occlusion, remove interferences. Once you achieve, when you compare this simulation with your CBCT or virtual treatment planning or with the model, then you give for production. This particular case was done by Dr. Kumar, and what we do is, once that is established, we fix these brackets or whatever without wires. So the surgeon wanted just the brackets without wire. We performed the surgery, and post-surgery, this is how his teeth looked. The surgery was performed maybe a month and a half back, the last month of February. This is the final result, what we have prior to the aligner placement. And this is the occlusion following surgery. Once we establish this, now we're going to place the aligners. Currently, the patient is wearing the aligners to settle this teeth into fine occlusion. So it'll be very satisfying for me to watch this case finish. So this is the pre and post treatment. This is what we achieved in a matter of maybe a month. This is what this patient's skeleton looked. He looked dead straight profile, good chin prominence, and he looked really nice. The occlusion, as you know, this doesn't require much work. Posterior settling can be achieved very fast. If you watch the clin check, it actually showed just 16 aligners, 0 to 16 is what required. So if you look at a week for an aligner, it's actually 16 weeks, and most of the treatment is done. So this is the last of the class 2 cases. This was a recently completed. So we used clear aligner technology, Invisalign in this particular case, to finish the case, predict the treatment, predict the occlusion, and this is what we achieved. Now, usually most of the time, I start my presentation in surgery first approach with class 3 cases, but this time around, we have done a sufficient number of class 2 cases for me to share. If I have to critically evaluate my experience of class 2, I think it's very important for we as clinician, as orthodontist and surgeon, our team, to take the patient in confidence. Please remember, in a class 2 case, it's more challenging. It's more challenging compared to a class 3 case. One of the reasons is when you advance a mandible and the patient is biting edge to edge, he finds it very difficult to eat. And some of these patients, if they're not well informed, can start doing things which are unnecessary. We had a lot of issues with some patients who anticipated something, who are not very happy with their profile at the end of the treatment. The reason is, if you remember, in a class 2, the maxillary teeth tend to be a little proclined. So these V-shaped arches will be addressed later on in the treatment. Every single step has to be detailedly explained to the patient what they should expect after surgery. It's very important, and it's your priority as a surgical team to take the patient and prepare them mentally and the surrounding people around. It's very, very important. So I think class 2 cases are always a challenge. So we as clinicians should take the patient into confidence to explain them what is going to happen following surgery, and then eventually things are going to improve. My next part of the segment is about skeletal class 3 cases. So this was, again, in my initial cases, I'm just going to show you what was planned. This was once again Dr. Krishna Shamrao way back in 2007. This is an individual who came to us. These are best cases, as I mentioned. They are mild to moderate crowding and straightforward, not much of orthodontics treatment. Maybe this was my first orthognathic surgery first case on my own. When I came back in India, this was the case which we did. And this is the standard STO. We did a maxillary advancement. And this was how the patient looked post-surgical. And this was the occlusion following surgery. This happened within 3 weeks. This is another individual who also was treated before. If you actually see this case, this is pretty interesting. He was already treated before with orthodontics. This was his occlusion. There was hardly any reverse overjet for me. So if you look at the top part of the picture, this was what the surgery was planned. We pushed the occlusion into almost a class 2, and then used the role of soft tissues and orthodontics to move the teeth part, and this is how we finished. So this is how the patient looked post-surgically. This was before and after. Okay, this is a fully documented cases done at RV, the Department of Orthodontics. So this was an individual who had come to our clinic, and he was not happy with his teeth exposure. And on intraoral examination, we told him that the problem was skeletal. It's got nothing to do with his teeth. And there was hardly any reverse overjet. The upper and lower teeth, the upper teeth were proclined, the lower teeth was retroclined. And this is how his radiographs looked. Usually in a regular scenario, which requires traditional orthodontics, we would have followed an extraction pattern, which would be to decompensate, which would involve upper 4 extraction to correct the incisor inclination and a lower 5 extraction to correct the molar relation. And this treatment would usually take about 18 months. Now, the following treatment objectives in this particular case was to rotate the maxillomandibular complex clockwise, to correct the dentogingival display. The most important was, as one of the speakers had mentioned, the paranasal deformity. So his surgical treatment plan looked like that. We planned a 3 mm posterior impaction, a maxillary advancement, and a mandibular setback. If you remember, I had shown this model at in the beginning of my slide, how I set up my case. This is the very model of this patient. So on a freehand surgery, this was the occlusion we were getting. When we looked in close, we saw the cuspal interference. A palate cusp was hanging following surgery. There was an anterior open bite. So what we did was we put a 1725 stainless steel wire. We engaged it passively. A annealed wire was placed. This is how the patient looked after 7 days of surgery. If you remember, for class 3 cases, we make it class 2. It was a bijaw surgery. Maxillomandibular rotation was done. This is how his profile looked at the end of surgery. If you watch, his chin is slightly behind. He looked almost convex. This was the occlusion after 10 days of surgery. Anterior open bite as we anticipated. Palatal cusp hanging. If you look at the model, if you go back to the refresh your memories and look at the model, this was the anterior open bite. This is a palatal cusp hanging. If you actually see, the model is what we have anticipated. So we as orthodontics, what we did was we preempted this particular issue, and we put the patient on a buccal root torque using a TPA to correct the hanging palatal cusps. We use mild class 2 elastics. Once we achieve that, this is how the patient looked after 30 days of surgery. If you see, his chin prominent is better. This was how we used elastic to settle his occlusion. We inserted the final finishing wires, and this was a change in the patient's frontal smile. If you actually see, his biggest complaint was inadequate dentogingival display. So what we did was, we were also not very happy with this particular dentogingival display. We placed him on extrusion arches using a 1725 TMA. A spring was placed, and this is what we achieved. So if you look at the third and the fourth picture from your left side, the last picture is how his dentogingival display had improved substantially. And this was his occlusion prior to debonding. This was the pre-treatment to begin with. And this was the case just prior to debonding. This is the post-treatment of the same individual. Look at his balance, facial balance, his chin, his smile. And this was the occlusion placed. So if you actually look at his case progress, it was within 6 months we could achieve that kind of a profile. Most of fine tuning of the dentition was done. So treatment duration was within 6 to 8 months. So if you actually recap of what was done, you can actually see this is a morph of the same patient. So following surgery, okay. This is another case which came to our department with a skeletal class 3. And this was his pre-treatment photographs. This once again was a straightforward case requiring minimal orthodontics. This is how the patient looked after 8 days of surgery. If you see, the prominent mandible is actually reduced substantially on the frontal view. If you look at the facial profile, it tend to be a little more class 2. This is how we like to keep it, little overcorrection, anticipating relapse. As we know that teeth move really fast after surgery. I think one of our residents, I think it was Dr. Vijay Yanawar, it was his case. So he kind of tried to close down the space quickly and the teeth dumped. We lost a bit of torque. So what we did was, because of this loss of torque, there was a decrease overjet. decrease overjet, what we used was a high torque TMA wire. We put in some torque. What we didn't anticipate in this case was on a diagnostic. This patient had a TSD, a tooth size discrepancy. So what we did was we reopened the space between all the teeth, and we built up the tooth with a composite, put the braces back, and we settled the occlusion. And this is how the patient looked. His occlusion looked prior to debonding. And this is the patient profile at the end of the treatment. This is a frontal and the profile picture of the same patient. This is a before and after. This is a smile of the same patient. And this is the profile view when you comparatively with pre-treatment. Fantastic facial aesthetics. We got a great outcome in this particular patient. Soft tissue balance, chin prominence, nose prominence, absolutely spot on. So this is how we finished the case at the end of the treatment. And this was the patient's profile. If you actually look at the third picture, you see the profile is a little class 2. Then this is how we finished the case. Okay, this is another case which was also done at RV Department of Orthodontics. This is a patient with blocked out laterals. We ended up extracting the laterals, treating the canines as laterals. Once we did this, we put a 1725 passive wire. This was prior to surgery. This is how the patient looked. We planned maxillary advancement, posterior rotation of the maxilla and mandibular setback. This was the surgical treatment objective. This is what we anticipated should come. We used a 3D CPT splint. I think C-Stars was once again instrumental in giving us this. This was the post-surgical occlusion. This is what we achieved. And this is how the change in patient's profile. Very close to the visual treatment objective, what we anticipated. So the next segment is maybe the last segment of the presentation is facial asymmetry. I'm going to show you some interesting cases of facial asymmetry. This is an individual who was from Bombay. He flew down to Bangalore to get his surgery done. Very enthusiastic young man who was very keen on knowing what he wanted, who was very clear of what he expected. So if you actually see, this patient had a condylar hypoplasia. There was an overgrowth of the lower part of the jaw. So Dr. David Toro and Dr. David Toro had planned a particular case. So this was his occlusion. If you see overgrowth of one side leading to an open bite of that particular side. So this was how his condylar hyperplasia looked. So what we did was we put him on some self-ligation braces, put him on some Gurian locks pre-surgery. Like I mentioned, we use annealed wire. And this is how his x-rays looked. If you see the body of the mandible also overgrown, condylar hyperplasia on the right side. This was a surgical movement. What we planned is intrusion of one side and extrusion of the other, just to get that facial balance. It was a bi-jaw surgery. And this is how the patient looked at the end of surgery. If you see, most of the facial asymmetry corrected, if not all. This was a profile of the same individual. So this patient was so committed to the treatment, he would fly down from Bombay every 6 or 8 weeks, get the job done and go back. So this was his post-surgical occlusion, what we saw. And this was the final finish of the same case, debonded. This is how we finished. This is how we looked. We see facial asymmetry more or less corrected, decent occlusion, very, very happy. Very satisfying to work on these cases. So this was another individual who had come to us, once again, had a class 3 facial asymmetry. He had condylar hyperplasia. He was 18 years of age, flying off to the US for his higher studies. So his right side condyle was overgrown, leading to facial asymmetry. So we did a 3D surgical planning. These were very initial cases which we did. I think C-Stars was really accommodative of helping us plan this case. So we planned his occlusion, And this is what we saw, the bite. Once the 3D planning was done, the splint was fabricated, and we put him on a 1725 passive TMA wire. This is following post-surgery. There was some interference with some bone segments, and we saw an anterior open bite. If you actually see a closer picture, what we did was we used cross elastic to correct this cross bite. So this was one of the problems we anticipated following surgery. And this was the occlusion, what we managed to achieve almost towards the end. And this was the patient profile. You see good facial aesthetics, facial asymmetry corrected. And this was the occlusion we achieved. This was another class 3 asymmetry. This patient, because of pandemic, we couldn't see how the outcome is, and his treatment got delayed, but I'm going to show you what we saw him last with. So this is a class 3 with facial asymmetry once again. So this were his x-rays, and we did his post-surgery. He looked like this. This was a differential osteotomy done. And this is where we saw him last. So this is how the patient looked, and not much of orthodontic work left. One good thing about facial asymmetry for surgery first cases is, if planned well, and if the arches are well aligned, it's very quick for the orthodontist to finish. Most of the work post-surgery is achieved, and very little orthodontic detailing and finishing is required. So when you compare with orthodontic first versus surgery first, you know, they for transverse problem, Wang et al. Compared 39 individuals with class 3 malocclusion who underwent Leaford 1 osteotomy and with bilateral sagittal split osteotomy. After 1 year after surgery, there was no difference between the surgery first or orthodontic first group, what they felt. The final outcomes of transverse dental changes were similar irrespective of pre-operative orthodontic treatment received or not. For vertical problems, they found that class 3 open bite using surgery first approach at 4 weeks points. During this, 33 consecutive patients received Leaford 1 impaction and bilateral sagittal split osteotomy. Out of the 33 patients, 13 received orthodontic first approach and 20 received surgery first approach. So when they compared the duration vertical problems, they felt that the surgery first approach, the duration was shorter. Stability was similar in both groups, both in vertical and horizontal direction. And the only difference between the increased upper mandibular movement following surgery and surgery first approach when compared with orthodontic first approach, they found that the mandibular upward movement was more. So in sagittal problems, the orthodontic first approach and surgery first approach, there's no difference between the two groups. Upon completion of the treatment, the pre-operative orthodontic done on the incisor proclination had returned to its original position. So in lower incisor position, the lengthy pre-operative orthodontic preparation for dental gain compensation is unnecessary in class 3 surgical orthodontics. So this was an interesting article. I think one of our PGs, Dr. Bushra, and former postgraduate, it was Dr. Varghese Mani's treasure of surgery first patient. Apparently, when we vetted all his cases and we wanted to do a study to understand what was the outcome, aesthetic outcome, and airway evaluation of a bijaw surgery.
You want me to?
So Dr. Mani had given us an access for more than 300 cases, and this article was based. We found that the surgery first approach was better, and because of bijaw surgery lead to better aesthetics. So success of to conclude, the success of a surgery first approach was the evaluation of patient, evaluation of the true skeletal discrepancy.
Dr. Akshay, how much more time will require?
The last word I'm going to utter, sir. So skill of the surgeon and skill of the orthodontist, both are very important. It's important to understand what is required, what are the strengths and weaknesses of each. So in conclusion, please weigh and consider before doing a surgery first approach. Thank you.
Thank you, sir, for sharing your knowledge and experience in surgery first approach. We would be taking a question from the audience. And I request you to kindly answer the others in the chat. This is a question asked by Dr. Malik. How do you do STO and how do you prepare surgical template for SFOA? Is it the same as conventional method?
Yeah, I think, initially we do a surgery first approach, understanding that what is a discrepancy. You do a surgical approach to understand where the skeletal points have to be placed. Please remember, your dental might look bad, but if your skeletal points are in almost in line, then you have a fair idea of how. So the standard procedure is the same. The only thing is you will have procline teeth or retrocline teeth which are not been corrected, which otherwise in a traditional approach, all the teeth would have been well aligned on the X-ray. So it's this approach is standard. It's the same thing. We don't. There is no special analysis or special STO to be done. So
Thank
what
you,
we
sir.
do is we use the X-rays, surgical treatment objectives, either using a virtual planning software or paper surgery to understand where your skeleton has to be placed. The occlusion can be looked at with a model or with a virtual software.
Thank you, sir. Now, as a token of our appreciation for your insightful lecture, we would like to present to you an e-certificate for the event.
Thank you.
Thank you, sir. Thank you for gracing the event. I would now like to hand over the next session to the moderator of the next session, Dr. Ramaiah. She is an associate professor in the Faculty of Dental Sciences, Department of Orthodontics. Over to you.
A very good afternoon to everyone present here. It is my pleasure today to introduce the next speaker, Dr. Sheetal Potnis. Dr. Sheetal from Pune is a professor and PG guide in the Department of Orthodontics in Singha Dental College and Hospital, Pune. She has 17 years of UG experience and 9 years of postgraduate training experience and has completed her bachelor's in Bharati Vidyapeeth Dental College and her master's in the Government Dental College, Mumbai University. Madam also has the additional qualifications of postgraduate diploma in healthcare and hospital management from Symbiosis and the postgraduate diploma in clinical research from Symbiosis. She also is a PhD scholar. She is also the co-inventor of the Fab Anchor anchorage system and has received the prestigious P.P. Jacob Award for Innovation in Clinical Orthodontics for the year 2018 at the IOC. I invite ma'am to present today's talk. Over to you.
Thank you so much for the generous introduction. In the beginning, I would like to thank Dr. Silju Matthew, sir, his entire team, the Department of Orthodontics and Department of Oral and Maxillofacial Surgery, Ramaiah University, for organizing such a wonderful event. And thank you for inviting me to share my thoughts. So let's begin. I have a difficult task today of splitting the maxilla. So the topic is surgically assisted rapid palatal expansion. So the narrow maxilla has been recognized for thousands of years and even mentioned by Hippocrates. And to actually correct this narrow maxilla, initially slow expansion techniques were used. But the first published work for transverse maxillary expansion by actually opening the mid-palatal suture was given by Angel in 1860. Now, when we talk about opening sutures, there's a great deal of variability in the initiation, the progress of sutural closure, and the rate of closure. It increases in the third decade. Although conventional RME techniques can be used in younger patients, as the facial sutures become more mature with age, surgically assisted rapid palatal expansion is a useful technique to increase the transverse dimension of the maxilla in skeletally mature individuals. If you see the history right from the theory of distraction osteogenesis, which was given in 1905, there was a huge controversy whether actually it was possible to widen the hard palate at the mid-palatal suture right from 1860 to almost 1930. Then a combined surgical and orthodontic treatment was given for maxillary expansion. And it was actually in 1960 where Andrew Haas reintroduced RME to the orthodontic profession. After that, a lot of extensive work has been done in this field. TIMS has given a very extensive schedule for the activation of RME. Ultramec procedure given almost 15 years back by Dr. Eric Liu. and Marpi technique, which was very much popularized by Kijun Lee. If you see the prevalence, maxillary transverse deficiency is one of the most commonly undiagnosed or ignored problem. It's reported in 21% of children, and Profit and White have given that almost 30% of adults have maxillary transverse discrepancy. Coming to the etiology, right from the thumb sucking habit, obstructive sleep apnea, we have cleft lip and palate, then we have iatrogenic repair of the palate, which causes the maxillary transverse deficiency. A lot of syndromes have been associated with it. So it's basically the etiology is multifactorial. The case selection, how you would actually diagnose a case with maxillary transverse deficiency. For the clinical evaluation, we would like to see the maxillary arch form and the symmetry. The arch form is generally V-shaped and hourglass shaped. The palatal vault we will see is high and arched palate. There might be a unilateral or bilateral crossbite, and most of the times it's associated with severe crowding. Now, if you see the transpalatal width, this transpalatal width is nothing but the distance between the closest points on the maxillary first molars. So this is generally 36 to 39 millimeters, and it can accommodate a dentition if it is this much. If it is lesser than 31 millimeters, then generally crowding is present and you need to expand the maxilla orthopedically. When we see the maxillary posterior teeth, they are generally laterally flared. Okay, this may camouflage a maxillary transverse discrepancy, but because when you see the patient, he'll have a normal posterior occlusion. But if you observe carefully, we will see that there is a constriction of the maxilla and the intermolar width is less than 31 millimeters. Generally here, the curve of Wilson will be accentuated as the lingual cusps of the posterior teeth, they are tipped below the occlusal plane, and this will often lead to balancing interferences during function. Now, if we see class 2 or class 3 cases, one of the major components of class 3 malocclusion, along with the prognathic mandible, is a skeletal retrusion of the maxilla. And this is associated most of the times with a transverse discrepancy also. When you see in class 2 malocclusions, we all know what what McNamara has given as a foot and shoe principle. That's if the transverse width of the maxilla is less, then the mandible will not be allowed to grow anteroposteriorly. Okay, so in a lot of class 2 cases, we will see that there is a maxillary transverse discrepancy also. Now, when in class 2 we articulate models into a class 1 canine relationship, generally a unilateral or a bilateral crossbite will be produced. This is because when you advance the mandible, the broader portion of the mandible is going to come in contact with the narrow maxilla. And generally a 3 to 5 millimeter discrepancy is seen between the maxilla and mandible in these class 2 cases. Coming to the clinical evaluation of extraoral features, first of all, we need to see the mode of breathing, whether it's nasal or oral. A lot of times with maxillary deficiency, transverse deficiency, the pattern of breathing will be oral and there will be altered neuromuscular patterns. This may also be related to sleep apnea. Typically, we will see the paranasal hollowing and the alar bases are narrow. If we evaluate the buccal corridors on smiling, this is called as a negative space given by Van Astal. So they're basically shadows which occur in the corners of the mouth during smiling in patients who have narrow or tapered maxilla, and the facial pattern is mesofacial or brachyfacial. So when we use orthopedic intervention or RME to correct this, it's going to broaden the smile and enhance the appearance. Another thing to check for clinical evaluation is the mandibular shift on closure with the chin deviated towards the side of unilateral crossbite. When there is a mild bilateral maxillary constriction, what happens is when the patient closes, there will be an occlusal interference and the mandible will be shifted to one side. So there's a functional shift of the mandible and towards the side where there will be crossbite. Now, in this case, it's important to remember that do you see a unilateral posterior crossbite? the treatment is bilateral expansion of the maxilla, because there's a mild bilateral maxillary constriction and not a unilateral constriction. Then we have what Jacobs has given as the relative or absolute maxillary transverse deficiency. This becomes very essential in evaluation of sagittal discrepancy, especially in class 3 malocclusion. So in class 3, when you make an attempt to actually articulate the models in a class 1 molar and canine relationship and evaluate the arch coordination, what happens is when you shift the mandible behind, a narrow portion of the mandible is going to come in contact with the maxilla. So in this case, if in this case, there might not be a crossbite, which was evident before because a broader part of the mandible was in contact with the maxilla. So this is called as a relative maxillary transverse discrepancy. And absolute maxillary transverse discrepancy is, it implies a true horizontal width insufficiency of the maxilla. For the measurements of the maxillary transverse deficiency, we have model analysis, of course, transverse indices given by Pond, Lindahart, Korkos, but they're population specific and not very reliable. Nowadays, digital models we can use because the inclination of the posterior teeth can be very properly visualized in this. And so distinction can be made between the dental and the apical base maxillary transverse deficiency that is there. Also from the digital models, it's easy to get occlusograms and you can coordinate the maxillary and the mandibular arches. In radiographic measurements, occlusal radiographs have been used, but because of superimposition of bony structures on the mid-palatal suture and lack of adequate visualization of the posterior part, it's difficult to use them. Posterior anterior cephalograms, we all know Ricketts has given analysis, and based on these landmarks, Betts et al. Have given two methods for quantification. One is the maxillomandibular width differential, and the other is the maxillomandibular transverse differential index. So these can be used for to know whether there is a maxillary transverse deficiency. Also, CBCT is a very good diagnostic aid nowadays, in which because of we avoid superimpositions, the maxillary transverse deficiency can be noted easily. So once we have established that there is a maxillary transverse deficiency, we have options to treat it. The first one is RME. So this can be used in younger patients. Generally below the age of 14 to 15 years, RME is used. Then we have MARPE. This is nothing but mini screw assisted rapid palatal expansion. So in this case, we are basically increasing the skeletal anchorage. Here an analogy can be used where we used to have Godrej cupboards, the steel cupboards. So a young maxilla can be compared to a very new cupboard where it opens easily. You apply pressure on the handles and the cupboard opens. Now, as the maxilla ages, the adult maxilla can be compared to a little older cupboard where it's become rusty. And applying pressure just on the handle to open the cupboard is not going to give you, the doors are jammed and the hinges are also a little rusty. So basically, there is resistance laterally and also from the mid-palatal suture. So now here you have the option of adding more handles, okay, like using skeletal anchorage, and SARPE, which is a surgically assisted rapid palatal expansion, where you're actually going to knock off the hinges and you're going to create space between the doors so that you can hinge them open. Now, if you use RME in skeletally mature patients, you're going to get certain unwanted effects. Okay, since we are using orthopedic forces, but the sutures are mature, so they are going to be dissipated onto the teeth. So we will see lateral tipping of posterior teeth, extrusion. Since there's a lot of force on the posterior teeth, there'll be periodontal breakdown, alveolar bone bending is seen. Buccal root resorption is there, fenestration or dehiscence of the buccal cortex. Also, the palatal tissue necrosis can occur. And ultimately, basically, there's going to be inability to open the mid-palatal suture, lot of pain experienced by the patient, and instability of the expansion because there's only going to be lateral tipping of the posterior teeth, and that's going to relapse. So what effects we want of RME is basically the increased width at molar, increased intercanine width. There's a decreased depth of the palatal vault, increased width of the palate, a little bit of buccal tipping of the posteriors, and improved nasal respiration. So it's this is a very common effect given of RME, is that the nasal passage improves and the nasal respiration will improve after RME. Decreased buccal corridor, since we are going to broaden the arch, so the negative space is going to reduce. So when we come to the indications for SARPE, first of all, it is used to increase the maxillary arch perimeter to correct posterior crossbite. Then it is used to widen the maxillary arch as a preliminary procedure when some other orthognathic surgery is planned, like in a class 2 or class 3 case. It's better to avoid doing the sagittal correction and the vertical correction and transverse correction all in one, all at a single stage. Okay, so here we have two-stage surgery where initially the transverse discrepancy can be handled, and then we go in for the sagittal and the vertical correction. Because if we segment the maxilla into multi-pieces osteotomy, what happens that there is a very good risk of inaccuracy of being able to place the segments properly, instability, and lot risk of other complications occurring. Another indication for SARPE is to provide space for crowded maxillary dentition when extractions are not indicated, to widen maxillary hypoplasia associated with clefts of palate, to reduce wide buccal black corridors when smiling, and to overcome the resistance of sutures when orthopedic maxillary expansion or RME has already been tried, but it has failed. So simple distinction is given based on the amount of expansion which is required and the procedure that needs to be followed. If expansion required is less than 5 millimeters, then you can go in for a camouflage treatment in adults. If it's between 5 to 8 millimeters, there's option of doing one-step SARPE. So surgical assistance is essential in this case. So you can do either a single stage surgery where you can do SARPE and segmental osteotomy can be done at one time, or a two-stage procedure where SARPE is done and then it is followed by the segmental osteotomy to correct the vertical and sagittal discrepancy. If the space requirement is more than 8, means the amount of expansion required is more than 8 millimeters, in this case, SARPE should be done and segmental osteotomy is not recommended because it's going to be unstable. So if we talk about SARPE, what are the greatest resistance areas to maxillary expansion? Okay, initially there were reports saying that the mid-palatal suture was the area of greatest resistance, and later the zygomatic buttress area and the pterygomaxillary junction or the pterygoid plates were called as the critical areas of resistance. So when we consider a surgical treatment of SARPE, there are various sutures that we are going to break. One is we can do the palatal osteotomies. This can be associated with a subtotal effort 1 osteotomy, plus we have to release the lateral resistance. So let's talk about the sutures. Krogman has said that the cranial sutures are unified first, then the facial, and then the sutures which join the cranial and the facial complexes. And Sicho also reports that closure of sutures starts almost at the age of 30 years. Wright has also supported suture, and there's a wide variation which is given even from 17 years to 25 years as the age when the mid-palatal suture will ossify. Prophet also says that RME can be done till up to 25 years of age. So with the CBCT, if we take our axial CBCT, the maturation of the mid-palatal suture can be seen. Various stages are given from A to E. And if the patient is in stage D and E, that means the palatal suture has already matured and it's going to be difficult to do just RME. So you have to go in for a SARPE procedure. And in stage A, B, and C, the mostly in A, the maturation is very less, so it can be done with RME. B and C stages need to be evaluated whether you can go in for a RME or a surgically assisted procedure. a very landmark study was done by Melson, Osturk and Profit. And so they have said that RME is successful only if you do it up to 14 or 15 years of age. After this, it becomes impossible to do RME without surgical assistance. So when we talk about SARPE, we have to release all the resistance to split the maxilla. So the first thing that was given was a palatal osteotomy. So in this, basically, the osteotomy was done from the posterior nasal spine to a point just posterior to the incisive canal. Because of certain disadvantages of going in for a median osteotomy, okay, when you split the palate in the midline, there are chances of having a midline diastema, a midline shift. Sometimes the periodontium of the central incisors is compromised. A lot of times, if the nasal septum can be deviated to one side. So because of all these disadvantages, what was proposed was a paramedian palatal osteotomy. So two surgical splits are done about 2 millimeters from the midline. Again, from the posterior nasal spine, they extended almost just behind the incisive canal. And there the paramedian osteotomies are joined together. So when we do this, we also have to do a what is called as a midline osteotomy between the central incisors. So in this, a vertical incision is made in the alveolar mucosa between the central incisors. And then with the osteotome, it's gently tapped into the interseptal bone between the two maxillary central incisors. We have to place one index finger intraorally, just so that we can feel the edge of the osteotome breaking into the palatal cortical bone. After the palatal osteotomies, it was said that the resistance is not so much from the mid-palatal suture, but from the lateral articulations and from the zygomatic buttress area. So some people authors have done a lot of studies, and they came up with either the zygomatic buttress or the other articulations of the zygomatic bone, which cause resistance to opening of the palate. So Haas and Wirtz, they both said that basically the RME is not parallel when you split the maxilla, and that's because of the lateral resistance that is there. So after mid-palatal osteotomy, it was recommended that a total bilateral maxillary osteotomy from pyriform aperture to the pterygomaxillary fissure was done along with the mid-palatal split. So if we see here, we have resistance from all these structures. Anteriorly, it's the pyriform aperture. Laterally, we have the zygomatic buttress and the articulations of the zygomatic bone. That's the zygomatico-maxillary articulation, zygomatico-temporal articulation, and zygomatico-frontal articulation. And posteriorly, we have the pterygoid plates, which prevent the maxilla from splitting. So it was also recommended that there is no need to do a palatal split, but only removal of the resistance from the zygomatic buttress might be sufficient to remove the resistance to expansion. Along with this, there was osteotomy, which would separate the pterygoid plates. But later on, it was said that to separate the pterygoid plates from the maxilla, a lot of force was required. And due to this force, there were high chances of the pterygoid plates fracturing. And the pterygoid plexus and the other neurovascular structures which are there, there was a great chance of those being damaged. So that should be avoided. Another thing which needs to be done is the release of the nasal septum. So this should be done because when expansion is done, the nasal septum or the columella can deviate to one side if it is not released. TIMS has given certain 3 stages depending on the age of the patient to what type of osteotomy should be performed. In stage 1, which is for the patients aged 25 years or older, and RME was tried in them and it failed. So only a median osteotomy should be performed. In stage 2, median and lateral osteotomies should be performed for patients aged 30 years and older. And median lateral, and anterior maxillary osteotomies is performed for patients who are aged 40 years and older. Now, concerning the surgical technique, one has to look for optimum equilibrium between maximum mobility of the maxilla and a minimally invasive surgery to avoid complications. But the literature does not show any consensus, and general tendency, of course, is towards a minimally invasive surgery. So I'll show you some of the cases that we have done, and the protocol that was followed in these cases was that only bilateral maxillary osteotomies were made, and there was no split in the mid palate. So basically, a soft tissue horizontal incision was made through the mucoperiosteum in the alveolar mucosa. This was right from the base of the zygomatic arch. Forward, it was to a point at the apex of the lateral incisor and then down to the gingiva of the central incisor. There was an exposure of the lateral wall. The osteotomic cut was made from the pyriform aperture through the anterior and lateral walls of the antrum and across a buttress at the base of the zygomatic arch right up to the tuberosity. So the only lateral cuts were made, and this was followed by soft tissue closure. In these cases, the total amount or how the activation was done, I'll tell you. The total amount of activation or the expansion which is required, it should not be done intraoperatively as one stage procedure. Sometime back, Steinhauser, he actually proposed that the maxillary expansion should be done after osteotomy. The entire expansion should be done at one go, and he actually placed a iliac crest graft between the separated halves of the maxilla. This is not recommended to be done. The expansion device should be turned intraoperatively to a maximum of 4 quarter turns, that is 1 millimeter, to confirm that the bony release is sufficient, which will allow the maxillary expansion to be done easily. So what we did was initial 90-degree turn intraoperatively, and then the patient was advised to open the screw with 2 turns of 45 degrees each day, morning and evening. So the first case is a 25-year-old male patient. He's a class 3 with a prognathic mandible, but a very vertical growth pattern. So it's compensating for the concave profile. And maxillary retrusion is also seen with the typical paranasal hollowing. Okay, if you see the intraoral pictures, there is a transverse deficiency of the maxilla. Lot of crowding in the maxillary, and the mandibular arch has tried to compensate as the mandibular incisors have retroclined. And there is a missing lateral incisor on the right side. So these are the pre-treatment X-rays. And of course, the phallometric evaluation has given that there is maxillary retrusion, mandibular prognathism is more, and a vertical growth pattern can be seen. So in this case, the treatment objectives were, first of all, expansion of the maxillary arch, alignment of the teeth, creation of space for the lateral incisor, and to coordinate the upper and the lower arches. In the second phase, surgical correction was planned by a BSSO setback for the mandible and replacement of the lateral incisor, and phase 3, which consisted of the retention. So initially, surgically assisted RME was using bonded Hyrax appliance was done. Then the appliance was retained for 3 to 6 months in the patient's mouth, following which we bonded the patient. Alignment of the lower arch was done, uprighting of incisors so that the upper and the lower arches could be coordinated. Once the appliance for the upper arch was bonded, then the alignment of the upper arch was done. Upper incisor were proclined and space was made for the lateral incisor. Then a bilateral sagittal split osteotomy was done for the mandibular setback. Lastly, occlusion was finished and retainers were placed. So if you see here, with the SARP procedure, the split in the palate and the occlusal radiographs can be seen. The midline diastema, which is a very good indication of expansion which is taking place. This is the amount of expansion in the maxilla that we got, and the post-treatment X-rays. And here, of course, a lateral incisor was replaced, a space was made for the lateral incisor and it was replaced. So with the occlusion in place. The second case was a similar case, class 3, 22 years old male patient. He also had a prognathic mandible and a slight protrusion of the maxilla. So in this case also we followed the same procedure for Sarpe. That is a lateral osteotomy with no mid-palatal osteotomy was done. Just the lateral osteotomy cuts were done. The intraoral RME appliance was placed. And here if we see the retention, the screw is remains in the mouth for 3 to 6 months. We just block the screw and keep it. And later on when the arch is bonded, TPA is generally placed so that the width of the molars can be maintained. The next case is a female patient, again 21 years of age, and she is a class 2 with a convex profile. Here it's what I talked about, a class 2 case where there is a mild maxillary deficiency and generally associated with a unilateral crossbite. So similar, we did a Sarpe procedure with just the lateral osteotomy cuts and achieved expansion of the maxilla, and this can be seen in the occlusal radiographs where a split of the mid-palatal suture is seen. Of course, the suture splits in a V fashion with more opening at the anterior and lesser in the posterior region. So some of the orthodontic considerations that are to be done before we do the procedure. One is the mandibular dentition. It should be decompensated before surgery. So that you can assess the amount of transverse expansion that is necessary to establish arch coordination and to assist in preventing post-expansion relapse with the dental interdigitation. Then the appliance, the tooth-borne appliance that we are going to use for the expansion, it should be placed pre-operatively, and the key should be available during the operating procedure because we are going to intraoperatively actually expand the mandible at least 4 turns, 4 quarter turns. If a bone-borne palatal distractor is going to be used, then the distractor can be placed at the surgery after the maxillary articulations are already transected. And ensure that there's enough space between the roots of the central incisors for a midline split before sending a patient for Sarpe, because if the space is inadequate, root divergence has to be created before the midline split is done. When you talk about the retention and stability, generally a 3 to 6 months of retention period should be followed. The RME appliance should be kept in place for 3 to 6 months and the screw is blocked using acrylic or GIC. And this is followed by TPA when the appliance is bonded with premolar extensions most of the times. Post-treatment, you can use a Hawley's appliance with fixed retention. Now the relapse in these cases is about 5 to 25%. So there's excellent stability with surgically assisted rapid palatal expansion and loss of 1/3 of the transverse dental expansion. It's generally only the dental expansion which relapses. So it's due to the lingual movement of the posterior teeth and the skeletal expansion is most of the time stable. Certain complications which are associated with Sarpe, or the general complications which are associated with surgery are always there. Infection, pain is experienced if there is inadequate release of the maxillary articulations. The palatal tissue irritation due to expansion appliance or ulceration, which is seen in about 5 to 6% of the cases. There might be hemorrhage, maxillary sinus, posterior epistaxis or retrobulbar hemorrhage. Sinusitis or aseptic necrosis can be seen in 1 or 2% of the cases. Now, since we are applying forces on orthopedic forces, sometimes they are dissipated onto the teeth. So periodontal breakdown, blunting of papilla dehiscence, external root resorption, certain pulpal changes can be seen in the teeth. There are always chances of asymmetric expansion, especially if the lateral resistance from one side is not released. And the nasal septum deviation towards one side will be seen. As we said, complications after maxillary palatal expansion with osteotomy between the central incisors. So basically, those will be associated with either the periodontal breakdown of the central incisors associated with the root resorption, or then loss of vitality of the central incisors. Certain rare complications have been given with this procedure. One is the temporary partial paralysis of the oculomotor nerve, some certain cerebrovascular accidents, skull base fractures, or vital compartment syndrome. Now, if you see here in the picture, you will see that there is a fracture of the in the sphenoid sinus, the roof and the floor of the sphenoid sinus. So these forces sometimes which are associated with the expansion, they can be transmitted to other bones in the craniofacial complex, and they have the potential to lead to aberrant fractures. Okay, either at the base of the skull, the orbit, or the pterygopalatine fossa, and these of course can cause neurovascular damage. So minimally invasive surgery can lead to aberrant fractures at base of skull or orbit and damage important structures. So is it a right decision to go in for minimally invasive SAPE procedure? The main considerations have always opposing interests. One side is that a more invasive technique will give you maximum mobility of the maxillary halves for correction over larger distances with less cost but more possible complications. And the other side is less invasive with less complications but more relapse, more periodontal problems, and unexpected fractures. So it's impossible to predict pre-operatively which patients will fail to respond successfully to a minimally invasive procedure. And the surgical dilemma is always there to reconcile optimal therapeutic outcome with the procedure that is minimally invasive. So what we can do is look for signs which will tell you whether expansion is occurring or not. One is the midline diastema. Next is the buccal tipping of the molars, which will be seen if the forces are dissipated onto the teeth and not on the not orthopedic forces. Then you will see certain asymmetric expansion happening if the lateral resistance is not released adequately. And there will be significant pain on turning the expansion screw. So if any of these signs are seen, we need to stop and reconsider the procedure of SAPE that we have followed and act accordingly. So with this, I would like to thank the organizing committee for giving me a chance to share my thoughts on this at this platform.
Thank you, Dr. Sheetal, for this in-depth analysis of the transverse dimension, which is much ignored and often missed. Your initial diagnostic information was very useful, and your entire presentation was very clear and concise, and it has improved our knowledge on this topic tremendously. I hope that you will accept this certificate as a token of our appreciation for all the hard work and excellent presentation that you have given us today. Thank you so much, ma'am. I now would like to invite the moderator of the next session, Dr. Satyashri, who's an assistant professor in our department, to kindly take over for the next session.
Good evening, everyone. Today's last session speaker is Dr. L.B. Peter. I'd like to introduce Dr. L.B. Peter. He's a professor in Department of Orthodontics from Government Dental College, Kottayam. He has completed his BDS in the year 1996 from the College of Dental Surgery, Manipal, and he has completed his MDS in 1998 from the same college, Manipal. And he has also completed his PG Diploma in Clinical Research from Annamalai University in the year of 2011. Apart from this, he has also a LLB graduate from the Mahatma Gandhi University. He completed in 2013. He He has completed his PhD from University of Kerala in 2019. He is a gold medalist in BDS, first rank for MBS entrance, MPARS Manipal, first rank in Kerala PSC examination for government post, first rank in LLB examination. He has 22 years of teaching and clinical experience. He has 25 publications and 15 national presentations. He is a member of Board of Studies, Kerala University of Health Sciences. He was a past member of BOS MG University. He is a member of IEC GDC Kottayam, member of World Federation of Orthodontics, peer reviewer for Journal of World Federation of Orthodontics, Journal of Orofacial Orthopedics, former reviewer of JOS. His clinical interests are mini implants, biomechanics, edgewise appliance, legal issues in clinical practice, psychosocial issues related to malocclusion, class 2 malocclusion. His paper was accepted in the annual AO meet Boston, USA 2021. I would like to invite Dr. L.B. Peter sir to give a talk on legal consideration or legal aspects of surgical orthodontics. It's over to you, sir.
Thank you, Dr. Satyasree. Am I audible?
Yes, sir. Yes.
Let me begin with a lighter note. This is the last presentation and programmed at the fag end of the day. And it is always challenging as well as advantageous to present at the fag end because it is challenging because most participants are tired. Some may even might have left or might be dozing. And it is advantageous because many of the participants have left. And technically, I should not be having a time constraint also because I am the last presenter. I don't have any presenter. I don't make any presenter waiting for me. Now, listening to this, probably Satyasree might get angry. And I would say Silju sir has rightly appointed Dr. Satyasree as the moderator for this section because Satya means truth. And law is nothing but differentiating truth from falsehood. So legal issue in surgical orthodontics can be handled if the doctor is truthful to the patient. So with this light note, let me begin. I take this opportunity to thank the Indian Orthodontic Society, the Association of Oral and Maxillofacial Surgeons of India, the Ramaiah University for giving me this opportunity. And my special thanks to Silju sir for having trust in me and letting me to present in this occasion. Now, right from morning, you have been listening to excellent lectures regarding surgical orthodontics. And I'm sure that your armamentarium is currently packed full with surgical orthodontics, and you are simply looking forward to take up the next case tomorrow to nail it. Now, it would be wise to have an armor or a shield of protection before you start your case. So I hope my presentation will provide this armor or this shield for you. Before I continue further, let me elaborate on two legal concepts. Now, this boy reported to us for surgical orthodontics. I'm not going to much details. He was a severe maxillary deficiency case. We did the joint clinic discussion, developed a treatment plan, and we did the preliminary pre-anesthetic evaluation. We got the approval and we proceeded with decompensation. Now, after the decompensation, he was referred to maxillofacial surgery department, and from there, he was referred for the full course of pre-anesthetic workup to the anesthesia department. And now the report came that there is moderate risk for general anesthesia due to some ectopic heartbeats. Now, listening to this, the patient's parents declined for surgery. And now this boy is walking around with a decompensated class 3 on a skeletal class 3 base. Now, two questions I would like to ask. Whose fault? And does he has a legal remedy? Now, if we sit back and analyze, the orthodontist has properly done the diagnosis and treatment planning. Decompensation was carried out. Case is referred to maxillofacial surgery. The maxillofacial surgeon is willing to do surgery. He approved the treatment plan and referred for anesthetic consent. And the anesthetist did a preliminary approval by taking the pre-anesthetic workup. But during the final workup, there is some issues. Now the question here is, there is no fault could be fixed to anyone, but there is an injury. Now the issue is, how can this be addressed? Now I invite your attention at this point to motor vehicle accidents, where sometimes we may be driving through the road, maintaining or obeying all traffic rules. Suppose if a bike guy negligently comes and hits our car, and if the court case is dragged to the court, we may have to pay sometimes compensation, even if we are at no fault. This is called no fault liability. Now, this concept prevailing in motor vehicles accident cases has recently been imported to consumer protection and of late to medical litigation. And the term they call it as deep pocket theory. That means even without a liability being ascertained, sometimes a doctor or a hospital may have to pay compensation. And the courts generally believe that they let the affordable one or the one in a better position pay. So that was my first concept to introduce. The second concept is surgical orthodontic treatment is a team approach. So consequently to this team approach, by chance, if there is a negligence claim and some compensations are to be paid, who will pay the compensation? Suppose if the anesthesia issue and based on that a complication arises, the orthodontist will tell, no, it is not my fault. Then why should I pay the compensation? Here is my second legal principle, that is joint and several liability. In such cases of team approach, usually the liability is singly, that is parties have to singly as well as jointly liable to pay compensation in an unfortunate event of litigation. And the institution which we are treating the case, for example, since there is surgery, it will be done in a hospital. So the hospital is vicariously liable. What do we mean by vicarious liability? Vicarious simply means like a vicar. It is said that the vicar of a parish is responsible for the sins of the members. If it is so, the institution is liable for the sins or the torts or the wrongdoing or the negligence of its employees. So these were the two concepts I wanted to introduce before I go further. That is the no fault liability and the joint and several liability. Now, this joint and several liability is illustrated in this case, which was recently decided. A 20-year-old BCom boy approached the orthodontist for gummy smile, and it was discussed with the maxillofacial surgeon, and a Leaford 1 impaction and genioplasty was planned. Accordingly, orthodontic treatment was carried out, and some complication arose during the extubation procedure, and the boy developed cardiac arrest, which was initially revived, and within few days he passed away. And the allegations were inexperienced surgeon, inexperienced anesthetist, lack of facility in hospital, etc. However, if we look into the final judgment, we can see that the hospital is vicariously liable. The parties 1 to 3 are jointly and severally liable to pay the compensation of 15 lakhs plus cost and the interest. So these were the two concepts. Now, with these two concepts, let me take an anticipatory bail stating that I am excluding these aspects from this presentation: basic ethical principles, basic aspects of informed consent, law of the land to be followed by a dentist, basic ingredients of negligence, medico-legal cases, and basic aspects of Consumer Protection Act. I also state that most of the issues that I presented are potential problems that may arise and which will enable us to take precautions. So an young orthodontist or an oral surgeon who is listening to this should not deter from treating cases. I will come to this towards the end, how law protects us, medical faculties or medical fraternity, from litigation. Okay, now it is pertinent to have an analysis of the current scenario of doctor-patient relationship. The patients have themselves defined them as consumers. And of course, they have defined the doctors as service providers. And the treatment that we provide has been defined as service under Section 242 of the new Consumer Protection Act 2019. Now, our inability to treat or cure the problem unto the patient satisfaction has been defined as deficiency of service. And it is called by the name negligence, and it is actionable. Now, in this scenario, what should we do? How do we protect ourselves? At the same time, we deliver quality treatment to the patients. Now, here, the word that comes to my mind is when they are seeing us or the patients are seeing as professionals, we should act pakka professionally to them. That means we should show professionalism in our treatment. When I think of professionalism, what that comes to my mind is an MBA graduate or a sales executive explaining his or her product to us, explaining all the details and making us convinced to buy that product. Similarly, previously, doctors used to have the key words like work, work, and work. But now what we should do is talk, work, and more talk. Now, whether this is a welcome change or not is not at all relevant because the change has already happened. So what we should do is we should enable the patients to take an informed decision after explaining all the safety and the risks associated with the proposed treatment plan. And there should not be any information gap in discussing the matter to the patient. So that marks the end of paternalism and thus begins the era of enlightened decision making. Now, it is very important to strike the right balance because we, as well as patients, are living in a consumeristic society, and the patients will be asking for guarantee for the treatment. At the same time, don't forget that we are part of a noble profession and healing care. So striking the right balance is most important. So to recapitulate, what I have talked till now is the paradigm shift that has happened in the approach of the court towards medical litigations, the joint, several, and the vicarious liability, and the changed patient-doctor relationship. Now, henceforth, this discussion, I have planned it in a different way. I have planned it as a question and answer session. I have framed about 20 questions, and I will put forth the points. Whatever points that I have missed out, we will discuss at the end if the time permits. The first question that I put forth is, what provision of the law makes you or a doctor to injure or put an incision in the body of another human being? This is because the law of the land states this way. The Indian Penal Code states that those person who causes hurt or grievous hurt or injury by making an wound on the body of another person by using a sharp instrument or a dangerous weapon has caused, is liable for punishment. Now, when the law states it this way, how will a surgeon put a Leaford 1 incision like this? Now, here comes the chapter 4, general exceptions, which states that it is not an offense if a person causes an injury which is not intended to cause death and done by consent and good faith for the patient's benefit. So the two words we should note here is in good faith for the benefit of the patient and with consent. If you injure a body of another person, it is not an offense. Now, this is the provision that enables medical, surgical, and dental specialties to be practiced in India under law. My second question is, what are the important issues in orthognathic surgery that can lead to litigations in the future? First and foremost, being the surgical complications leading to death, as I mentioned before, disfigurement and paralysis. I am aware of a case where the patient has undergone paraplegia following Leaford 1 osteotomy. The reasons experts say that it is because of the excessive chisel and mallet application for the split, which has led to micro hemorrhage within the brain. The other reasons could be an unsatisfied result, maybe an aesthetic or a functional result, relapse, which could be classified immediate or delayed relapse, neurological problems like numbness and paresthesia, which amounts to be the most important challenge, prolonged treatment time leading to dissatisfaction, and other complications due to the appliance like decalcification, white spot, root resorptions, etc. Temporomandibular disorders and obstructive sleep apnea. And the most important being a mismatch between the expectations and outcome. So this puts forth the third question of mine. What are the triggering factors that leads to a patient seeking legal remedy? Now, it would be mostly because of a comment made by the colleague of the patient or a relative of the patient, or it may be a colleague made by a comment made by another dental professional, an aggressive fee collection protocol, a pre-existing psychiatric condition, or very rarely due to a genuine treatment deficiency. Now, this manuscript looks into the legal issues in orthodontics, and it has stated that 47% of the lawsuits against an orthodontist is because of poor patient-doctor interaction. 40% are initiated as a result of a second orthodontist criticism, and only 6% is due to retaliation of fee collection, and very meager 3% is due to poor treatment results. Now, this may be applicable to surgical orthodontic cases as well. My fourth question is, what are the surgery-related complications that can lead to litigation? Now, remember, when you subject your patient to general anesthesia, always there is a life and death issue. It has been claimed that the mortality rate following anesthetic procedure is 0.5 in 1 lakh procedures among healthy adults. Now, every oral surgeon who listens me at this point of time would definitely vouch me when I say that experienced anesthetist is a key. Smooth induction and smooth recovery during anesthesia is just like a smooth takeoff and landing of a flight. In maxillofacial surgery, we need nasal intubation versus oral intubation as done in many other general surgical procedures. Hence, the experience of an anesthetist is very important. Also, don't forget to do the complete course of pre-anesthetic workup before undertaking decompensation. Now, this is because anesthetist does not know most of the time that we are worsening the condition before conventional orthognathic surgery. And then if it is rejected, the patient has to have a legal remedy. To continue, there can be complications like cardiac arrest, bleeding, which I'm not going to detail. Another issue that would be an excessive swelling. It would be better not to let the patient see their face before the edema completely subsides, because we know that mind is something totally different. The first sight that they see in the mirror or the parents that they see with a severe edematous face will be traumatic to them, and even a very good result may be judged negative based on this. There can be sometimes, as Mustafa sir and all have mentioned, necrosis, especially in cleft cases, and neurological problems, as I mentioned, amounts to 50% of the issues post-operatively that can lead to an unsatisfactory result by the patient. Now, for any of these problems, the solutions are basically the same. You have to explain in advance, informed decision-making, and proper documentation. Now, my next fifth question is, what are the reasons for unsatisfactory results in surgical orthodontic patients? It could be due to a poor planning, a wrong diagnosis and treatment planning. This quite often encounters in a borderline cases, whether to go for a single jaw surgery or bi-jaw surgery. Here, I have no further explanations to tell, which we have been listening right from morning. Another most common perplexing question will be genioplasty, to be done right now or as a second procedure. Now, to be frank, I have not seen any patient who is willingly agreeing for a second episode of general anesthesia for genioplasty. So try to plan genioplasty as far as possible. And in exceptional cases, when you are in a real dilemma, please delay it after explaining to the patient. Now, failure to decompensate could be other reason for unsatisfactory results. The transverse decompensation is always an issue, which Rohan sir has elaborated. And there is no remedy other than hand-articulated study models to evaluate this transverse decompensation. The other reasons could be improper surgery leading to a wrong split, improper fixation, the condylar sag, improper splint, etc. And of course, there is no shortcut to skill and knowledge as envisaged in this kind of symposia. What are the causes of relapse in surgical orthodontic patients? As I mentioned before, immediate relapse could be due to a condylar sag, especially with the mandibular advancement surgeries. A delayed relapse could be due to improper occlusion, which was elaborated in detail, inadequate post-surgical orthodontics, stretching of the pterygomacetrix sling, and always remember the hierarchy of stability, which we are familiar with. So here we know prior to undertaking surgery and surgical orthodontics, what surgery are we going to do? So whenever the range of surgery belongs to a highly unstable surgery, you transfer the information to the patient and let them bear the onus of a relapse that occurs due to it, due to that reason. Also, don't underestimate the possibility of unpredictability of late growth, especially following orthognathic surgery, and ensure that hot spots are eliminated before or looked into proper before undertaking extensive surgeries. The seventh question is, can orthognathic surgery cause TMD or cure TMD? Now, when we look into the highest level of evidence using systematic reviews, we can see that there is little or no harmful effect on the TMJ and oral function with orthognathic surgery, similar to orthodontic treatment. Thus, we can consider that orthognathic surgery as well as orthodontic treatments are TMJ neutral. However, this systematic review specifically answers the question and has stated that orthognathic surgery caused a decrease in TMD symptoms for many patients who had symptoms before. But at the same time, it created symptoms in a smaller group of patients who were asymptomatic before surgery. So here there is an uncertainty. So here again, we can transfer the onus to the patient, especially explain to them if they have a symptoms prior to the start of treatment. Also, don't underestimate idiopathic condylar resorption, which is more prevalent in female patients following orthognathic surgery. The next question is, why there is more possibility of legal issues in orthognathic surgery patients? Now, this may be because of the elective and cosmetic nature of treatment. Here, I would mention one more point. Suppose if your department is very busy with a good number of surgical cases, and if you are posting an orthognathic surgery case, don't post the case towards the end of the day if you have multiple surgeries to be performed, because At the end of the day, probably you may be fatigued. The anesthetist may be fatigued. So at that point of time, doing an elective and a cosmetic surgery is unjustifiable. Also, remember that the outcome following orthognathic surgery is subjective. It varies from patients as well as between patient and their parent also. Also, there is good money involved in orthognathic surgery since there are no insurance coverage for this. The other reasons could be the prolonged post-surgical treatment time. Kiak et al. In their research have found out that in a conventional surgical orthodontic treatment, the post-surgical treatment should not exceed more than 6 to 9 months. The reason being, beyond this period, there is a deterioration in the self-esteem and self-perception of the patient. So they will be unsatisfied if you delay. This is an exemption for surgery first approach. Also, don't underestimate a psychiatric element behind the patients seeking surgical orthodontic treatment. So this has led to the next question. What are the psychiatric issues in surgical orthodontic treatment? It is nothing but the body dysmorphic disorder, which was previously known as the body dysmorphophobia. This is now considered as a spectrum of disorder coupled with anxiety, depression, obsessive compulsive disorders, etc. Now, there are 3 criteria to make a diagnosis. The person may be preoccupied with a defect, maybe imagined defect or a minor defect, but however, his concern for the defect will be excessive. And it causes some social distress, and this condition cannot be better explained by any other medical conditions. Now, 80% of the cases, the patients usually have face as a target organ for this kind of disorder. And we have our own Indian prevalence for body dysmorphic disorder from our own Madam Secretary of our association, as Silju sir respectfully calls her. She has outlined 5.2% prevalence among orthodontic patients, and the international prevalence being 7.5% versus 2.9 in general population. So there is every chance for a dental surgeon and a skin specialist or a cosmetologist to encounter a case of body dysmorphic disorder. Now, to assess this, there are various methods, out of which the most prominent being use of questionnaires. Various kinds of questionnaires are available which you can use to survey this. Our own member, Dr. Rajiv, in their article has mentioned that an orthodontist should evaluate patients psychologically to rule out BDD like other disorders. And this can be simply done by putting forth 4 questions like, are you happy with the appearance? Is there anything that you would like to change about it? Have you sought any help before? And what do you expect to achieve from the treatment? Now, remember, if this patient is having an underlying psychological issue, the best of your skills will not make the patient happy. You should always refer to a psychiatrist, get it evaluated, treated, and then only you touch the patient for orthodontics and surgical orthodontics. My 10th question is model surgery and splint fabrication. Whose responsibility? It was well elaborated about the techniques, so which I'm not going to details. The traditional benefit of model surgery is to plan treatment as well as to fabricate splint. Now, it is primarily the duty of an orthodontist, but I would say in concurrence with the surgeon to fabricate the splint and do the model surgery. And the splint should be traditionally kept for 3 to 4 weeks until a flexible working wire is placed. That simply means that the splint is placed by a surgeon and removed by an orthodontist. Textbooks elaborate the use of splint. However, I have noted certain surgeons do not use splint, and as long as there is no issue arises because of that, there won't be any problem. But in a court of law, suppose if the matter in question is, had there been use of splint, would the result would have been better? In such an issue, the literature supports the use of splint, then we will be in trouble. But provided you have a very good explanation, you can evade the liability. Now, the cumbersome procedure of this 3D fabric, the splint fabrication can be eliminated with 3D planning, and our experience is also not different, and the splints have excellent fit. Now, since I have covered halfway, 10 questions out of the 20 questions, I have a question for you, just to wake up. Here the question is, 21-year-old female was planned for BSSO setback and advancement genioplasty. On the table, a ramus osteotomy and an advancement genioplasty was done. Is there any legal issue, or can there be a legal issue in the future? Can the participants type the answer in the chat box? Just to ensure that you are hearing me. Yes, some participants are typing. I think most of you are sleeping. Yeah, responses are coming. Thank you. Thank you very much. Thank you. Now, here, as long as there is no problem, there is no issues. The result is good, patient is happy, there will be no issues. But here there is a case, Samira Kohli versus Dr. Prabha Manchanda, 2008, which says that a consent given for one procedure cannot be treated as a consent for a different one. So if at all you are expecting an on-the-table change in treatment, make sure you get that in writing after explaining to the patient. Let me proceed. My 11th question is, how accurate is a prediction software? We have discussed this prediction software quite some time before. Now, this is very helpful in motivating patients and treatment planning. And this software is possible because of the predictability of the soft tissue changes following hard tissue movement, and based on which algorithms have been developed. If we look into the highest level of evidence, again through systematic review, we can find that virtual planning is highly accurate and reproducible. Now, we also have our experience here. This patient reported to us for a orthognathic surgery, again due to a severe maxillary deficiency and overclosure of mandible. We have done the 3D planning and developed the projected outcome of the patient, and it was projected to her, and she was very happy with the outcome. And we could produce the predicted outcome also, and it was patient was very happy. Now the question is, how confident are we to get the predicted soft tissue change every time, so that we can confidently tell the patient that this will be the result at the end of treatment? Now look at this patient 2 years down the lane. Now we can see that at the day bond, we maintained the predicted outcome, but 2 years down the lane, you can see the class 3 is slightly creeping in. That means the inherent instability of a maxillary down fracture and advancement is showing its true color. So my request would be, always be cautious while showing the predicted outcome. Tell that we are anticipating an outcome close to this range, but we cannot be taken for granted that this will be the predicted outcome and this will be maintained throughout. So that would be a better say. My 12th question is, how different is the informed consent process in surgical orthodontic patients? Always remember, surgical orthodontic cases or orthodontics as such is an elective cosmetic procedure. So you should always give no treatment as an alternative treatment in your plan. And remember, there is no limit to the information, because just a mouse click away, Google Doctor will answer all the doubts for them and enable them to take part in the decision-making process. That is nothing but autonomy and self-determination. Some authors have suggested a 3-part informed consent process for conventional surgical orthodontic cases because of the 3 steps involved: pre-surgical, surgical, and post-surgical. The UK terminology, they quite frequently use the word enlightened consent. Now here it is done as a long-term process, done over multiple sittings. This is because there could be additional information gleaned or could be change in treatment plan during the process. Hence, you will have to amend the consent process in a surgical orthodontic cases quite frequently. Always remember to include these red marked words in your individualized consent form, that you state in the consent form that the patient, that the treatment is elective, it is cosmetic, the patient is willfully agreeing to the treatment after understanding all the possible consequences and including the remote possibility of death and debilitation. You also can add the other complications that you can think of, like the bleeding, postoperative pain, even relapse in your consent process, but be truthful, explain to them. Now, after explaining to all these things, one question that you will definitely ask me is, will the patient agree to all this after listening to? Now, if the patient declines surgery, you will be leaving a patient, allowing a patient to live his entire life in with a deformity, carrying a deformity in a poor quality of life state. Is that justified as a doctor? That will be definitely the question that comes to your mind. I have an answer for this. My question back is, are you really exaggerating? Or are these events or what you have explained is real? They will definitely agree if they want improvement, because here the improvement is a quality of life versus life expectancy in general surgical procedures. So you have to be truthful to the patient, disclosing everything to them. Of course, they will agree if everybody around takes such consent before treatment. And we have recently witnessed this when we have stopped our operatory due to COVID. And when we restarted, we introduced many consent forms, and all the patients were ready to sign any number of consent forms that we produce before them. So if everyone is taking, they will, but make sure you elaborate and enlighten them appropriately. Now, this will ensure you the peace of mind. You have been truthful to the patient and they have decided for themselves, that is autonomy. Now, this boy's face has given us sleepless nights quite few years back. He had undergone a simple genioplasty. Even the genioplasty was not done. He was simply anesthetized and suddenly he collapsed and he passed away. And we have heard about this kind of unfortunate events happen. So we have not exaggerated anything to the patient. Now, here I would like to enlighten, and I would like to further mention you about the communication skills require a revisit. Now, traditionally, the communication skill experts tell us that we should be looking at the eyes, patting on the shoulders, shaking hands, and being empathetic while communicating to the patient. But I would say this alone will not work. You should apply your mind, understand the patient's frame of mind, concerns, and you should have decide a manner of disclosure, a preferably an incremental manner of disclosure. You should weigh the risk versus benefit. And finally, explain this in terms of daily risk. For example, the possibility of anesthetic risk could be explained to them by stating that the risk is much less than the risk that you took to travel from your house to my operatory during this heavy traffic. So that would make them very clear. And at the same time, you have been truthful to them. Listening, of course, is more important. And even if, remember, they have defined ourselves or themselves as consumers, we are part of noble profession. To elaborate little further among the informed consent process, remember the consent process should be always prior. Now, why do I say this prior? We all know that it is prior because in surgical orthodontic cases, on the table, if you change the treatment plan, it is not prior. You cannot take consent from a patient under general anesthesia. Remember, for an adult, only an adult can give the consent. Now, if you anticipate a change, remember, you explain to the patient about that, mention in the treatment plan, and then you go for a consent from the bystanders. Remember, a broad consent is not acceptable for elaborate treatments like surgical orthodontics. Also, the consent for one procedure I mentioned. Fresh consent for repeat procedure is mandatory, and consent without necessary information is no consent at all. Orthodontic treatment, orthognathic surgery, and anesthesia requires separate consents. This is called the Montgomery case, or the landmark case, which happened in UK, which changed the outlook of the consent process. It shifted the consent process from doctor-centered to patient-centered. Here, a small statured diabetic woman was not warned about the 9 to 10% risk of deformity that can happen to the baby after a normal delivery, and hence a cesarean section was not performed. Finally, the baby suffered disabilities. Here, when the matter came to the court overruled the doctor-friendly Bolam test and held that the patient needs to be informed about the risks of the treatment. That is the material risk. Material risk means any risk that is capable of changing a decision by the patient. Now, Bolam test, as we all know, was the doctor-friendly test, which is otherwise known as ordinary prudent clinician test, which the court used to apply in consumer litigations or medical litigations, where the court will only see that the treatment plan that you adopted is in line with the other clinician's treatment plan, or one body of evidence is supporting your treatment plan, means you have escaped. Whereas when it comes to Bolito test, which happened in 1996, it is a patient-friendly test. Here, you need not only there should be a justification for your treatment plan, which is supported by a body of evidence, you should also justify why you have selected this particular modality for this particular case. That is, a risk analysis has to be done. Now, I would suggest the ultimate test for whether to know whether your informed consent process is right or not is by applying this "if I had known this before" test. In a court of law, when the judge asks that if you had known this before, would you have submitted to this treatment? And if the patient says no, if I had known this, I wouldn't have submitted for this treatment, means your consent process or somewhere you have gone wrong. So my 13th question is, how should be the documentation in surgical orthodontic patients? It is actually not different than any other cases, but it should be little more meticulous. We do take all the routine measures and complete anesthetic evaluation before starting. Software prediction, I mentioned, be careful. You should document the entire event or entire case in a chronological order. And the document process, whether it is correct or not, can be evaluated by giving one of your case file to a third person and ask him to read. And if he can develop the entire process of your treatment like a cinematographic screenplay without any break in continuity, meaning your documentation was complete. The British Orthodontic Society and British Society of Oral and Maxillofacial Surgeons have issued a radiographic guidelines to be obtained as the minimum required records for orthognathic surgery. They say that questionnaires should be administered prior to end of treatment and 2-year follow-up to patients because of the psychological issues related to surgical orthodontic treatment. Baseline radiographs, as we all know, the pre-surgical OPG, lateral ceph, etc. Immediate post-surgical orthopantogram is the responsibility of a surgeon to be taken, and cephalogram at 1 to 3 weeks after surgery is fixed as the responsibility of an orthodontist to be taken, and pre-debond ceph to be taken if the post-surgical orthodontics exceeds beyond 6 months, and lateral cephalogram should be taken 2 years follow-up. This is what they have put forth. These are the 5 criteria for a good charting. The facts that you mention in the chart should be factual. It should be timeliness with progress notes and date. It should be legible without overwriting. If at all you want to correct, you should cancel it with a single line. put your initials and write why are you changing the note. Also use standard abbreviations and it should be complete. Now, issues can arise in orthodontic as well as surgical ortho cases when there is transfer of cases. If the case is moving out from your control or when you are receiving cases from other doctors' case. Here, I am not elaborating further. Ensure that you collect all the records, you draft the informed consent process accordingly and undertake treatment. Also, there can be problem when there is a change in treatment plan, where patient initially accepts plan and later rejects or later accepts an initial camouflage treatment plan. So accordingly, you obtain fresh informed consents and modify your charting process. Storage of record is very important, especially in surgical orthodontic cases. Even though DCI says 3 years, I would say hospitals should preserve it for 10 years minimum. It is very good to have your clinic with a CBCT scanner, 3D scanner, 3D printers, fine. But it should be mandatory to have an area to store your record. This is, you can go digital and have a SLR camera for taking records and a separate dedicated area, maybe your consultation room or separate area where you can arrange all the records, call the patient and patient party, sit together across a desk, discuss the treatment plan and convey the treatment plan. Also make sure that you have a good handwriting while charting. My 14th question is, what are the legal issues in cleft lip and palate? I will go fast here. Now, arch expansion has no association between cleft success, but it can temporarily widen the, temporarily spoil or affect their speech for a while. Remember the inherent instability due to maxillary down fracture. You explain this to the patient, and the velopharyngeal incompetency and speech issues also explained because a velopharyngeal flap cannot be done simultaneously with a maxillary advancement. So explain to them about the second surgery that is needed for speech improvement. Now, in distraction osteogenesis, there is definitely a prolonged hospitalization time if an extraoral distractor is used. Hence, there is chance for more infection. Need for future surgical treatment may be needed, and external scars should be explained. My next question is, what are the legal issues in surgery first, which we have just now discussed in depth? So I'll go very fast. Case selection and all is the key, which has been elaborated. Always warn that post-surgical treatment time will be prolonged. And if there is a similar, the case is of similar footing, based on your experience, you can convince them for a surgery first, but otherwise give them the option. And regarding the immediate profile improvement that we tell to most of the patient that as an indication for surgery first approach, please be very truthful. Now this case, we have done surgery first approach, not typically indicated, but we could, patient wanted that way and we proceeded. And from a class 3, we have developed over 7 to 8 millimeter overjet and a class 2 appearance. So it is not an improvement. It is an improvement from class 3, but definitely it's not a real improvement. Now, if you think this is very mild class 2, look at this case presented by Sugawara et al. From an extreme class 3 to an extreme class 2 at the end of surgery. So there was improvement from one spectrum, but worsening to the other spectrum. So be truthful, explain to them at the start of treatment, and those who are interested in the medical legal aspects of surgery first can look into this article. Also, there is systematic review says that there is a slight higher risk with surgery first approach. Fine, it is based, I mean, your expertise will definitely dictate that. Now I come to my 17th question, that is, what are the do's and don'ts in an event of an unfortunate event of a litigation? Let me start with the don'ts. It is very easy to say, don't be panicked. But remember, panickiness will not take you anywhere. Now, if you are properly chartered, if you have done everything very well, please don't negotiate out of the way. If law is there to protect consumer, remember, law is much better in protecting a doctor. So don't negotiate out of the way. Also, don't get into arguments with the patients, and please warn your staff also not to argue with the patient or the patient party. Don't ever issue any records without proper backup. only you have to issue the original records if there is a court order. Otherwise, you can issue only duplicate records. If there is a court order, you have to issue original records, keeping a backup with you. Let us see the do's in the event of litigation. You sit back, relax in a closed room, collect all the records, and make a note of the events that has happened chronologically, and open a file in your clinic. Discuss with a good lawyer, an expert colleague, genuinely. That means don't hide any facts over here. Then with them, you can sit down and plan a strategy to defend the case. And you have to adhere to this plan till the end, unless your lawyer asks to change. Take the team members and the hospital into confidence. If possible, you can keep your, when you converse with patient or with the other people, you can voice record and retrieve, if possible, the CCTV footings and elaborate and plan a strategy. The usual defenses that are put forth for medical negligence cases are act of God. For example, a delay in orthodontic treatment or surgical orthodontic treatment with consequences at this time of COVID is not because of your fault, because the entire sequence of events that is happening right now is an act of God. So you have no control over it. The second defense usually adopted is contributory negligence. That means the patient were also negligent. A patient were also negligent in doing certain things, which has resulted in this damage. So the quantum of your negligence will definitely go down, or your case will go down. So for example, not following up regularly, even changing doctors is considered as contributory negligence. Or if the patient removing the intermaxillary fixation by themselves are all contributory negligence, which your lawyer will be able to elaborate to you. Now, very rarely, believe me, very rarely, there can be criminal negligence. Now, in Pramanat Kataria versus Union of India, Supreme Court has black and white told pronounced that doctors should not be made to call to the police station for evidence collection. Doctors should not be made to wait in a court veranda. They are part of a noble profession. They should not be tormented, tortured, etc. As well as in Jacob Matthew versus State of Punjab also, 2005, Supreme Court has categorically listed out the criteria and conditions to be fulfilled before arresting a doctor. So it is very rare. Don't be bothered about it. And if at all you are asked to give some evidence in a police station, you attend with a trusted colleague or a lawyer or a respectable person with you. Be polite and present the facts of the case, and don't produce any critical evidence in police station, because the case will not be settled in a police station. It will be settled only in a court of law. And don't leave any records in the police station. Now, suppose if your charting, your flaws or treatment results has some issues, then you discuss with your lawyer, and if the patient is ready to negotiate, you can settle the case. But if at all you are settling the case, remember, a settlement deed is must. And even if you have a settlement deed, remember, the patient can still reopen the case in the future. Now, my next question is how to select a good lawyer. Obviously, our professional bodies like Indian Orthodontic Society, Indian Dental Association, Association of Maxillofacial Surgeons will definitely come to your rescue. Discuss with an expert colleague. Look for the lawyer's efficiency in handling similar kind of cases and his track record before committing to him. And I would suggest avoid close friends or relatives, just merely they are lawyers. But if they are experts in the field, fine, you can go ahead. A good lawyer versus a great lawyer. This is because of the current judgments that we have been witnessing from court. We are forced to say that a good lawyer knows the law and great lawyer knows the judge. And some have even gone beyond to this. And remember, advocacy is a much broader profession, and there are more number of jobless lawyers than dental surgeons. So be very careful when you're handing over a case to a lawyer. Now, if I was a patient's lawyer and a client approaches me for a malpractice case, I will ask the patient, have you consented to the treatment plan the doctor has asked for and given it in writings? My second question will be, did the doctor take adequate records for your treatment and was he documenting it every time? Now, if the answer is yes, I would say the client that you have a poor case, but still I will take up the case as like any lawyer. That is different story. And if they say that no to at least one question, I would say you have a good case. Now, I hope you understand what I mean by this slide. My second last question is how to safeguard yourselves from litigation, which is quite straightforward. Remember, all cases reporting to you for surgical ortho and even for orthodontics are not your cases. Don't consider every case that approach me for an opinion is my case. Case selection is the key. Ensure that the patient is motivated and they are affordable for your treatment plan. Suppose if the patient is not motivated, they are having an underlying body dysmorphic disorder, this would be the best case that you can refer to your neighborhood practitioner willfully and explain to the all aspects of the case and spend quality time with the patient in obtaining informed consent process. Also document meticulously with other records as we routinely take. Signed informed consent is must. Separate consent, which I already mentioned. Avoid unnecessary comments, loose talks, and never underestimate surgical risk. My last question is, do a clinician need to bother too much about litigation when he is surrounded with a plethora of law and law enforcing agency in treating cases in India? Now, these are certain paper cuttings which says that Consumer Court dismiss negligence complaint against dentist. Only 15% of medical negligence cases are genuine. Now, this was a case you might remember which happened in Mumbai, and it was decided in 2012 where the patient underwent orthognathic surgery and unfortunately the worst event has happened. And after thorough evaluation of the records, they found that the case was dismissed. There is no negligence. So if the documentation is poor, happening a death or the worst event or a complication is not merely because of negligence. So you can always the law is there for your protection. Remember, medical negligence is to be established, it cannot be presumed. That means the burden of proof is always lies with the patients, except in case of criminal negligence, which is very rare. And there is high standard of evidence required to treat doctors as being guilty. This was held in Bimal Chatterjee's case. So hence, we don't have to worry too much, provided our documentation and our treatment plan and our execution is in right with the acceptable standard of care. Now, are all complications lead to liability? No, all complications are not due to negligence, but failure to manage a complication can amount to negligence. For example, if you don't have an emergency kit in your clinic when the complication arises, that will definitely amount to negligence. Error of judgment, a mere error of judgment is not negligence. Only very gross negligence or recklessness can attract criminal liability under 304 IPC. Now, 304 is a situation where there is a death due to some unforeseen reason, and it is a cognizable. Cognizable means a police can arrest a person without a warrant, and it is bailable and it is non-compoundable. But this is very rare event. This the Jacob Matthew cases I mentioned in 2005. It could be done only according to CRPC, Criminal Procedure Code, section 174, where the doctor can be arrested or questioned only after a peer group has been consulted and the quantum of negligence is fixed, and then only further proceedings can be undertaken. So don't bother about this aspect at all. Now, very often a specialist can be called for expert testimony in a court of law. Now, whenever you are called for that, remember, you study the facts of the case and do a thorough literature search before opining in the court, because your record will be marked as an evidence under Indian Evidence Act, and you will be questioned in the court of law after administering the oath, and maybe the opposing parties' lawyers can cross-examine you. Now, remember, cross-examination is not very easy. I have faced it once or twice when I was called as an expert witness, where once a lawyer had cross-examined me for 45 minutes, and it is the lawyer's capacity to be, his status among the advocacy will be ranked based on his capacity to perform the art of cross-examination. So it is very difficult when he puts question in a twisted manner to answer. So if at all you being an expert testimony in a court of law, you just tell them that I have not understood this. I am a medical expert. If you use legal terms, I cannot understand. So don't commit anything in a court without properly understanding. Sometimes this happens in a court of law, if at all we are called as an expert testimony. Now, he was a young, energetic, enthusiastic orthopedic surgeon. He did an unusual surgery where many of the surgeons rejected to do surgery by taking all the risks. And unfortunately, the worst event has happened and the patient passed away. Now, he was a victim of media trials. He underwent medical malpractice stress syndrome. And remember, there was no body which supported him, I would say. Maybe body might have supported, but he eventually committed suicide. But remember, if a good body would have extended its support, or a good lawyer would have extended him the support, he would not have committed and he would have been living among us. Remember, law offers protection to all, not only to consumers. It considers our profession still as noble profession and offers definite protection to us. So my take-home points are, I explained about the joint several liability and the no-fault liability. I mentioned about the enlightened consent and the paradigm shifts. Remember, writing saves you. Very less chance for criminal liability. Don't bother too much. Mens rea is the word. That means the criminal intent, as our Mustafa sir mentioned before. Body dysmorphic disorder, don't underestimate. And the best practice would be to under-promise and over-deliver. And apply this test if I had known this before. And I also mentioned about the do's and don'ts and the importance of a good lawyer. Now, of course, prevention is better than cure. One satisfied customer may or may not bring a new one for you. But definitely, one unsatisfied customer will turn down at least 10 or even more customers from your practice. So spend quality time with them, follow the right method of documentation, informed consent, and obviously enhance your skill and do meticulous practice in the right scientific way. There is no course to worry in practicing in India. So I hope your full armamentarium is now equipped with an armor of shield, and you can nail the case from tomorrow onwards. And these are some references which I have looked into, which if you are interested can look into, get insight. And that's all, Your Honor. I rest my case. Thank you very much, and special thanks to Siljujar sir for inviting me, and my surgeon, Dr. Benny Joseph, who did excellent surgeries for me, and my team members in the Department of Orthodontics, and my surgery colleagues from oral and maxillofacial surgery who does excellent surgeries for us. Thank you once again. Thank you very much.
Thank you for such a wonderful presentation, sir. Giving in-depth knowledge about legal considerations. There are few questions from the participants. I will read out.
All right.
So someone asked about, sir, as you mentioned, no limit of information. What all and how much to tell patient about science behind the treatment?
Yes, that is
able to understand the depth of the procedure.
Yes, that is what we need. What I said is the revisiting in the communication skill that we should do. Now, we cannot hide any fact from the patient. At the same time, we should not psych the patient by giving too much of information. So that is a call that you have to make. So you, over the years, probably you will learn that skill, and that is a call that you have to make. But at the same time, you cannot hide any information from the patient. Now, probably you can disseminate the information in an incremental fashion, because at the time when the patient comes to you first time, like, you are a stranger to the patient, our patient may be stranger to you, but over the due course of time, when you build up a rapport between the patient, then you can disseminate more and more informations, and he will definitely take it more. I thank you for this question. So it was a wonderful question.
Sir, one more question. Sir, how do you address the consent aspect while in a visiting orthodontic practice?
Yes, that is again a wonderful, very relevant question. When we consult a clinician, we will be at shortage of time, and we will be doing everything in a compromised manner. I know that, but again, I told you the liability is several and joint. So the consulting, the doctor who appointed you as a consultant also will have responsibility if a complication or a legal issue arises. So it should be his practice also should be having a proper pakka documentation as well as consent process. And definitely you can disseminate some form of core informations to the patient. A consultant surgeon will be there. He will also do his part. And the resident doctor of the clinic also can elaborate the matter to the patient. So you can converse him and ask him to spend some time regarding that. If at all you don't have some specific, so that much time to disseminate to the patient. And however, we cannot evade from the liability if consent is not properly taken. However, you have to develop a scheme in your consultation practice so that you disclose and you take a consent and consent properly. Thank you for this question.
Sir, the last question. The informed consent, should it be handwritten or can it be pre-typed?
Yeah, that is also a very good question. I thank you for this question. Now, there is no need for a handwritten question, but courts have recently decided that a blanket consent form that you make to sign for every patient is not valid enough. So what you have to do is you can disseminate the necessary information in the top part of the consent form as a blanket information, and you put a box, a blank box below. And in that blank box, either if you are generating it in a computer, you can type it, or you can write in the patient's present in that blank box the matters that are specific for this particular case. That way, the consent form will become individualized. Now, when the consent form is individualized itself, remember the court will have a favorable approach to you, because that means you have tried to take an individualized consent process. Remember, lack of consent is not a big issue in litigation. An expert lawyer can easily give a clean chit by arguing various law points regarding that. But if you have a well-written, individualized consent form, always there is beneficial for you when the judge looks at it. Thank you for this question.
Thank you for the clarification, sir. So I would like to present you the certificate of appreciation.
Okay, 1 second. Let me.
Sir, you have to stop sharing, sir.
Yeah, I'm doing that. I'm sorry for that. Thank you so much. Thank you so much for the certificate.
Thank you, Dr. LB, for a wonderful lecture. I think it was an eye-opener, and you have shown us that the law not only protects the consumer, but also the doctors. And I think you were like the last batsman who came and hit the six and won the match.
Thank you, sir.
So
thank you so much.
It was so enlightening. You
Thank
to
you,
woke us up all from a slumber, and you showed us the light. Thank you so much.
Thank you very much, sir. Thank you.
Over to Sharanya.
Thank you, sir. Am I audible, Dr. Satya?
Yes, sir.
Thank you, everyone. Today was indeed an exhaustive and in-depth session on the topic of orthognathic surgeries. It was Leonardo da Vinci who said that learning never exhausted the mind, and today's session certainly proved that point. This was a mammoth task which was led by none other than Dr. Silju Matthew, the Indian Orthodontic Society president, and his team, along with the teamwork by Dr. Ranganath from the Oral and Maxillofacial Surgery. To conclude today's session, I would first like to invite Dr. Sridevi Padmanabhan ma'am, who is the Secretary of the Indian Orthodontic Society, to kindly say a few words. Dr. Sridevi ma'am.
I think Madam is having
I
some.
think ma'am is technical issues. I also next would like to invite our President-elect of the Indian Orthodontic Society, Dr. Shri Krishna Chalasani sir, if he could say a few words to the gathering.
I think there is some technical issue there also.
All right. Could I invite Dr. Ranganath sir to kindly say a few words, the head of the Department of Oral and Maxillofacial Surgery of the Faculty of Dental Sciences, Ramaiah University, a part of our organizing committee. Dr. Ranganath sir.
Dr. Ranganath is here with me and he extends his gratitude to each one of you. And I would finally like to conclude by saying that today is a historic day when two great organizations came together for a synergy of collaboration and sharing of experience and knowledge enrichment. And we have some excellent lectures today reflecting on all the aspects of surgical and orthodontic management of malocclusion. I thank the President and Secretary of AOMSI, the head office of iOS DC for facilitating this process. Special thanks to all the learned speakers. Each lecture was a gem. I thank Dr. Prashant, Dr. Ratna, Dr. Mustafa, Dr. Pramod Subhash, Dr. Dipesh Rao, Dr. Akshay Shetty, Dr. Sheetal Putnis, and Dr. LB Peter. All of them enriched us. They all gave perspective of the topics that was given to them. They brought in so much of clarity, and we are thankful to them. Gratitude to all the moderators from the OMFS as well as the Ortho Department of FTS US. Thank you, Dr. Sharanya, for being a wonderful MC and carrying the function through. Finally, I thank the attendees who came in large numbers and joined us on this wonderful journey of learning surgical orthodontics. Thank you all. Stay safe, stay healthy. God bless. Thank you. Jai Avas, Jai Hind.
Thank you so much, sir. This entire event would not have been possible without the amazing leadership and the dynamic aspects of our iOS president, Dr. Silju sir, who inspires us and he leaves an imprint even in his absence. So thank you so much, sir, for this wonderful, this mammoth effort. I would also like to thank all the speakers and the moderators, and most of all, I thank the audience for their patient listening and for being so actively involved in all the sessions with their question and answers. Thank you, one and all. Stay safe.